And I think there are a lot of survivors also and non-medical community. So I'll try to speak as in a simple non-medical jargon as well as possible. So in the next 25 minutes, I'll be talking on fertility risk and preservation in oncology patients. What are the current guidelines? So when we talk about fertility risk. So what is fertility risk? So just to start, what does fertility means? Fertility means the capacity of a male or a female to have a child, right? So to have a baby. So when we talk about fertility risk, it's different in males and females. Obviously, this risk is calculated when the cancer treatment has finished, when a patient comes to the survivor clinic, and we see what has been the effect of cancer and its treatment on the fertility. So generally in females, we assess by what we called as premature ovarian failure, which means that there is an absence of menstrual cycle in a female. And when we do blood test on them, the level of FSH is more than 40 on 2 consecutive states. In males, we assess it by a sperm analysis, where we kind of look on how much is the sperm count. When the sperm count is less than 5 million in an ejaculate, or there is a complete absence, we'd say that the fertility is affected. So it's a very busy diagram, but I just want to show that how this ovary looks like in a female, right? So this is a kind of a section of the ovary. So if you see, is this pointer working? How do I go back? How do I go back? So if you see the black line, the above is the normal ovary with a lot of follicles. We start from the primordial germ cells, and then they become antral follicles, and that is the mature egg, which is called as the Graafian follicle. Now, under that black line is what cancer does. They can cause damage of the primordial germ cells. They can cause damage to the antral growing follicles. They can cause damage to the Graafian follicle. Above that, they can also cause damage to the vascularity of the ovary and cause inflammation. So various chemotherapy drugs are used in cancer treatment. Some cancer treatments affect vascularity, some affect cells, some affects the cellular content of the ovary. If we look at in males, the testicular sperm production is in the control of brain, which is called as hypothalamus, which in turn gives message to pituitary, which in turn gives message to the testes, which is we called as gonad, which makes sperms, and the male hormone, which is testosterone. Now, what exactly cancer does is it can affect the cancer treatment in the form of radiotherapy or alkylating agents can affect any of them. So if you see on the top, the purple arrows and the orange arrows, the purple is the alkylating agent, which is the chemotherapy, and the orange arrow is the radiation. Now, they both can affect the Leydig cells, which produce testosterone, and the sperm production happens in a stepwise manner. As you can see, the tail end structures are the sperms. So they are generally affected by the alkylating agents. So again, this cancer treatment in the form of radiation and alkylating agents or chemotherapy can affect both kind of cells in the testicular region, and hence the effect on the sperm production. Now, there are various guidelines which kind of tell us how much is the risk with each cancer therapy, which cancer affects sperms and which cancer affects eggs. Now, when I spoke about the risk, the definition of the risk categories is a particular cancer treatment can be low risk to fertility, a medium risk, a high risk, or a very high risk. Now, what it means is low risk means that the general incidence of fertility in a population, those who have not undergone any cancer treatment, is around 10%. So low risk means they are like any baseline. And there are a lot of cancers and cancer treatments which fall in the low risk category. Medium risk, the risk to fertility is 10 to 60%, high risk 60 to 80%, and very high risk more than 80%. And how do we assess this risk? Obviously, when a child is passing through a puberty, we assess how the puberty is progressing on in both males and females. We also do some biochemical markers like FSH, estradiol, and AMH in females. And in males, we do semen test, FSH test, and inhibin B levels. Now, when we find a particular risk because of cancer, there are 4 things we should keep in mind. Exactly, I would say 3 things. Counseling is the most important because we should tell our cancer patients if they're having a treatment, what is their risk to fertility, whether they fall in the low risk category, medium, or high risk. So fertility counseling is very important. And if we want, if they are in the high risk or very high risk, can we preserve their fertility? That's the next question. Like in males, we do preserve semen tests, semen samples. In females, we can preserve egg. And I think my next speaker is going to speak in detail about it, so I'm not going to touch on it. But these are the options we can give to our patients to preserve their fertility. The last thing we should do is, because the survivorship of cancer is increasing, we should discuss about the fertility in the survivor clinics. Ask them the questions, how the puberty has been, whether they are planning to get married in the near future. So we should ask those questions. And I think we were speaking Dr. Poorna Kurkare as well. So I think the late side effects part has to be discussed with regards to fertility as well. Now, just an example I wanted to give, that if it's a case of leukemia, right? If a child or an adult gets a cyclophosphamide, which is 1 gram per meter square, it is low risk. But if the dose is 3 grams, it becomes a medium risk. Again, with the bone marrow transplant, if the cyclophosphamide dose is more than 5 milligrams per meter square, it is in the high risk. So every cancer treatment have their own potential of affecting the fertility. Radiotherapy, again, the dose of radiotherapy, more than 45 gray to the pituitary, like I showed the hypothalamus and the pituitary. If it is more than 45, it is a high risk of affection. So these are, I just wanted to show this table so that we know which are the high risk and the very high risk cancers, like not cancers, but the risk factors. Cyclophosphamide dose, busulfan, ifophosphamide, and their dose, they cause dose-related damage to the eggs and the sperms. What options, like I said, I'm not going to discuss in detail because my next speaker is going to speak on it. Now, speaking about the guidelines, which is obviously one of my topics I have to speak on. There are various guidelines, none from India as such. So we do follow the international ones. So this one is the IGHG, which is International Guideline Harmonization Group, which is a collaboration to optimize care for childhood, adolescent, and young adult cancer survivors. They have guidelines on 3 particular aspects. One is the communication. Like I said in the beginning, the counseling, the communication to our patients is the key, which is the recommendations are that all doctors, all healthcare providers, all support staff should be familiar with effect of fertility by cancer treatment. They should be able to talk to the patients about it. And to provide them, in case need be, online resources, educational resources to their parents, to the caregivers, or to their partners, wives, husbands, about fertility. The healthcare, it should be a sensitive information. Obviously, it's a very busy slide because these are all recommendations. It should be given in a very sensitive way. And also, the points should be discussed on aftercare treatment. When the cancer treatment finishes, when they should go and check the fertility. For us fertility specialists, we generally recommend that 6 months after completion of their last chemotherapy, they should come and speak to us. They should come and check their, just maybe a general questionnaire, or if they are worried, get their semen test done, get their hormone profile done. There's no point in getting before 6 months because of the diagram which I showed in the beginning, because the damage, the follicles which have been damaged at a germ cell level can take 6 months for them to recoup back to the antral follicle and the Graafian follicle stage. So it's important they should come and meet us 6 months after the last treatment. Again, this is on communication, it should be open. The next recommendation by this group, guideline group, is on the female cancer patients. So who should be informed about the potential risk? Like I have discussed, we should formulate in our head as healthcare providers about the risk of particular cancer with regards to fertility. Who should be counseled? Again, there are risk factors like alkylating agents, cyclophosphamide, radiotherapy patients, bone marrow transplant patients, total body radiation patients, because these are very high risk group which can develop infertility later in their life. What methods should be used? Again, I'm not going to go in detail because there can be egg preservation, there can be embryo cryopreservation, there can be ovarian tissue cryopreservation, a lot of options we can give them to preserve their fertility. And what methods for reproductive preservation are appropriate? Again, the proven methods at the stage are oocyte and embryo cryopreservation and ovarian tissue cryopreservation in females, and in males, it's a sperm cryopreservation. For male group, male cancer group, again, who should be informed? The same, all patients should have their risk assessment. Who should be counseled? It's the same. All high-risk groups and very high-risk groups should be counseled. And again, for them, the preservation techniques can be sperm sample given by masturbation or by penile vibration, or taking testicular tissue, which is obviously not proven therapy for preserving fertility at this stage. And the last thing from this group is the premature ovarian insufficiency. Like I discussed, premature ovarian insufficiency is a condition where a female doesn't get her menstrual cycles regularly, maybe at a month of 3 months, 6 months. And when we do their biochemical markers, their FSH is more than 40 or AMH is less than 1. So the counseling should be done or based on that. And again, there are high risk factors like alkylating agents, cyclophosphamide, which can be more causative for this kind of condition. So when should pre and peripubertal survivors be referred? So like I said, now we come to the survivorship clinic where the child has finished, or an adult, an adolescent has finished the treatment, but they are more than 13 years of age and there has been no sign of puberty, or a female who is 16 years of age and has not started her menstrual cycle, and there is no progression of puberty. Puberty undergoes through a series of changes. In like females, there is a breast development, there is a hair growth, and then the menstrual cycle start. In males also the same, there's a testicular volume enlargement and the change of the voice. So if it doesn't happen, that should put an alarming sign and for further investigations. When should post-pubertal survivors be referred? Again, it's the same thing, what I have just discussed. What should be done when abnormalities are identified? Now, that's a good question, that in the survivorship, if we find something abnormal, like there is one aspect of preservation before any cancer patient starts the treatment. And there is one aspect which is picked up in their survivorship clinic. So if we come to know that in the survivorship clinic, their fertility has been affected, what to do? Are there any options available at that stage? It depends on the type of damage. Yes, there is a concept of using donor oocytes. We can use surrogacy for such conditions, or donor sperms for such conditions if they have exhausted with their own sperm and eggs. So yes, there are options for which I would say thorough counseling has to be done. The next is ASCO guidelines. Essentially, these all guidelines stress on the same thing, on 3 important aspects: counseling, preservation, and surveillance. So I think all these guidelines have stressed on the same thing, and it's a more repetitive. ASCO is the American guideline, which has come up with the same thing. So just kind of a little summary to say that, if a female patients present with cancer, we should define the risk as low, medium, high. In low group patients, the counseling is sufficient. We don't need to worry because their underlying fertility affection is same as anybody, around without cancer treatment. But in the medium group, they should be discussed about preserving their fertility. In that group, in every group, in fact, we should know whether they are prepubertal or postpubertal. And we should offer our treatment strategies of preserving their fertility accordingly. In the male, again, it's the same thing, whether they are low risk, medium risk, or high risk. And then we assess them whether they are prepubertal or postpubertal. and counsel them. So just to conclude, there are a few slides on the conclusion. The take-home messages is communication and counseling related to fertility is key for all patients. Risk assessment of each cancer is important for appropriate advice. Semen analysis when we are counseling our male cancer patients. Semen analysis or semen freezing is the gold standard for evaluation, for preserving the fertility in males and also for evaluation of spermatogenesis. Measurement of testicular volume and of certain hormones like FSH and inhibin B can be done where there is a concern about the fertility affection in the survivor patients. Survivor for impaired spermatogenesis should be performed only at the request of the survivor. Like I said, we should talk about to each our survivors in the clinic, or informed decision when paternity is desired in the foreseeable future. Or jab wo shaadi karna chahte and they want to know more about it, we send them for further testing. And if on testing, the reports come as sperm count to be less than 5 million or there is no sperms, then they should be referred to the reproductive or fertility specialist for further management. In females, FSH and estradiol blood test are used to evaluate the premature ovarian insufficiency, especially in the prepubertal survivors and those who are less than 20 years of age. AMH is a very good tool for assessing overall fertility, but maybe not very best when we are trying to kind of screen them post-cancer treatment, because it can have a variation. But if a girl has achieved the age of 20 and post, then AMH is a good indicator for assessing the fertility. If there are no money constraints, then all three, FSH, estradiol, and AMH should be used for seeing the fertility in female patients. For childhood cancer patients, if there is no sign of puberty in a child by 13 years of age, or there is no start of menstrual cycle by 16 years, then they should be referred to pediatric endocrinologist or pediatric gynecologist. Referral to gynecologist or specialist should be done if the AMH or the FSH levels are on a higher stage. And thank you so much for patient hearing.
Thank you so much, Dr. Puneet Rana Arora. And our next speaker is, Our next speaker is Dr. Colonel G. Dhandoria. He is Consultant Senior Advisor in Gynec Oncology at Command Hospital, Eastern Command, Kolkata. I welcome him.
Thank you, organizers, for the invitation, Karan Chitulkar. This is my first visit to this city and to this meeting. Really heartening to see the various topics being discussed, and especially this particular age group. And extremely delighted to see the survivors and their talks. It's so uplifting and so encouraging. These are my affiliations. I am practicing as a gynae oncologist and obstetrician in the city of Kolkata, the city of joy. I am also affiliated with few international organizations. मैं इस मौके का फायदा उठाना चाहता हूं जो सर्वाइवर ग्रुप्स हैं। मैं एक इंटरनेशनल गायनी कैंसर सर्वाइवर नेटवर्क का हिस्सा हूं। अगर आप हमारे साथ जुड़ना चाहते हैं, we will be more than happy to support you. I have no conflicts of interest for this talk. Fertility preservation. A casual PubMed search showed that 1946 also there was a publication. So this is this old that this topic was identified, recognized. However, it's only for last 2 decades or so that fertility preservation has been discussed regularly and is being identified as a separate, may not be a specialty, but certainly a group where some concerted efforts are required. Why are we talking about oncofertility or fertility preservation? Because almost 80% of these adolescents and young adults will achieve a long-term cure. And I mean, that's a great thing to be there, so that ultimately, when they reach the reproductive age group and when they are in that particular frame of life, they would want the fertility to be there. So we need to address these issues. Speakers earlier in the morning mentioned that the awareness about fertility preservation is rather poor, even among various oncologists. A Canadian survey had shown that only 9% of patients had received fertility preservation, which is rather poor. So we need to discuss more about this particular subject so that the awareness comes and it is incorporated in our practice. So I would say that it is need of the hour. This is a beautiful diagram in one of the recent guidelines. This was in ESMO, I guess. No, in the European Society of Human Reproduction. So if you see, this diagram beautifully depicts the team approach. Starting from the leftmost, the green part of the semicircle, where the clinical care, all the medical pediatric oncologists are first time seeing the patient. So that is a time that we need to address fertility, even before you are contemplating your management plan, because that is a time that your management has to incorporate possible fertility issues. Then a huge role of counseling, which my previous speaker has also mentioned. Counseling is a huge part of this particular problem. Counseling at various levels. A young girl or a boy may not be aware, may not understand fertility. Even the parents may not really identify fertility as any issue at that point of time. So it's our job, it's our responsibility to inform that maybe not today, but after some time, fertility would be an issue, could be an issue, especially with the malignancy which has a long-term survival. So comprehensive counseling needs to be there. Psychological support also is required as through the journey of a cancer patient. And lastly, when the patient has been so-called disease-free for some time, then comes the post-treatment follow-up and post-treatment options about when the patient can plan pregnancy. So as already mentioned, counseling has to be the first step. It should be discussed and introduced as soon as the diagnosis is made and the management plan is being formulated. The counseling has to be individualized. It cannot be a group counseling like a lot of cases we probably do. So it depends on that particular individual at what stage of life, at what stage of disease the individual is at. And accordingly, counseling should be done. The counseling would be different if the individual is married, because then it will be a couple counseling. What are the various factors? This will be a slight repetition of the previous talk. I'll run through it. Certain factors which would increase the possibility of lower fertility or infertility would be an older age at diagnosis. If pre-treatment AMH levels have been done, if they are low, then the possibility that fertility will resume is less. And of course, what is the anti-cancer treatment that the individual is being exposed to? And as the treatment goes on, what is the risk of gonadotoxicity at the end of the treatment? There could be other factors which may be contributing, but the evidence is inconclusive as of now. So smoking, the body mass index, BRCA mutations, etc. There's very limited information about the newer targeted agents, the various immunotherapy that was discussed in the morning. There is no real data available. What is their long-term outcomes on fertility? This slide also has been, a similar slide has been flashed several times since morning. Depending on the risk of possible gonadotoxicity, various drugs have been divided into different risk categories. So I'll skip this for sake of time. Just a mention about radiotherapy. Whole body radiation or total body radiation is known to cause almost complete infertility. However, if it is used for certain disorders like leukemias or lymphomas, there are other forms of radiotherapy, especially to the pelvis or abdomen, which have variable effects depending on the malignancy. Hematopoietic stem cell transplantation has almost a 90% premature ovarian insufficiency incidence. So we need to be aware of these different treatment modalities, and we need to inform the patient that these are the possible likelihoods. Coming to the different fertility preservation options, what all can be done, what all can be offered. So from an oocyte cryopreservation or an embryo cryopreservation, which is the standard of care or the most research or the highest level of evidence that we have, to maybe oocyte, maybe ovarian cryopreservation, then experimental techniques like in vitro maturation, ovarian transposition, etc. When we have decided that we need to go for oocyte preservation, the oocytes may not be available at that point of time, so the ovaries need to be stimulated to produce oocytes. As far as the recommendations are concerned, GnRH antagonist protocols are recommended. Earlier, there used to be a concern that in case the treatment has to be initiated early, then how would you wait for the ovarian stimulation to happen? Because one has to wait for at least 2 weeks period for ovarian stimulation and oocytes to form. But nowadays, random start protocol are in place and they can be resorted to. In case there's a estrogen sensitive disease like breast carcinoma, then letrozole is recommended. Oocyte cryopreservation is the first choice as far as fertility preservation in girls or women is concerned. So this should be attempted as and when it is applicable. One can preserve the entire lot as oocytes only, or in case there is a partner available, then one lot can be only oocytes and one lot could be embryos. Because embryo cryopreservation is part of routine ART practice. So this is not something new. So there is just one possible issue about embryo cryopreservation is about losing the reproductive autonomy and ownership. In case there is a marital disharmony, or if there is a demise of the patient, then who owns those embryos? The Indian laws are not very clear about it, like most of the country's laws, and this could be a possible issue. So one should be aware that this may be a future problem. Ovarian tissue cryopreservation is also an option. However, there are certain eligibility or ineligibility criteria. Patients who are undergoing only moderate to high risk gonadotoxic treatment should be offered this. And of course, if there is no partner, or if it's a younger patient, then maybe oocytes are not available. There are certain ineligibility criteria. If the AMH levels are less than 0.5, or the antral follicle count is less than 5. This depicts a poor ovarian reserve, and possibly the outcomes are not going to be good. Age over 36 years is a relative ineligibility criteria. Ovarian tissue transplantation, laparoscopy is the preferred approach. There are several places where the ovarian tissue could be transplanted. It is not recommended in case the ovarian tissue itself is likely to be involved. So in ovarian malignancies and maybe in higher grade of endometrial malignancies, one would not recommend the ovarian tissue transplantation. Pregnancy is possible after the ovarian tissue has been re-implanted. Studies have found that there are no increased risk of congenital malformations. Long-term follow-up, however, is still recommended. And this can be done even in BRCA positive patients. In vitro maturation, it's an experimental technique, not very well established. Studies are ongoing, and this is to be done only as part of a clinical trial or as a well-conducted scientific experiment. It would only be done when ovarian stimulation cannot be done. There is no time for that. GnRH agonist, as far as gonadal protection is concerned, this is most commonly used in breast carcinoma patients, as was brought out by Dr. Bajpayee's talk. However, this is not a fertility preservation technique. This is only an ovarian function protection technique. The fertility restoration after GnRH agonist is rather poor, and one can only use GnRH agonist for a very short duration of time because it causes menopausal-like state. And this was also brought out by Dr. Bajpayee in a talk that this is reported as a significant symptom and a poor quality of life indicator. Ovarian transposition or oophoropexy, this is something that I have done. In case of younger patients of cervical cancers, even in certain early stage endometrial cancer patients, we can transpose the ovaries out of the pelvis and protect the ovaries from the harmful effects of radiation. Although it's not a foolproof technique because there is a concept of scatter radiation. And also when you bring the ovary back into the pelvis, it wouldn't function as if it would function in its natural position. One can do it laparoscopically or open as the skills are present. If we were to compare different procedures, this table is a very easy to understand table. So the established methods are only two, that is embryo or the oocyte cryopreservation. You can obviously use it only in a post-pubertal girl. The live birth rates are encouraging as far as embryo cryopreservation is concerned, but not so much with oocyte cryopreservation. Experimental methods, as I've already mentioned, are ovarian tissue cryopreservation and the transplantation, and the oocyte in vitro maturation. The debatable methods are GnRH analogs, oophoropexy, and gonadal shielding. In some cases of radiotherapy, gonadal shielding is done, but these are relatively poor fertility preservation methodologies. Coming to the fertility restoration part, once the treatment has been completed, we have gone past the fertility preservation techniques. Now the patient or the couple desires fertility. So what to do now or when to do it? So firstly, an assessment for fitness for pregnancy needs to be performed. This depends on the disease, that depends on the treatment that has been received. If the patient has had a pelvic radiotherapy, the uterus itself gets a certain amount of damage. There is increased risk of abortions, increased risk of fetal growth restriction, preterm labor, possibly because of the reduced vascularity of the uterus. So one has to assess what are the possible long-term side effects of the anti-cancer treatment that the patient has received. Certain chemotherapeutic agents can induce diabetes or hypertension. So one has to assess the individual, what is the risk of pregnancy. This would not be a normal pregnancy. So this sort of a pregnancy has to be dealt in a high-risk pregnancy unit, possibly with a maternal fetal medicine specialist. Though there is no defined acceptable, internationally acceptable cutoff as to how long or how less a patient needs to wait before trying to conceive. But 1 year period from the last treatment is generally accepted as the period. Of course, patient has to undergo a full preconceptional counseling because possibly the patient the first question that they ask is what are my chances of recurrence of this malignancy during my pregnancy, because pregnancy is supposed to be an immunocompromised or relatively immunosuppressed state. So we need to discuss all those options. Of course, it depends on the malignancy itself. So all in all, it has to be in a specialized unit, and this sort of a pregnancy cannot be dealt in a regular antenatal clinic. There are certain other interventions which are why I have written uncommon is because the practical scenarios where we are able to do all this is rather uncommon. So there is a conservative management or a non-surgical management of endometrial cancer. It has to be performed in a very select subset of patients. A young patient who is strongly desirous of future fertility has to be grade 1 or grade 2, but stage 1A endometrial cancer. High dose progesterones and levonorgestrel intrauterine device are recommended as the possible conservative non-surgical treatment options for endometrial cancer. However, this requires a lot of counseling, a very close follow-up, and obviously the risk of recurrence of the malignancy. Trachelectomy, I am yet to see a trachelectomy in India. I've seen a lot in outside countries and in international conferences. We don't get operable CS cervix patients, so how will we get a patient who can undergo trachelectomy? Trachelectomy is to be performed in 1A. We don't diagnose patients of CS cervix 1A. We don't have, unfortunately, the diagnostic abilities or the screening abilities, which is a huge problem, and that's why we are the leading country with cervical cancer. Anyway, I'm digressing from the topic. But trachelectomy is a surgical procedure, which is a fertility preserving or a uterine preserving modality that is available if there is a patient who can benefit from trachelectomy. There is an experimental surgery which has been done a few times by a Brazilian colleague, Retan Ribeiro, who transpositions the uterus out of the pelvis. So the uterus is taken above up to the level of the umbilicus. The cervix is sutured with the umbilicus. The patient menstruates through the umbilicus. I have seen this surgery, the surgical video. It's an experimental technique reserved, or rather being offered to patients of rectal malignancies who would require not just surgery, but radiotherapy. He has even achieved pregnancies in a few of these patients. So though his case series has only double-digit numbers as of now, less than 20, but he's doing it, and certain other people, aspiring surgeons, are adopting this particular technique. So just for the information of the audience that this is also happening. People are coming up with some new ideas. I haven't touched much about males because there are only two options for boys or men or males. That is, one is sperm cryopreservation, which is the preferred modality. If possible, sperm should be cryopreserved. And second is the testicular cryopreservation, which is still experimental, should be performed as part of clinical trials. Hormonal gonadoprotection is not recommended as part of fertility preservation. Maybe done as part of testicular function protection, but not for fertility. And of course, the patient should be informed that there is a possibility that the sperms could be genetically damaged once the patient is undergoing chemotherapy. So this would also be part of the counseling. I think this slide was shown by the previous speaker. There are a lot of fancy future interventions which are being attempted. So they're all fancy names. I guess I'll just skip them. I'll be happy to take any questions. And my city is undergoing this huge festival, which will culminate next month. So you're all welcome to visit this vibrant festival. they call it Pujo and not Puja. So you're all welcome to visit my city. Thank you.
Can I ask 2 or 3 questions?
Yeah.
Yeah. So I think the most important thing is for a male, it's not because it's a well established the sperm, and this relatively quite cheap also. So the first question will be how much costly is the procedure for a that is one question. And are there any recurring costs because I deal with more of a testicular, so I know that the patient has to pay for sperm the bank, they have to pay 5,000 or some amount. So is there any recurring cost like a sperm? And the second question is that what are the centers where it can be done? So like chemotherapy is being now the tier 2, tier 3 city. So are there enough expert available to perform this procedure? And the other thing is that the data for the GnRH with the breast cancer can be extrapolated, I deal with nasopharynx also. So sometime can we extrapolate this data for the nasopharynx female patient also before giving starting the chemotherapy, extrapolating the breast data in preserving. And I think the best solution for this, which I think sir is also there, some sort of a booklet for a fertility preservation regarding male and female. So whenever we see a patient in our OPD, because in our OPD like Tata is too busy, so we don't have time to discuss. So we can have some booklets, though the aspects of the fertility aspect has been explained to the patient and their caregivers, the parents. So some sort of quick that these are the center, these are the procedure. So if you want to explain, it will take too much time. But if you can have a booklet regarding so that will be really helpful to the survivors.
I'll try to answer all if I remember all the questions. Please remind me if I forget. So I work in armed forces organization where there are no financial transactions. So, but my predecessor can definitely answer the cost factor. But from my common knowledge, from hearsay, yes, continuation of a cryopreservation facility would definitely require cost. And I was mentioning about the legal loopholes. So one of them is how long can you preserve the gametes? So most of the countries say 5 or 10 years, but there is a call that they should be preserved as long as the
We have a
patient
new
or a
ART
couple.
law now. So we have a new ART law which was passed in March 2022, very recently signed by President. So the oncofertility cryopreservation is now for 10 years.
Yeah.
So, but after 10 years, they have to come back to us, renew their consent. They can still preserve for longer duration, especially, with children and young adults. They can still, but they have to come back and sign that consent form again. Yes, for further 10 years. Yeah, so see, embryo, there's a difference between the cryopreservation success of an egg, a sperm, and an embryo. Now, embryo is very sturdy. There have been a lot of reports about embryo cryopreservation giving pregnancies even after 10 years, 20, 25 years. The data on sperm and egg is very, very less. Still, sperm still has a data after 10 years, but for egg, it's very less data because they're very fragile on its own. And that's why we do encourage, if they are married and in a stable relationship, embryo. But like Dr. rightly said, that autonomy is also important, because if something happens in their life, the consent, if it's embryo frozen, then it's neither female nor male, it goes discarded. So neither of them can have it. So ideally, for cancer patients, they should have individual gametes frozen, sperm and egg, rather than embryo, which is obviously the most tried and tested frozen technique for preserving fertility.
And the cost.
And cost. So cost for sperm is very less. Yes, so it's a preservation cost and it's a maintenance cost. So the preservation cost is around, we take around 15,000 for 1 year. And then the maintenance is 5,000 because they are frozen in liquid nitrogen cans. Yes, so liquid nitrogen cost is that much. So it's 5,000 for the subsequent years till they want to get it frozen.
And for this ovum
So ovum cryopreservation, like I showed the diagram of the ovary, because they are in a very, very kind of a immature state. So they have to be matured before we can freeze them. So they undergo a series of injections for 10 days. A female goes those injections to mature those eggs so that we can take them out and preserve them. That process take around 10-12 days. So that process, procedural cost is
age bracket after which you can
post pubertal, post menstrual, any
Post-menstrual.
post menstrual. She should have started her menstrual cycle.
practically what I have faced in counseling, that there is a reluctance. There are two aspects. One is a parental reluctance to undergo any of this talk or thing with the adolescents also. Like we have a 13 and 14-year-old boy, and parents say that no, he won't understand. He understands everything, but there is a reluctance on the parts of parents to discuss this matter with the child who is undergoing, say, bone marrow transplant, and you are sure of infertility. There is a reluctance on the part of the parents, and understanding this whole process and feeling that they will use out time for the cancer management, which will be the threat to the life. So they don't want to discuss those things. And secondly is there is a fear amongst the parents that if during the active cancer phase, if you preserve the gametes, can you pass on the malignancy to the progeny? There is a big fear. So many of them have expressed this fear that can you preserve it now? We don't want to pass on the same thing to the next generation. And despite counseling, they are not ready to reconcile and agree and give consent.
So for such counseling, especially for the breast cancer patients with BRCA mutations, they can be tested in embryo by a test called as PGT, which is pre-implantation genetic testing. So those patients can definitely be counseled that if we transfer an embryo back, it will be genetically tested for BRCA-free mutations. But yes, for other cancers, we don't have any test, and that apprehension always remains.
So the total cost for a procedure will be, I think, the cost of a GnRH injection plus the
Plus getting the eggs out through a transvaginal ultrasound method, and then it's a preservation.
approximately.
So that injections plus the procedure cost is around 80,000. That's like for just for the cancer patients. It's not, and then the freezing cost is around 30,000 per year. And then maintenance is 15,000 per year. It's because they are stored in the cryolocks. So it is different from the sperm vials.
So the overall cost is much more than
The time it takes and the cost is slightly not, too much, but yes, it's more than the sperm vial.
that is the biggest challenge. The patients who are not affording that, they have a limited amount of money. Yes, treatment, and so at that time they will say, "पहले तो treat करो, doctor आप ये क्या बात कर रहे हो? Let us start the treatment to happen." So it's very difficult for a semi-affording or male still it's okay. We can convince them that you have to.
Yes, it is now a mandate. Everybody, not only oncology patients, but for our fertility group of patients, those who have not been able to get pregnant, also have to be counseled. So we have to do check-post. So we are doing like the couple of counseling softwares we have, questionnaires. So we ask every patient to fill those questionnaires, and then we ask them to meet a psychologist. And then, so they are all tick boxes at the moment we are doing. Yes, it's a matter. And I think for oncology patients, like I said, I think talking about it initially, because, cost is a factor, especially in egg preservation, the time, the cost is a factor, but at least talking to them so that they know about it. And when they finish the cancer treatment, at least they are aware what to expect. If they stop their menstrual cycle, they know it could be, affection of the cancer treatment. At least they'll come back and, seek help or get their blood test done. So I think it's the knowledge and awareness to the cancer patients, which is very important, even if they don't do the uptake of the fertility preserving strategies.
And to the general oncologist also.
Yeah. So I think
The oncology fertility, yes.
Situation, as Madam Kurkure has said, is they want the cancer treatment to be started quickly. That 2 or 3 latent period, no, for this and that, and ovarian stimulation, and that they're not ready to accept. I had 2 patients of Hodgkin's, like 16, 17-year-old girls. Counsel ki ऐसे हो सकता है, बाकी नहीं डॉक्टर साहब आप तो ट्रीटमेंट शुरू करो जल्दी से. So,
but this has also been shown in the Western data, where despite all the resources and counseling, the uptake of fertility preservation is around 10%. So it's not unique to the Indian context where there's resource limitation as well. And so that's, those some fears are universal or some apprehensions are universal.
How much minimum time is required when we send a female for this gamete preservation?
For the female, if we are preserving oocytes,
Oocyte.
it is 2 weeks. But ovarian tissue now is well proven. It doesn't come in the experimental. So since 2019, the ovarian tissue has been classified as a standard tool of fertility preservation. So ovarian tissue, if we are doing, then it's a day case kind of a procedure for a day. It doesn't need any makeup.
So I think what I can suggest is that either the ISMPO or the TYACON can, join together with one of your organizations and have a, consensus document which would be of benefit to your community and certainly to our community. And we could also have a information sheet vetted and got ready for the patient. As Vamshi is saying, if you
I
would,
would like to add to that, that we should have the, for long-term survivors of cancers, we should have a resource dictionary, like directory sort of a thing, that who can do and
We have
with
to
the cost,
contact-
cost consideration, everything. Because these are not very
These
easily available.
We can give the
And
assistance.
IVF, people think that IVF is equivalent to oncofertility, which is very wrong. It is not equivalent. So we have to be very specific in creating a.
Some sort of a consensus guidelines which yes stated and the teaching like sir our DM yeah yeah
Guidelines, correct documents.
And the resource.
Yeah.
Resource as to how to go about when you face the
in
situation.
the centers where it is available, like in Indore, I don't know whether it is available or most likely it will be, but in a city like Jabalpur or whether whom to contact, when a medical oncologist want whom to send, kiske paas bhejna hai. These sort of sources may help.
Ma'am, concluding remarks.
Madam Bobri, law. I was not aware of the citing law in passed or not. We are not aware.
Thank you.
As a chairperson, I would request Dr. Jyoti Bindal to come and share her thoughts with the audience.
I'm very thankful to Professor Chitalkar and the organizing team for giving me this chance. Excellent deliberations by Dr. Arora and Dr. Mandoria. Just to give a brief background of me, I'm not an oncologist. I am an obstetrician and gynecologist, and having remained as professor and head for 10 years, I mean, in a government medical college, we have really come across huge number of cancer patients. So there are a couple of comments I would like to add. Dr. Mandoria, we are past that stage where we do not see a cervix stage 1A. Because nowadays colposcopy, visual VIA, all these methods have led to very, very early diagnosis. So we are doing a lot of fertility conservative surgeries. Cone biopsies and all are happening in a big number. But again, these are mostly for the patients. As we know, cancer cervix can only usually happens after an sexual exposure. So these are we're talking of post-puberty patients. But I think today the whole talk is mostly about pre-puberty people. And my one comment for preservation of oocyte, if you have given chemotherapy to these youngsters who are pre-puberty, I don't think their oocytes, if you preserve, will have a fertility, because they in the pre-puberty stage, the oocytes are not the ones which if you preserve. But ovarian tissue preservation, great idea. I mean, it is what is going to work, but not pre-puberty oocyte preservation. Probably, according to me, it may not work, because these oocytes are they will never go to Graafian follicle stage. The pre-puberty oocytes won't go. So there's no point in preserving them. So ovarian tissue preservation, yes, I agree. But for these patients, if you are giving chemotherapy, now ovarian tissue also has a huge way of recouping. So these patients, many times we have seen, if they've had a chemotherapy exposure, the oocytes and ovarian tissue is not killed for life. They regenerate. What I'm trying to say is this. So these patients often, and as all of you have said, counseling is the main pillar, and this idea about brochures and video clips is a great idea. I think all the centers should have that readily available, something like a ready reckoner, so that anybody who comes can just go through them. And as all of you have mentioned, the parents are too resistant to even think of, oh, this young girl, पहले तो आप इसका cancer ठीक करो. I'm not going to talk about, whether she'll have children or not. That's probably the main mindset parents have. So yes, I agree. And of course, later in life, but we do have very, very good options available. Ovum donation, sperm donation, all these options are there for, you can have a donated embryo and get it transplanted in the uterus of the cancer survivor. So all these things are happening, and they are probably the options. But once again, I must congratulate for brilliant deliberations and a lot of discussions, which is what we don't see in conferences these days. Thank you once again, sir.
Thank you, ma'am, for coming and sparing your time and making sure that we, as a part of the general academics of the university. So I'll request you to accept a small token of our appreciation. Sure. Khushi, please.
Most of the people are not really parents are not happy about okay, fertility, we'll see it later on. So my point is, if that female girl survive, what about her bone marrow? Are we giving justice by giving the hormone supplementation? Fertility, it's okay. Like if you see one scenario, you can always adopt a baby, you can always have egg donation. So is that a big deal to preserve the ovum, to put up that much of cost? Is it really necessary for a poor person? Most of the cancers we see are from the poor families. So my point is, no, my point is to give this female a good life. Her bone should be fine. That is what I feel.
I think
We can see that.
It's a very personal. So if you go to by the definition of a WHO, health is a mental status also. So even if we treat the patient physically, if they are not going back to this community and they feel that because of the disease or because of the treatment, my life has affected and I'm not able to. So it's a physical feeling. So if the patient is affording, definitely we should consider the fertility, and that is an important component and a part of a female life. We cannot separate. We cannot see.
No, I fully agree. I said I'm just showing the different coin. Yes, yes. I'm just showing the other side of coin as well.
Now I request Dr. Ramandeep Singh Arora for being a moderator of this session. So I invite all the panelists, Dr. Vikas Asati, Dr. Swati Patel, Dr. Namrata Kachare, Dr. Shilpa Bandari. I think she's not there. She's not. Thank you.
Dr. Shilpa is the IVF specialist, right?
Yeah.
Right. Can I invite Puneet then instead of her, because we need an IVF voice as well. Or you can sit wherever. Thank you so much. Good afternoon. And thank you, Dr. Chitalkar, for this opportunity. I'm an onco-fertility by default or by compulsion because my wife doesn't spare me. So I have gradually over the years picked up the little bit knowledge of onco-fertility. What I did was I enjoyed the talk by both the speakers. And I think using real life case scenarios would probably bring out some of the points which were mentioned here. I also had not realized that they were going to be survivors. And I think it is important that I think they can relate to some of the situations over here. And if any of them feel comfortable sharing their own knowledge or their own questions, that would be very welcome. So thank you to all the panelists for joining. I'm going to start. I'm a pediatric oncologist at Delhi. So I'm going to start with a simple pediatric case. This is a box standard 4-year-old girl with newly diagnosed B-cell ALL. Her TLC count is 45,000. I'm sorry, you have to turn and see there. And her family is aware and is keen to explore the options regarding fertility preservation. So the 4-year-old girl who's come to you with or diagnosed with ALL, right? And fertility preservation is not probably what comes first to your mind at that point, either as a pediatric oncologist or as a family. But here is a family who wants to know more about it. So I'll start with Swati because you're the pediatric oncologist here, right?
Yes, sir.
And so for such a patient who comes to your hospital, what would your treatment plan be? Just the broad heading, not the details.
So, sir, this child is a case of previous ALL. So we treat her according to the BFM protocols. So we will start her on chemotherapy induction.
And your risk group would be?
Sorry,
She's 45,000 TLC.
Okay, so she'll be intermediate risk to
Right.
begin with.
So depending on what protocol you use, and you use like BFM is one of the most commonly used, you would be intermediate risk. If you would follow a COG or a UK protocol or ICL protocol, it would be standard risk, right? Now, this patient would then, if you had to quantify based on the Puneet's talk about the risk of low risk, medium risk, high risk, and very high risk, what kind of gonadotoxicities you think is going to happen to this 4-year-old based on your protocol of BFM intermediate risk?
So, sir, she'll fall into the low risk category because her cyclophosphamide equivalent dose will be less than 4.9 grams per meter square. And we will not be giving her cranial irradiation also. So she will not have any other gonadotoxic therapy.
So I think that's fair. I'll slightly modify what you have said because these classifications keep changing. But for somebody who's less than 3 grams, we would call it low. And somebody who's 3 grams per meter square, we'll call it medium, which basically means their risk of infertility is between 10% to 60%, just quite a wide range. And of course, if you go to 8 and 7 grams, then it becomes high risk. But this patient would fall somewhere between standard to intermediate risk based on the protocol you use. Okay. Now, this is the reference which again Puneet had showed before. These are the CCLG guidelines, and they have given this UK reference, but this is the reference for what constitutes risk grouping. Now, I'm sorry, I'll engage with the other panelists as well. I'm just pediatric oncology, heart-to-heart talk. So now this child is, assume this child doesn't have ALL, but has a rhabdomyosarcoma, still a 4-year-old child. What do you think is the risk group now for this patient?
So now she'll fall into the high risk group because we'll be giving a very high dose of the cyclophosphamide here. So
right.
she'll directly fall.
And so I would even say it falls into the very high risk group because you're giving ifosfamide 54 grams per meter square. And if depending on whether you give maintenance oral cyclophosphamide, you're really pushing the boundaries here. So there's a very, very high chance, 80% plus, that this patient will become infertile subsequently. Okay. Now, last question for you as a pediatric oncologist. For a child with ALL, do you mention gonadotoxicity? Do you communicate with the family or not?
Sir, frankly speaking, a 4-year-old girl with pre-B-cell ALL, I would not counsel about gonadotoxicity. That is not on their minds or my mind at that point. However, a child, a boy with a testicular involvement, I would like to mention if we are going to give testicular RT, then that I would like to mention. But generally speaking, this is not.
What
one of
about the
points.
rhabdomyosarcoma patient with 4-year-old? Would you talk about infertility to them?
Yes. So, sir, when we talk about the counseling, when we are counseling the patient about the late effects, we do mention them in brief. Even in the initial counseling, at that time, we will definitely mention that this is one of the toxicities.
So I agree with you there, and I think that's what most people will do. And this was emphasized by both the speakers before, the importance of counseling both in adult and pediatric patients, and that's spelled out in each guideline after the other. And if you go and look at studies which have asked subsequently survivors or parents, were you told no? Do you wish you were told yes? Even if you couldn't do anything about it, we would have liked to know. So there is that part as well. Now, Puneet, I can ask you this question. What are the options for fertility preservation in this scenario of a 4-year-old with ALL who is low to moderate risk? Would you offer them fertility preservation? If you would offer them, what would you offer?
So I think in this scenario, I mean, high to very high risk is the one who should be offered
So this is
fertility.
low to medium. This is not
So low
very
to
high.
medium, I think you would just talk about it, counsel about it. Maybe you would not offer them. But when you always will have to look for her pubertal progression when she reaches the age of 9 years, because nowadays puberty is being achieved at 9 also. So when she comes to survivor clinic, I think post 9 years, you should definitely check on her pubertal progression. In the low and the medium risk group, I would not.
What if it was a rhabdomyosarcoma
Yes,
patient?
if it is a high and a very high risk group, then ovarian tissue cryopreservation is the only option for her to save the fertility. And in this case, because she's 4 years, her ovaries are too small. So rather than ovarian tissue, we may end up taking her whole ovary, one ovary. So it may be more end up in having an ovary kind of a preservation rather than the ovarian tissue cryopreservation, because an adult ovary is 3 centimeters. A child of 4 years will have an ovary of 0.5 to 0.5 centimeters. And in ovarian tissue, we make a strip of 1 millimeter, at least 8 to 10. So I think we'll have to take the
5
whole.
millimeter ovary. So you
Yes.
can't take 8 to 10 slices of 5
Yes,
millimeter ovary.
exactly. So I think it will be more like counseling the patient, mom and dad as well, about taking the whole ovary out rather than the
So
ovarian
this is
tissue.
the guidance from the UK group, which is, oh, I think why have I put testicular here? I've mixed up my slides. It was a girl, right, to begin with?
Your point, no? Can you put it?
Sorry, I've got,
Raman, can
yeah.
you put that
I'll put it
male?
here. This
Ah.
one, right?
I would say that if this was a male child, then what would you do? So you can't have a sperm semen.
You can't do that.
banking. So ovarian tissue, now it is still an experimental. I wanted to bring out that over this testicular tissue. We have done at Tata, we had done the testicular biopsies of the long-term survivors and processed them at Institute of Research in Reproduction at IRR. And it was shown that the totipotent cells, embryonal cells, they are still preserved. And if given a correct niche, they can again go back and perform the function like and cause spermatogenesis. This was done in mouse and then it was replicated, and we have published this paper on 14 or 15 long-term survivors, testicular biopsy. So that is still, so as the ovarian biopsy is being done, the testicular biopsy is done for reviving spermatogenesis, but that is an experiment.
So
Totally experimental.
Yeah, so what I'll do is, I think I will show some data towards the end on both ovarian tissue cryopreservation and testicular tissue cryopreservation, where it stands as of today. I think you wanted to make a point? No. So this, so essentially in this patient, you cannot, save the oocyte. You cannot, then you are left with tissue preservation. As has been pointed out, it's not practical in the case of ovary, and in the case of testes, it's definitely experimental. So you essentially have no choice but to counsel the family, and post-treatment, monitor for puberty onset and counsel when the time comes. I'll come to the next case, and I would like Dr. Vikas, right? I'd like to bring you into this. This is a 14-year-old female, and depending on where you work, this patient may go to an adult side or a pediatric side, who has a relatively large volume, 400 ml Ewing sarcoma of the pelvis, which is non-metastatic. She achieved menarche a year ago prior to her diagnosis, and her treatment will involve ifosfamide, depending on protocol use, and pelvic radiation, because that's shown to be of benefit as well from the disease control point of view. Now, what would you as a medical oncologist use to treat her?
So we are giving neoadjuvant chemotherapy, like 4 cycles of neoadjuvant chemotherapy, followed by local therapy in the form either surgery or radiotherapy. Then again continuation of same chemotherapy for a year, total of 17 cycles, 1 year of treatment.
And what drugs would you use?
VAC alternating with ifosfamide plus etoposide.
And Dr. Swati, would that be a similar treatment as well? You would use a similar kind of treatment for this patient?
Yes, sir, that's what we are following.
Okay. So VDCI, some people use 14 cycles. That's what I do. Some people use 17 cycles. Some people use 2 weekly. Some people use 3 weekly. But the cumulative dose for at least 14 cycles is the same. With 17 cycles, the cumulative dose will exceed. Dr. Vikas, what would be the risk of gonadotoxicity in this patient?
That will go for high risk.
Right. So very high, I would say.
Very
But
high
there is a
risk.
very high category also
Correct.
of 80 to 100%. Not only because of 8.4 gram per meter square of 7 cycles of cyclophosphamide, this is based on 14 cycles, not 17 cycles, and 63 gram per meter square of ifosfamide, but also for the fact that you now have pelvic radiotherapy. So all of them together would do it, would make the risk extremely high. Dr. Namrata, I want to bring you in over here. What kind of fertility preservation option do you think would be available to this 14-year-old with a pelvic Ewing sarcoma? Could we do anything with the ovary, or is there no role of ovarian transposition or anything of that over here?
Transposition can be done, but then scattered risk will be always be there. Means it has to put in the inverted bracket to the thing. Okay, we can do the transposition still about the thing, and scattered radiation is around 5 to 10%.
Right.
Apart from that, 14-year-old madam can be do the preservation. Huh.
Either oocyte or ovarian tissue.
Ovarian tissue. So in any other place we are doing ovarian preservation?
So
Tissue
ovarian tissue,
preservation?
yes, ovarian tissue preservation. I mean, we do have techniques, but the uptake is very less. It's just, the medias for the ovarian tissue are very costly. So once we open them, it has got a shelf life of only 10 days. And we should have ideally 10 patients to use them because it's very costly. So at the moment we do offer, but the cost is more than oocyte. So it's better in this case. Yes, I mean, we are trying to explore the fundings and, get it more subsidized. But yes, we don't have the volume. If, like, let's say every oncologist counsel patients for ovarian tissue, if we have 10 patients in a month, we will be offering at a much, much lower cost than the oocyte cryopreservation.
What is the cost, actual cost?
So the media cost is around 2.5 lakhs. So if you only use for one patient, so it goes high then, even if we get subsidized. But if we have like 10 patients, which we can use one vial for, the cost will really go down, 25,000 something will have only in ovarian tissue.
If we are all connected nationally.
Yes, then that's
program.
what the international, they have done. What they have done is they have made ovarian tissue cryopreservation bank. So let's say you do a surgery in Indore. There are cryo bags in which we send you a little media, freezing media, which is very cheap. So you take the ovary out or the ovarian tissue out, put it in there, and it comes overnight or within 8 to 10 hours to us. And then we do the rest of the preservation. So that's what the Western world has done as well.
Dr. Namrata, just give you an example that in the entire UK, there are 22 centers which treat children with cancer. You cannot treat them outside those 22 centers. But there are only 2 centers which do ovarian tissue cryopreservation, which is Oxford and Edinburgh. One for England, one for Scotland. That's it. just because you have to have pooling of resources, patients, expertise, research, etc. You cannot hope to open it in 100 places or 10 places or 20 places. Only then can the numbers and the science and the effectiveness be looked at. So this is the guideline for such a patient, which is in green, it is oocyte or embryo cryopreservation. Embryo obviously not in this patient because she's only 14, but if she was suppose 18 or 20 or 24 and she was either married or she had a stable partner, they could have explored that option. But a oocyte preservation, which would now be considered within standard of care, is what would be advised as long as the prognosis is not compromised by the delay, which generally for a sarcoma patient, we have that time margin. For a leukemia or a lymphoma, that margin, the luxury will not be there. Coming to the harvesting of ovarian tissue for cryopreservation, there is a recommendation because now the risk is very high, but it has to be balanced with the facilities available, the cost available, and the expertise available. And so I don't think we should dismiss it, but we should be conscious of the setting we are in and what can be achieved in our setting, and not be very gung-ho about it. The oophoropexy is important, but again, in this case, because the chemotherapy is going to be the main one causing the gonadotoxicity. So regardless of where you put the ovary, the chemotherapy is going to anyway cause harm to the ovary. Hormone suppression, alkylating agents. Now, as a pediatric oncologist, don't do hormone suppression at all. But I know medical oncologists who are here do hormone suppression, GnRH analogs for many of their patients. I think the maximum data is in breast cancer. And even there, it is controversial. It is not crystal clear or straightforward. For other cancers, other than breast cancer, it is not offered, or maybe it should be offered only in the context of a research protocol. So I personally would not use GnRH analogs in such a patient who's 14 and has got an Ewing sarcoma. We've discussed this, so I will leave it. And you very rightly pointed out radiation scatter. So that's a problem. And then something else which I didn't know is that there's a risk of remigration. And so the procedure should be performed as close to radiation as possible. The challenge is we are going to give 3 months of chemotherapy. So if we give 3 months of chemotherapy, or we do something, so then there's not much point in moving the ovary by that time. So that's something to be kept in mind. Role of hormone suppression I've discussed. Radiation. But if by that time you've already done the tox, unless you're doing radiation right up front for some reason, otherwise by that other time, nothing is. Dr. Banore showed the pictures of where you can put the 3 places you can put the ovarian transplant, the ovarian transposition.
Yeah, the hormonal function is retained. It's the fertility which is reduced.
But there is a biological basis for that because the hormonal component is more radiation and chemo resistant than the gametes. So yes, so depending on the dose, but it would be fair enough. I think that's a fair point. That from that point of view, it would.
I just have a question here. Oophorectomy, ovarian transposition, is there any cutoff age, like a child should not be this much age, or where there's no, let's say young, like 4 years, let's say a girl would have it?
The
Would
4
you
year,
consider-
of course, it would be difficult to do because, as you said, the size of the ovary will be too small. But yes, studies are not there, and I have not done. So most of the time we have done laparoscopic oophoropexy in the more than 20, 21, 20, 28, and we have seen that the ovarian function continues. Most important is we lose where exactly is the ovaries when we do the imaging. So the point is to put the clip there So you can identify, yes, this particular place, the ovaries are there. So the ovaries follicles can be identified and you want retrieval of the ovaries that can be done because you will be placing it below the liver somewhere. So very high. It's difficult to identify. So we do something like that.
Right.
It's just an evolving world.
It's very interesting. So the third patient, sorry, Dr. Hemant, please.
Can I ask a silly question? So, we are pretty confident that the pre-pubertal testes is a lot more resistant to chemotoxicity, gonadal chemotoxicity as compared to the post-pubertal testes. Does the same hold true for the ovaries also?
Yeah, it does. It
It's
does.
very,
Yes.
on the contrary, ovaries are much more sturdier.
Sturdier than the
than
male.
Because there are fixed numbers of follicles which you are born with, and they're all in a quiescent phase. So the chemotherapy which acts on the replicating cells spares the ovaries very well. That is how the gonadotoxicity in female is much less if you are not use the radiation.
Yeah.
While so is not the case with the sperms, because sperm is formed once it starts, it's a continuous replication. It's in dividing phase. So the sperms are damaged much more. The hormone producing cells are very resistant. That I agree of testes. But
But there's a caution to the point which you're making, which is it has in the past, using that assumption, been thought that all the children are not going to get infertile because they are affected because that's not the case. So they may be relatively less sensitive than an adult or a post-pubertal ovary or a testes, but they still remain at a significant risk from all these treatments.
Yes.
And so fertility preservation or the implication of gonadotoxicity has to be considered for them.
no, so what I am trying to say, the gonad has two major functions. One is fertility and one is hormone. If you are not able to, in very young children, able to achieve the fertility part of it, we have to think from the hormone part. That is very important for the internal milieu of a growing child. That is my submission.
And I think I'm even more convinced that a document should be prepared on this. I haven't seen so much interest in any session since morning, and a session which can keep me awake post lunch meal. So I think you guys really need to, husband and wife need to do something.
No, we will.
So actually, there's something in the offing right now, and we share it. Coming to the third, actually, in the last scenario, there's an 18-year-old male, and again, this may fall into the pediatric group or the adult group, who is newly diagnosed with stage 2BX, so bulky disease, Hodgkin's lymphoma, has a large mediastinal mass, and the patient is unwell from the size of the mass. Dr. Vikas, as a medical oncologist, how would you treat such a patient?
Because the patient is unwell, I will start with the chemotherapy, ABVD, and once patient is stable, then I think that is the point I will discuss the fertility and all.
Dr. Swati, would you follow a similar treatment protocol, or would you have a different approach to the patient?
So, sir, while counseling, we can mention that this is, when we are telling about all the side effects of chemotherapy, we will mention, but we'll say that, yeah, first we need to take care of the immediate problems and then.
So how would you treat a Hodgkin's lymphoma stage 2BX bulky disease?
So we'll start with ABVD chemotherapy, sir.
Okay. Now, there are, as medical oncologists in adult, ABVD is what would happen all the time. As pediatric oncologists in the West and in India, there is now a growing effort to move away from ABVD. There is a slight superiority in the outcomes. There's definitely a superiority in terms of late effects, because you divide the doses between, don't give just 6 cycles of doxorubicin or 6 cycles of bleomycin, but you split them up. And so the European protocol, the American protocol, and now the INPOG protocol, which is the study which Tata is doing, a randomized study, are moving on to the OEPA COPTAC model, which is slightly more toxic in terms of febrile neutropenia, etc., but has an added benefit in terms of late effects as well as efficacy. So you could use either. So I'm not saying that what you're saying is wrong. But what, for example, I would do, or at least the data says for early stage Hodgkin's, 1A, 1B, 2A, ABVD is equivalent to OEPA COPTAC. And in an Indian setting where finances are issued, logistics are issued, I think that's fine. For 2B, 3, and 4, there is some evidence to say that it is if your center can deliver it and the supportive care, the OIPA COPTAC or the Uronet PHLC1 protocol is more superior. So regardless of what you use, that's the kind of philosophy, and then you may or may not use it. Yes, Dr.
So what we are doing, that we are doing the PET adapted response based on the response we are treating. So we start with ABBD, and based on 2 cycles of PET, if there is a CMR, we continue with ABBD or ABD. If there is PET is positive, with especially dual score of 4 and 5, then we escalate to escalated BACO.
Yeah. And that's something which adults do quite commonly as well. So that protocol or this protocol, and I haven't put the data for SLB-COP, gonadotoxicity for ABBD. What would you put gonadotoxicity for ABBD?
ABBD maybe intermediate.
Okay.
I'm not sure.
Yeah, that's okay. So the ABBD 6 cycles, the only thing you're doing is dacarbazine, and that forms into the low group. The doxorubicin and the vinblastine and the bleomycin are not causing effect on the fertility. If you use the Uronet PHLC1, particularly the treatment group 3, which is for stage 3B and 4, you end up giving a little more cyclophosphamide, and the group risk shifts to medium. Otherwise, generally a low to medium risk disease for risk of fertility. Now, what if this patient had bulky pelvic disease? So now we're talking about stage 3B rather than stage 2B. So you've got mediastinal disease and pelvic disease. What would then be the risk to this patient of fertility? Either of you?
So, sir, it depends if we are going to give a pelvic RT or not, because now there is evidence that if there is a PET response, if there's a CMR, then RT need not be given. In that case, it will still fall into the lower medium risk as per the chemotherapy. But if we are going to give RT, pelvic
But
RT,
you don't know this when the patient is diagnosed whether you're going to give
Yeah.
RT or not.
that is right.
Right.
That
So
is-
you will have to make a decision for fertility preservation based on the assumption that you may have to give it.
Mhm.
So the risk would increase if there is pelvic RT potentially possible, which you may or may not give eventually. And so now, because the pelvic RTs come, the risk group goes higher. Now, I wanted to share some Indian data with you. Puneet, would you offer fertility preservation? No, let me ask this to actually Vikas and Swati. Would you offer fertility preservation to this patient? It's a low to moderate risk group. Forget the pelvic disease. It's just a mediastinum, Hodgkin's lymphoma. There's also some evidence to suggest that Hodgkin's lymphoma per se can also affect the fertility. So low to moderate risk, Hodgkin's lymphoma, would you offer fertility? An 18-year-old. I've forgotten what the gender was. Female. So would you offer? Let's check. Wait. So would you offer them fertility preservation? And if you would, what would those be?
So yes, sir, I would offer them fertility preservation. Firstly, because as you said, we don't know at the beginning how he's going to respond. He may relapse in future. He may have multiple issues, and we are going to give him chemotherapy anyways. He's 18-year-old, so sperm cryopreservation
So
is
even with the low
fairly
risk
feasible.
ABVD protocol, you would still want to think of offering fertility preservation.
Yes, sir.
Dr. Vikas, what about yourself?
So in male, it's simple, sir. Like we can discuss with the patient and also the family. The 18-year adult male is there. So we can discuss if he is willing.
So discussion is compulsory.
Compulsory.
After that, willingness is up to the family and they can make a choice if it's there.
Completely agree.
This patient was unwell, so you may not have the potential to do that.
Yeah,
but
yeah.
if they
But
were
maybe after 1 or 2 cycle, because it is dose dependent.
So that's a very important point you said. Puneet, you want to say the answer to that?
So once you start the chemotherapy, you should not offer fertility preservation. So it should be upfront at the beginning of the cancer treatment before you have started chemotherapy, because there have been enough data to say that chemotherapy can alter the genetic and the cellular damage in the sperm. And you are just basically giving them a hope without any, positive effects for long term.
But is there any data regarding this particular
Yes,
thing there?
yes. So
Yeah.
there is enough data on
So
the
that-
effect of chemotherapy on the sperm damage. Yes.
I mean,
Yes, even 1 cycle, you should not counsel. You should not offer
I
that.
think you had a
Testing-
slide, some information that in your presentation, if I remember correctly. Something you had shown.
Yeah, so that was that after chemotherapy, the restoration of fertility with
Right.
intact sperm would The high chance of genetic abnormalities in this sperm.
But even like we said, 1-2 doses, there are two problems. One is the genetic changes. The other is the quality goes down. And so they're both challenges. I mean, you could try, but it's not recommended. Yes.
Something is better than nothing.
No,
Sorry.
No, it's
that
so especially with the low risk Hodgkin's group, ABVD, it's better to do it 6 months. I mean, just call them back 6 months after the last chemotherapy.
that is
Check
also-
whether
check
they may
whether
not have any
may not-
affection.
might not.
That is much better than preserving the sample once they've had 1 or 2 cycles of
So
chemotherapy.
this is, what about the BP, that BP regime,
Yeah.
testicular cancer?
So obviously that falls into the high risk.
Yes.
High risk.
So cisplatin will push it into the higher risk.
Yes, still
And
you
with
would
one
not.
ovary gone and one ovary exposed to cisplatin.
Many times these patients are infertile upfront. And once we give
And
chemotherapy,
here also
they become
patient is
fertile.
unwell.
It's already
Yeah.
well established that
So,
patient may have.
so patients' sperm counts will be very low, infertile upfront. So when should we do that?
Sorry, I didn't get the question. We're talking about Hodgkin's right now?
No. I think the thing is that
testicular cancer.
the problem with Hodgkin's is the disease itself can affect the sperm parameters. So I think when we see such patients in this thing, we do mention them that whatever will freeze may not be the kind of a genuine analysis we will have, because Hodgkin disease itself can affect it.
So that is fair. So
Yes,
if I understood,
testicular as well. Yes.
so I understood there were two.
Yeah.
There were two questions I understood. First is, if you give chemo and after 1 cycle you bring the patient, that is not advisable or recommended. However, when I was making this presentation, it came to my attention that you can, at that stage, if you had it, testicular tissue biopsy or ovarian tissue biopsy still works after 1 cycle of chemotherapy. In fact, for leukemia patients, because there is a risk, suppose you were doing tissue biopsy, and there's a risk that the leukemia cells may be in the ovary or the testes. So you should actually do it after the patient is in remission, which is 5 weeks down the line. And so there is data to suggest and a practice recommendation that specifically for biopsy, you can do it after the first few weeks of chemotherapy. But for semen preservation, for oocyte preservation, it is not recommended. I think you are talking about a different point, which is what if the baseline assessment of the patient is suboptimal? So sometimes we send patients of Hodgkin's and they do give 3 semen samples, and the semen samples are oligospermic or the motility is poor, etc., etc. So what you do in that case is you work with what you have. You save it, you freeze it. It's a backup option, although suboptimal. And then once the treatment finishes, you test it later and see how things are. And if push comes to shove, you use what you have. There's no other choice there. And barriers to fertility preservation. So in Indore, for example, would you be able to send a patient for fertility preservation? Where would you send it? Are your IVF specialists glued on to it? What kind of experience have you had?
There are multiple centers who are doing sperm preservation, and maybe more than 5. Even in-house also we are doing some. It's
Okay.
available.
And your experience as a pediatric oncologist?
Sir, I think the biggest 2 barriers that we'll face is that one is the immediate condition of the patient. The patient having cancer, and the parents are always concerned about the child, not the future generation, all that. And the second is the cost that we face. Even in private practice, even in the government setup, everywhere the cost, even for a cryopreservation, even for a sperm banking, will be very difficult for the patient who is struggling to get the treatment for the cancer itself. Yes, because the children
So I
At
want to
least
share
20.
with you some brief information. So this is part of the INPOG HL 1501 study which we did, where it was an ABVD based regimen, and we had recommended that for adolescents, you could offer them fertility preservation if they were willing. And out of the 400 odd patients on this study, around 100 odd were above 13 years of age. So out of those above 13 years, assuming that they had achieved puberty, only 7 were offered fertility preservation, right? So the offering fertility preservation was only 7% of patients, and only 2 did it successfully, which are both males. The females who were offered did not manage to do it. So So the remaining 92 or 93 were not offered, right? So we then went back to these 27 PIs, out of which 22 gave a response and said, please rank in order of importance. What would be the barriers which you would encounter when you would think of fertility preservation? And this is Hodgkin's teenage I'm talking about, not talking about any other disease right now. So in a teenager who's getting ABVD protocol, stage 3B disease, what would be your barriers? And we divide them into public hospital and charitable hospitals because their challenges are different, and private hospitals. And as you can see, affordability, accessibility is something which ranks very highly in public hospitals. While in private hospitals, affordability and accessibility is not as high. It's more about the cultural acceptance of the parents saying, oh, my child will be able to do it, or something which we're interested in, etc. So that was, we were also looking at whether there was a fear of child abandoning treatment because of this waiting. And surprisingly for us, we found that that didn't seem to rank high in the importance of things, although that's something which we have always thought would be a reason, or anecdotally we have experienced that. So options for fertility preservation, I think this was highlighted in the talks before, which was sperm cryopreservation via masturbation or penile vibration is the obvious choice, easy, fast, cost-effective. If that is not possible, or the patient is post-pubertal but finding it difficult, you can do electroejaculation or testicular sperm extraction. This is obviously in pubertal and post-pubertal. They say no recommendation can be formulated for harvesting testicular tissue at this time, and they do not recommend hormone suppression. I just have 3 more slides and I'll finish, and because these topics were discussed earlier. What is the evidence of efficacy of ovarian tissue cryopreservation? Because that's been discussed many times over here. I don't think anybody over here has done it. You talked about some experiment, the thing which you did in Mumbai University, that was, yeah, that was very early embryonal stem cells, something you were looking at. So the first ovarian transplantation, which means putting back the ovarian tissue, was done in 1999. And 2004 was the first live human birth, which came from an ovarian tissue which had been re-implanted back in a patient. And 2015 was the first time this happened in a peripubertal patient. So it was an African patient who had gone to the US or UK or somewhere, and was had already started showing breast development, and her hormones were pubertal, but had not had menarche yet. So around 14 years of age, they did her ovarian tissue preservation, and then a few years later, they transplanted it back, and she became pregnant. Subsequently, 2018 is the only case report yet of a prepubertal child who was 9 years old, who had an ovarian tissue cryopreservation, which was then re-implanted back in her after I think she was sickle cell, and she had a transplant done for that, and then eventually became pregnant. This came out 4 years ago, and this remains the only case report for pediatric age group. But for the older adults, there have been a number of reimplantations, and the number of live births 2 years ago had already exceeded 200 in 2020. So this number is obviously increasing, but mostly for post-pubertal, not for pre-pubertal. And the American Society of Reproductive Medicine 3 years ago has acknowledged that this method is safe and clinically accepted. Keeping in mind, we are talking A, about the Western context here. B, we are talking about post-pubertal patients over here, because the pre-pubertal data is not there. So it is a promising option, but it is something which has to be kept with the safeguards of a clinical trial, or oversight, etc., and pooling of expertise and resources. Otherwise, it has the potential of misleading or wastage of money and resources. Coming to testicular tissue cryopreservation, till date, there has been no success in the form of pregnancy, either in a post-pubertal or a pre-pubertal testicular tissue preservation till date. The success has only been in animal models, in several animal models. So theoretically, there is a biological basis there, but it hasn't translated yet into human living. So this still remains a experimental method or a research-based method in every guideline across the world. I think this is fine. Yeah. So I want to thank the panelists thank all the participants from the audience. Any questions for the panelists? Any questions for the experts sitting here or are
I have a more of a grassroots question to the panelists that all these procedures, in last several years, is the number increasing of people who are undergoing these procedures? Are like more and more patients going for it? Like say in a span of say 100 people, how many are like as of today roughly?
So I would say that in practice, because I practice in Gurgaon, we do get a lot of consultations. We do get a lot of discussions with cancer patients, but the uptake rate is very low, especially with the female group.
Okay.
Male, very good. I would say in the current data, we had around 10% uptake.
Okay.
But female, it's I would say 1% only.
Okay.
But yes, the number of patients in OPD discussing about it has increased. So thank you to all the oncologists, who talk to their patients and then they come to us. So yes,
Okay.
the consultations are increasing.
And how is the reach in the rural areas? Like now with that we have been so digitalized and all, is it reaching to the doctors there at least who can
So
offer?
I work with the CAN kids,
Yeah.
I work
Yes,
with
I'm
CAN
aware of
kids.
that.
So I do the online consultations because wherever they have a reach,
Yeah.
if they have a survivor passport. So, and I have made those groups in that passport. So that person who's filling up the passport, if they see a high group or a very high risk group, then I do a consultation with them and do advise them some tests if need be,
Okay.
depending on their history.
Okay.
So that's how we're trying to reach at
But
the
it's
moment.
only your organization or
Yes,
like
so
amongst
yeah.
the doctors when you all have so many clinical meetings? Because these questions often come
No, I
to
mean, there are
people
a lot of
like us
medical
who are
oncologists here,
working.
Dr. Hemant, Dr. Vikas, they can
Yeah.
comment on. I think it's my experience because I work in oncology department
Yeah.
is that it's definitely not an afterthought.
Yeah.
Tumor boards are actively discussing fertility preservation all the time, but every discussion is tempered with time. How much time will it take?
Yeah.
How much resources
Yeah.
is it going to take? What is the availability of that facility in my own place?
Yeah.
No, I
And-
think I am pretty sure in my mind that the knowledge in at least medical oncologists is it significantly needs to be
Increased.
enhanced.
Enhanced, yeah.
There's a
Gap
big
there.
black hole over there.
So the only questions are which in my mind regarding the question which I have asked regarding the benefit of GnRH analog with breast cancer. So can we extrapolate to the nasopharyngeal cancer now? Because I had a patient at 19 years. So I was in dilemma, should I give? I don't have a data. So can we extrapolate for, because that's an easy thing. GnRH is available left and right. So
But GnRH analog
it's
is
still, sir, it's
So
it is not for fertility preservation. I had brought out in my talk. GnRH analog
like a breast data, there is a good enough data that with the, like a TNBC,
is not for fertility preservation. It is only for ovarian function preservation, even in breast cancer.
and in breast cancer
doesn't
patients
preserve
also,
fertility.
it has been shown more useful in the hormone receptive
Yeah.
tumors.
Mhm.
So it's
and can we extrapolate from that aspect?
No, we can't. I don't think
Yeah,
we can.
so-
And this is a verbatim statement from the ASCO guidelines, which you were referring to as well,
Yeah.
which is that the evidence for fertility preservation is conflicting. So whenever you're using it, please don't use it as a substitute for established methods of fertility preservation. You
Yes.
should still do the oocyte preservation or the embryo preservation and use this as an added benefit. Also, the data is only in the setting of young women with breast cancer. It should not be extrapolated to other cancers, although it is being extrapolated because I know from my colleagues who use it for other cancers because there are not many other facilities available, but the data does not support that.
And even
I don't
the-
do breast cancer, so I am.
Yes, so even the recent ESMO guideline also mentioned that respective of breast cancer type, like hormone receptor positive, negative, or HER2 status, the GnRH analog can be given. But in apart from the breast cancer, we can discuss, but still the data is evolving.
One last question to the army, the person, sorry, I forgot the name. So I also belong to the same fraternity. Since we have a patient scattered all over the country, but we have the drain points like in say command hospitals, wherever there are these things. So do we have as compared to the civil setups, are we more accessible to these facilities for the defense people, the people who are coming in the defense? Just because the drain points are like the command hospitals at 5-6
The counseling
locations.
definitely. I mean, we will be able to counsel any patient from across the country. but not all command hospitals have a ART center. ART
Okay.
centers have been dealing from command hospitals.
Okay, but
I-
you,
I don't
we have a facility of referring them to different.
Yes,
commands.
so yes, we can do that.
But is it like, is the response good or is it coming up?
Yeah, so probably as we talk more and more about in such meetings, more people will start coming. But practically, we hardly get any such requests.
Thank you.
I would
Yes,
like
please.
to ask one more question. Yeah, thank you. I'm Dr. Shashank from Arvindo Medical College. So my question is like in our clinical practice, when we treat seminoma patients, so in early stages, we obviously we have to think twice in the earlier cases, like we have to give chemotherapy or should we go for radiotherapy? And our major concern is the preservation of the fertility. So can I have a brief overview, like which technique to, because as per the survival.
He's asking stage 1 seminoma. We are not able to preserve anything. Should we go for chemotherapy or radiation?
So I can answer because the for stage 1 seminoma we have to give carboplatin. So the suppression potential for that, but I sent to all patients before starting. In fact, the ideal time for a sperm preservation in a test tube is before architectomy because the testis might contain some. So the ideal time is, so ideally any patient who is going to offer, irrespective of either they're going for radiotherapy or chemotherapy, I send to all of them. But the incidence of compared to the BP chemotherapy, which is carboplatin, what we have seen that when we checked sperm after 2 or 3 years, majority of the patient was
So in initial cases, when patient asks us like, sure, should we go for chemotherapy or radiotherapy? And which is the technique we should have? So what should I?
That is a different question.
But in either case, you should be offering
That is a
fertility,
different
you should be
question.
offering
Which
semen
modality? That I will
preservation
discuss with you
first,
later on.
right?
But we do.
That's a medical, that's a oncology
My
question.
question is,
over here.
most of this
What do you-
tumor in pediatric age group and teenagers are systemic diseases. That's why we give chemotherapy. Without chemotherapy, prognosis is dismal. Sarcomas, leukemias, lymphoma. So when we are reimplanting the tissue, is there any risk? Because patient asks, "Sir, वो tissue तो आप वापस डाल रहे हो, जब chemo देना था तो उसमें भी तो हो
Okay.
सकता है cancer."
So you're talking here about testicular tissue which has been preserved, right? And then you want to put it back into the patient. I have no experience. I think there is information out there with the specific guidance out there. For leukemia, as I mentioned, there is definitely a theoretical risk of contamination, and the advice is to do it once the patient goes into remission, not do it upfront. And even then, the testicular tissue will have enough material which will be viable later. Specifically for germ cell tumors or for sarcomas, I really don't have the knowledge to be able to give you an answer for that. Okay. Thank you. Thank you so much, Tom. Thank you.
Thank you, Dr. Ramandeep Singh Arora, for carrying out a wonderful panel discussion. It was very engaging and informative. So now our next session is a debate motion. It is adolescent and young adults with cancer should be treated by an adult medicine trained oncologist. And for this, let me take a pleasure to call upon a person who's been a spine of Team TYACON. Now he doesn't require any introduction. I call upon Dr. Colonel Prakash Chittalkar as the chairperson of debate session with a loud round of applause.
Trained medical oncologist, that internal medicine MD physician, or it should be by a pediatrician. The motion says it should be adult. So I have the worthy proponent of the motion in the form of Dr. Amit Joshi, who is a professor of medical oncology in Tata Memorial Hospital, and he's a unit head of the unit which actually has a AYA clinic in Tata Memorial Hospital. So I call upon him to defend this motion.
So I think it's a very difficult topic, but still I have tried to do justice with this topic. So who should treat this patient? So I will just go with some basic. These are will be the point that what is the burden of TYA or AIA survivors? What are the physiological aspects between the children and adults? And we know that there is a possibility or dearth of the trained medical oncologists in our country. And is there any protocol similarity and need of long-term follow-up from oncology perspective and monitoring of long-term metabolic complication for all these survivors? So this question very oftenly discussed that whom we should define the AYA. So there is no consensus, but what I can get the literature that WHO defines. So anything from age of 14 to 39. So for a discussion purpose, anyway, even in Tata, the cutoff for a pediatric is, so the moment the patient is 15 years, we come into the picture and treat. So less than 14, pediatric medical oncologist treats the patient, and then after 15, we come into the picture. And most of the international guidelines follow this. So if you see the age group, definitely the medical oncologists are the person from this. And now comes the magnitude of the problem. So if you see the number of, this is one of the FAIR database which has looked into the causes of death in the young adults. So if you see the numbers, the neoplasm comes into the second or third. So that means the patients who requires care, the number is too high. So it's not that the number is less. So that means definitely the volume is big. This is another data which I found. If you see the last line, the worldwide there was an estimated this number of cases. We then the incidence is approximately 7% of all cancer cases. So if you look towards the total number of cancer patients in our country, 7% of for this 20 to 40 is going to be a very huge number. So 7% looks less, but the absolute number for this overall population will be too high. So that means the number of patients who requires care is too high. And this how long this patient will need. So practically, as the number of survivors increase, the follow of these patients will go for a longer period of time. So that means the patients who are being survivor for a cancer in early age group, they needs a long-term follow-up. So some sort of a, and they will become adult. So even if the treatment is started at age of 15, ultimately they will become adult at some point of time. Now comes our Indian situation. So this is the data for not for a medical, this is the situation for a doctor in our country. And this number, so the current number, this includes both the MBBS and the Ayush. So if you see the number of doctor for a population in a other part of the country, this number is so it is well below the average number for even a general physician or MBBS. Just leave us aside the medical oncologist. So that means the number of doctors for even general population is less. If we further subdivide, and this is further worse in the cases of cancer. So these are some figure which are highlighting the number of cancer patients which we have in due course of time. So if we this is the WHO document, slightly older, but it says that the one medical trained oncologist for 2,000 cancer patients. By comparison, if you compare the Western world, this is around 100 cancer patients with one trained trained oncologist to treat them. So this number is quite high. So 2,000 cancer patients with one trained medical. This includes the radiation and all other also. Where in Western world, this is number. So that means we have a less number of physicians. And then the trained oncologists, the number is still less. So if we divide further in subspecialty, we will not have enough doctors to treat this. So this is like a Mumbai local where the already there are too much crowd to enter into that, and we are cutting one or two other bogies from that. So the more so if we divide this TYA as a separate entity, the number of doctors who are treating the other cancer will come down. So I don't think so that still we have a time. So the adult medical oncologists still, if we increase their number, we can tackle the TYA also. So this was the something, and let's see the distribution of cases in TYA. So if you see the type of cancer which are seen in this age group, so this is the chart for the male. Now, if you see the number of the type of malignancy, the testicular cancer, leukemia, thyroid, lip oral cavity. So these are the malignancies which are very common in the adult population. And if you come to the female, the number of the breast, so still this comprises of around 30%. So that means these are the malignancies. And if you see the both male and female, still, so these are the common malignancies which are seen by a trained medical oncologist. We being trained in treating these patients. So do we still need a separate? I don't think so, because the malignancies which I have just shown in this, so the breast and the thyroid, uterus, leukemia. So these are the very less number. Still, the chunk of the AYA is formed by the breast, thyroid, uterus, and the genitourinary. And some. So that means the main burden for a TYA cancer is still adult-oriented cancer, not the pediatric. It's not the leukemia, lymphoma is not very high. So still we feel, and as a medical oncologist, we can treat leukemia, lymphoma also. So I don't think so that we need a separate entity for this. Now comes the question for a pediatric oncologist versus adult medical oncologist. So if we see the physiological aspect of the adults versus children, so this is the just chart which is showing the systolic blood pressure. So if you see that there is a wide variation under 1 year, 2 year, 3 year, but if you come to the adult after 16, everything. So that means the physiologically a TYA is more closer to the adult rather than the pediatric population. So they will have a difficulty in treating the adult. When this survivor will become adult, they will not be even trained to handle the. Similarly, the same as the, and if you see the age the blood pressure variation is still not that high. So that means similarly the respiratory rate, if you see the wide variation from birth to 15 to 18 years, and after that it remains constant. So what I meant to say that the physiologically the TYA are more closer to the adult population compared to the pediatric population. So pediatric oncologists should not ideally venture into the area. Similarly, the cardiovascular differences. So if these are the points, the body surface area, the blood volume distribution, these are quite different from a pediatric population to the adult population. So similarly, the GI difference. So what I meant to say that the pediatric population is an entirely different subgroup of group, whereas a TYA which may mimicking more to an adult side rather than a pediatric side. So pediatric oncologists are well trained to understand and treat pediatric patients which are less than 14 years of age rather than the TYA patient which are physiologically more closer to the adult population. And just so this was the physiology. So the other question which was very commonly discussed regarding the good prognosis for the ALL and the various regimes which are being used for ALL patient. But if you look to the, so this statement was more relevant when we were not able to understand the biology of the disease. As the time passes, we know that ALL is a very heterogeneous group, and the type of the mutation, these are entirely different from a pediatric population to the adolescent and then to the adult. So the same chemotherapy regime or the same survival which is seen in a pediatric population will be entirely different because the biology of the disease is entirely different. So, and the other thing which have come into the during course of time, the most important factor for ALL is what is the MRD. So if we are able to achieve the MRD after the initial first course of the therapy, that is the best surrogate marker. So if whatever regime which are using, if we are achieving, and those patients who are not able to achieve MRD after the initial, they should be treated with a different regime like a transplant RD. So their cure rate might be better. So it's not the pediatric ALL based therapy which will improve the rate. It is the type of the disease which we are dealing, and the most importantly, karyotype and the cytogenetic and the MRD. So that what I again discuss in this slide, that the ultimately the therapy is based on the MRD, and this is the practice has already been started. So this slide is showing some details about how the pediatric ALL is different from the adult ALL. So there are various further subdivision into the molecular, that molecularly the pediatric population is entirely different. They have a good prognosis compared to the adult and the TYA population. This is just various mutations which are seen. So if you see the pediatric population 0 to 10 and some 20 year, the 12-21, which is a good prognosis, this percentage is quite more in this. But as this the adolescent and adult, the pH comes into the picture. So that means the treating this group of the patient will be more like treating an adult pH positive ALL compared to the pediatric population where the pH incidence is very, very low. So that means the adult medical oncologist will be better able to handle this group of the 922 positive pH ALL compared to the pediatric whom the exposure is not that common because the incidence is very, very low. Similarly, for the AML, so if you see the number of different mutation which is seen, infant, child, AYA and adult. So if you see the AYA and adult, the CEBPA, the FLT3, so the incidence is more or less same in AYA and adult, slightly more some, but the infant and adult, these can be grouped into one group. And if you have to group this, then AYA and adult are similar. So that means the medical oncologists who are trained in treating the adult can handle the AYA also, because we are dealing the adult population, and this mutation is very close to the adult population compared to the pediatric oncologists who are more comfortable dealing with this patient population. So that means the adult oncologists can be able to better handle the AML also compared to the pediatric oncologist. So this is the same which I will skip. So now comes the apart from the treatment, now comes the long-term care. So as we all know that the survival for a overall general population compared to the AYA survivor, definitely the life expectancy. This is mainly because of the development of long-term complication and the second malignancy. So, and this number, fortunately, this survival is gradually increasing because of the better care. So that means we will have a more number of survivors who are going to survive for a long period of time, and then the second complication, like a long-term complication of the treatment and the second malignancy, that number will increase over the period of time. So this is one of the JCO paper which have looked towards the cardiovascular mortality in the cancer, these AYA survivor. So if you read this line, the overall cancer survivor had twofold increased risk of developing severe cardiovascular disease compared to the normal population without cancer. And those who develop cardiovascular disease, they have a 11-fold increased mortality. So as a medicine trained medical oncologist, we are able to better understand the physiology of the cardiovascular function in a patient population. We can be able to understand the physiology and can better manage and refer to the patient population. Similarly, the other toxicity, the pulmonary toxicities, the endocrine abnormality, which we are dealing very commonly. So I think adult medical oncologist is the, and the long-term follow-up requires all these things. Electrocardiogram, which we routinely see, the mammogram for a breast cancer, adult medical oncologist, pediatric medical oncologist have never seen a mammogram, but adult medical oncologist we are seeing so that means we are more trained to tackle the AYA population compared to the so I think so this is the journey, how the patient passes through this population from a TYA to the, so this journey will be smooth when a medical oncologist, adult medical oncologist comes into the picture rather than the pediatric oncologist. So second malignancy, so if you see the data of the second malignancy, the cumulative incidence of second malignancy at 30 years was around 14%, which is a very big number. So 14%, and as an adult medical oncologist, we know what are the symptoms when the patient comes, and we can detect it early and treat it early. So I think it's better that the adult medical oncologist should follow these patients on the. So who are best trained to follow these patients in the future and treat if required for secondary cancer? The obvious answer is the adult medical oncologist. So I think there are three muscles: the pediatric oncologist, adult, and the third is geriatric. So I think at this point of time, they are sufficient, these three, and we do not need a TY medical oncologist at least this point of time. Let's wait. Similarly, so if we have a choice of Apple, Samsung, and the battery phone, So till the time we have enough money to buy an iPhone, that is a TYA trained medical oncologist, we can very well use the Samsung, which has all the functions. In fact, not much difference between the functioning and repair. And the repair of a Samsung phone is much cheaper than Apple phone. And I don't tell about the pediatric oncologist who is in this picture, that he is practically out. So still the time we have enough medical oncologists, enough trained people. I think the adult medical oncologists continue. When we have a more trained person, then we can buy the Apple and we have a money to buy the Apple phone. Till the time Samsung is good enough. So in the end, number of TIA cancer patients is increasing over time, and subsequently the survivor number is increasing. Limited number of trained medical oncologists. TYA are physiologically closer to the adults. Second malignancy can be detected and treated by medical oncologists are better, and the long-term complication can be picked up early and promptly treated by the adult. So we have a problem, then definitely we have a solution also. So what we did in our setup, just sir told that we have already. So the adult medical oncologist can decide a day that we will see the AYE patient in 1 day OPD, once a week OPD, call all those patients who need some more close follow-up. In a journal OPD, it may be different, but divide a day or decide a day that Friday evening, it's the AYE ongoing OPD. So all the AYE come into that OPD, so we can give time. And similarly, for survivor, we can decide a 1 day in a month that last Friday will be the survivor OPD. So the adult medical oncologist can very well fit in the picture. And till this time, we don't need the TYA oncologist and pediatric oncologist. I don't think so in the picture for treating these patients. Thank you. Sorry, madam.
I think I'll just say one statement to Chitalkar sir. Sir, not a fair fight. But still, I'll try my best. Not yet, sir. Not yet. I can't at least do this till ma'am is sitting here. So I think sir has already touched upon the initial part, which might be a repetition for all of you. So definition, it is different in different part of the world, as I've heard many times from Dr. Chitalkar. In India, we say 15 to 30 is the age group. In US, it is 15 to 39 years, and UK follows 15 to 29 years. So we know the burden of disease is high in this age group. Around 1.19 million of AYA cancer patients are there worldwide, and it constitutes, it is 6 to 7 times more cancer patient as compared to the pediatric age group. In India, the data is highly underestimated. There is data from a National Cancer Registry program, which is the collection of a population-based and the hospital-based cancer registry. So what is the pattern of AYA cancer? So now we are talking about, there are two different groups which are mixed in these particular age group. One is the type of cancers which are seen more commonly in the pediatric age group, which are leukemia, CNS tumors, lymphomas, and the other one are the carcinomas, which is more common towards the adult age group, more than 30 years of age. These are the four cancer which actually have the peak incidence during the AYA age group, which is osteosarcoma, Ewing sarcoma, Hodgkin's, and testicular tumor. So if we look at the survival data in AYA, somehow they have slipped through the crack, and we have not made much improvement in the survival of these patients in last 3 decades. We have made tremendous improvement in under 15 years of age, and as well as more than 40 years of age, but somehow this still remains same in this particular age group. So we know that these people have not gotten enough attention which they actually deserve. So what are the reasons for the survival gap in the AYA oncology is, I think they have the different biology and the spectrum of cancer, which is different from adult as well as a pediatric age group. They have a lot of behavioral and developmental issues, which not every center is well equipped to handle. And they are very less represented in the clinical trial. Also, there is provider issue. So, depending on where the patient present for the first time and who to whom the patient presents, the treatment is given according to them and not based on what is the best possible, what can give the best possible outcome to those patients. There are certain issues which are unique to AYA age group, which we don't see in the pediatric or the adult. They have a lot of self-esteem and body image issue, psychosocial issues, which need to be taken care of in a different way. So we learn from where we learn best from our the thing in pediatric oncology. We have made great strides from the in terms of the progress. In early 90s, the survival was less than 20%, whereas nowadays we have more than 80% of survival in pediatric oncology patient. And the reason for success in pediatric oncology, which is different from adult oncology, is I have heard this from Dr. Chitalkar said many a times that military discipline of the pediatric oncology is very inspiring, and we tend to adhere to the protocol. Our children are treated more on the clinical trial and on the same protocol base. Our success is based on the better understanding of the disease biology. So I'll go through how AYA should be treated depending on what regimen we should be used, where they should be treated, whether it's an adult center or a pediatric center, and who should be treating. So ALL is the biggest success story of pediatric, and it is seen almost in the entire spectrum of AYA cancer also. In last 2 decades, we know that since last 2 decades, we know that young adult with cancer patients have done better with pediatric based protocol as compared to an adult based protocols. So these are the comparative retrospective studies. And there was a meta-analysis of AYA patients with ALL treated with pediatric and adult induction chemotherapy. And we have found better outcomes on pediatric-based regimen in terms of all-cause mortality, CR rate, event-free survival, and the less relapse rate. Now we even have a prospective study where an adolescent and young adult patient were treated on completely pediatric inspired COG protocol, and there also we have found an improved overall and event-free survival. So there is no doubt that an ALL patient will do better with a pediatric-based protocol as compared to an adult-based protocols. Hodgkin lymphoma, this is a disease mainly of an adolescent age group. Here we do not have a black and white line where it should be treated with a pediatric or an adult based protocol, but it is more of a guideline say that it should be treated based on the individual risk of toxicity and the center experience. So if you are getting treated by an adult medical oncologist, then better stick to the protocol which they know, and if you are getting treated with a pediatric oncologist, then stick to the protocol which they know. This is a very rare malignancy in adult, but yes, if it's a pediatric malignancy, then a pediatric protocol works better. We have also data based on the treatment center, whether that makes a difference in the care of in the outcome and survival of the AYA. So there's a data from the impact cohort study. It was done in from Canada. They collected the retrospective data from 1992 to 2012, and they compared the outcome difference in AYA treated at the adult center versus the pediatric centers. And they included the 6 malignancy types where leukemia, acute leukemia, lymphoma, NHL, soft tissue sarcoma, bone sarcoma, and testicular cancer. So the outcomes were definitely better for those treated at pediatric center for acute leukemia, Hodgkin lymphoma, and non-Hodgkin lymphoma, whereas bone sarcoma, soft tissue sarcoma, and testicular cancer, there were no difference in outcome. So main reasons for this disparity I think is mainly sticking to the dose intensity which is there by a pediatric oncologist and in a pediatric protocol, and better psychosocial care at a pediatric center. Similarly, in a mature B cell non-Hodgkin lymphoma, the outcomes are superior when they were treated with a pediatric when they were treated at pediatric centers. So we have heard, I think, initial 10 or 15 slide of sir quoted that how busy the adult oncologist is. What is the burden of adult oncology in India? Pediatric cancer, we constitute only 5% of the total cancer burden. So that much time we have. So sir, let us share your burden.
But first get trained in that, then we will give you that.
So I think an adult oncologist, the practice differences, they are a very high volume center. Majority, the less number of physicians treating as compared to the patient. So the limited time is given beyond the immediate medical care. So usually they are, okay, you've come for this, you write down the chemo, get in the daycare, go home. Absence of ancillary supports and usually evaluation of late effect is not so much concerned when we talk about the older patient. In pediatric oncology, we have high staff to patient ratio, large amount of time available for our patient, better psychosocial care because we are used to dealing with such thing. Adherence to dose intensity. So we have to understand that this AYA do tolerate treatment better as compared to the older age group. So even this age dose intensity has to be maintained. And we do not leave our patients. If we are treating the patient, we believe in intact survival. So holistic care, even long-term follow-up and survivorship clinic is better with the pediatric oncology. And I think survivorship care is a well-established specialty of a pediatric oncology for a long now. And because most of the pediatric cancer have a better outcome, so they do we do see a lot of survivors also more as compared to adult. So here we have an edge as compared to the adult oncologist. Thank you.
Thank you. Thank you, Shivani. 1 minute, 60 seconds to Dr. Amit for any rebuttal. I'm counting the time. One judge versus the other judge. Okay.
So I think it is the basic difference between the biology of the disease. So pediatric patient treated in initial phases of the address. So it's not the chemotherapy which is making, it's the disease, their bad biology disease which are not making them the not much amenable for that. So if we, like a Hodgkin lymphoma, now the world is moving towards the CD30, the brentuximab. So it's not that we are not evolving, we are also evolving in terms of the treatment. So the toxicity and long-term toxicity, which I told you, most of the time the second malignancy, if you go to 20 year of age, 20 to 40, most common malignancy is the breast cancer, and pediatric oncologists have never seen a breast cancer. So if you see the number of type of the malignancy which is seen by AYA, it's more commonly a adult malignancy rather than a ped. If you leave aside the leukemia, lymphoma and brain tumor, rest is the adult malignancies.
Okay.
So we will refer adult leukemia and lymphoma to you, don't worry.
Yeah, your time is up. You can take 1 minute and rebut any points you have.
I think let's divide the diseases which are more of pediatric biology. Let us treat them, and the diseases which are carcinomas and epithelial malignancies, you can happily have them.
Okay. Thank you. Now I leave the judges for comments.
I started my life, professional life, with a debate that do you need pediatric oncologist? And I struggled and I saw that pediatric oncology as a separate entity. And but that is very much needed. As Amit has pointed out, that physiology is totally different. And up to the age of 15, their physiology being very, very different. And we always use this tagline as a pediatric oncologist that child is not a miniature adult. So we agree that the type of cancers, the behavior of the cancers, the concept of neoadjuvant chemotherapy, organ preservation, quality of life, survivorship, everything has been encompassed in a holistic care of a child. And that is why pediatric oncology successfully made its presence, correct? Now you have at other extreme, you have adult medical oncology. Now the basic issue here is adult medical oncology is, or adult oncology comprises of three very distinct periods. No, distinct periods. One is AYA, second is the adulthood, younger adult, no, beyond 39, up to 50, and then the real geriatrics with all comorbidities. So that geriatric with comorbidity is exactly at the other end of the spectrum than pediatrics, where in pediatrics you say that more is better and you be aggressive because you have a better chance of survival. So in geriatric, you have a different way of looking at comorbidities and balancing it out with the care. In the middle, we have these two sections, basically AYA and this. Now, AYA, if you go to see, when you count from 15 to 29, the first 5 years, now that is why even Indian Academy of Pediatrics says that the pediatric age group has been extended to 18. So some amount of AYA will go into the real pediatric population. So I don't think it is an adult medical oncology, and then it will be the real medical oncology. So the first 2 decades of life, the cancers in first 2 decades of life are distinctly different from the cancers thereafter. So it is the biology and the type of cancer which really dictates, rather than a pediatric oncologist or a medical oncologist. But you require a ambience and the paramedical care, which are so totally different. Like, so you require, ideally speaking, you require a space for AYA, wherein those which have a pediatric biology like cancers, they are looked after by pediatricians, which Shivani suggested, and those which are adult type are looked after by the adult physicians, and you have a psychologist, clinical psychologist, and the other medical team who is geared, paramedical team, who is geared to the needs of a adolescent and young cancer adult. That is the ideal way of looking at AYA, rather than pediatric oncologist or medical. They have to be happily married into this age group of AYA, looking after together. That is the ideal way of looking after the AYA in my conceptualization over a period of time. Because even I feel that 15 to 18 years, when now I am at SRCC where the age is 18. At Tata whole life, I treated up to 15. 15, I was very, very comfortable up to 15. Some children between 12 and 15 again make you uncomfortable. But most of the children from our rural and semi-rural setups, there you are very comfortable. But between 15 and 18, they make pediatric oncologists uncomfortable. Many a times the counseling and this thing is not very. So though pediatric age limit has been increased to 18, you do need a, so my vision of AYA is not a pediatric oncologist or adult. It is the ambience, paramedical care, and working together for the biology which you understand the best. And that person treats the
soft division of the
hard division. That is my vision.
So I think Vamsi and Shivani, both of you did wonderful jobs, and kudos to both of you. And as Madam suggested, I would also like to say that we do rather than a confrontation, we do a compromise, and we have a joint clinic where adult oncologists also sit and pediatric oncologists also sits. When I finished my training at Tata Hospital and I went back, we didn't have any pediatric oncologists. Nobody was interested from the Department of Pediatrics. And if a patient would come to me, कि डॉक्टर साहब एक पेशेंट को कैंसर है, बच्चा है, तो my first question would be कितने साल का है? And if the answer was 2 years, I would say कि किसी और को ढूंढो, दिल्ली लेके जाओ, बॉम्बे लेके जाओ, मैडम कुरकुरे के पास दे. Above 6 years, as madam is saying, area of comfort, zone of comfort for adult oncologists, above 6 years, I was fine to treat all these patients. So that is one point. Second point, when we train as adult medical oncologists, we rotate to pediatric oncology for 6 months, correct? when Madam trains her pediatric medical oncologist, there's no training into adult oncology.
अब ये start करा
So,
देंगे, madam.
so Vamsi, Amit, you missed a major point over there. So my feeling is that till we change the TYACON to KYCON, kid and young adult, TYACON patients should be treated by medical oncology. No sitting on the fence like madam. I 100% feel that as of today, maybe we will have a fourth category of medical oncologists in 5 years' time. Who knows? The TYA medical oncologists. But till that happens, these patients should be treated by adult oncologists.
Well, my point is, Amit, he in fact based all his premises on the US data, which is 15 to 39, which is a huge gap between what the Indians
Between 15 to
face.
12.
And there was a debate in the first global AY Cancer Congress why it is 39, and they were the US oncologists were actually categorical after 1 hour of debate that it is mainly because they need breast cancer patients, because that's where the trials will happen. That's where the money. Simple. That was the end of. So it's and our Indian consensus is 15 to 29. So that does reduce your maneuverability a little, definitely.
But I think it is more of a concept.
Yeah.
And the paramedical or other help which you need, which is, should be more age specific.
Absolutely.
And the expertise should be as per the, and if you are working with the disease management group, then I think the disease management groups prevail over, like MRD prevails over all the risk factors. The disease management group will
should
prevail over everything.
Yeah.
Like you have a breast cancer, the breast cancer disease management group only has to look up.
Correct.
In an academic institution.
Thank you. And thank you very much for very well done, both the proponents and the opponent. Thank you. We generally agree to disagree, right? Thank you. Rui.
हाँ से मिलके पहचान ही नहीं आ रहे हैं
Moving on to second and last session of today, which is oration on the topic, the art and science of survivorship, for which I would like to invite Dr. Purna Kurkure to share her views with us.
So before we invite the orator of the evening, little bit of preamble is, I think, needed. This is the first oration in which we are doing in the TYACON, and a little bit of background is needed. And it's my pleasure and privilege that this oration is named after my dearest friend, the late Dr. G.S. Bhattacharya, who we lost to COVID 1 year back. And the recipient of the oration is Madam Purna Kurkure, who is my teacher. And I think a little while back, Colonel Chitalkar and myself, we had decided that we should initiate an oration and we should name it in the name of late Dr. G.S. Bhattacharya. So real pleasure and privilege to invite Dr. And we had absolutely 5 seconds of discussion as to who should be the first orator. There was no confusion in either his mind or mine. No debate that the first oration should go to Dr. Kurkure. Over to you, madam.
I feel privileged and honored to give the first oration in the memory of late Dr. G.S. Bhattacharya. And
And I am really thankful to current office bearers of TYACON to give me this privilege. A word about Dr. G.S. Bhattacharya before we start the oration. Fondly known as GS to many and Gaurida to some, was an orator, oncologist, poet, pioneer, philosopher, researcher, visionary, and more importantly, above all this objective, a great human being and a friend to all of us in this fraternity. He was a son of a highly regarded army officer, and Dr. Malhotra's tribute to him has helped me to find out all these facts, which he published in Indian Journal of Medical and Pediatric Oncology. He did his schooling and college from several institutions across the country, MBBS from Calcutta, and finally MD in medicine from the prestigious Tropical School of Medicine, Calcutta. After a brief but impressive stunt as a scientist with the ICMR, where he was very much favored by the Director General then, he moved to Glasgow and he studied hematology and oncology and got his PhD thereof. The urge to serve the country and his motherland brought him back to Calcutta in 1997, where he set up a clinic and started working in the field of hematology and oncology. He had a tremendous academic bent of mind, and this can be judged by his active membership of so many international and national societies and his presence on several advisory board of international and national journals. He was an invaluable friend, always available for help, and he was a great mentor to many young students. Clear-hearted and straightforward. He would not mince the word and call a spade a spade. That was the nature of GS. He's survived by his charming wife Shilpi, and our tribute to him will be to continue to inculcate his fervor in pursuit of science. He was really always out-of-box thinker, and the greatest tribute which we can always pay to him is to think of out of box. And the debate we just had before this oration tells us as to how we can think out of box and still do the very good justice to AYA population in our circumstances. Perhaps that will be the tribute to him. So with these words, I again thank the TYA Foundation for bestowing on this honor on me to give first oration in memory of late Dr. G.S. Bhattacharya. And because of his pursuit for science, we have entitled this oration as Art and Science of Cancer Survivorship. As you can see here, just few decades back, nurse practitioner Karen in 73 said that if someone lived long enough to develop long-term complications, we would jump for joy and treat the complications. Because in 1971, USA declared war against cancer, and we are seeing the outcome of that as ever improving survival. And since the 90s, the mortality has gone down and survivorship has gone up. And this is more very evidently seen in pediatric cancers, where the SEER data shows that overall survival across the board is around 85%, 83.9 means almost 85%. The same is not true for all adult cancers, but AYA, as we all know, is sitting on the fence in between with a very good survival. But because of the barriers in giving the care, even if you consider them as a 50%, still we have a very huge population of AYA cancer survivors and those who are treated as children and now are in this AYA age group. So you have a combination of two population, childhood cancer survivors and AYA cancer survivors who are in this age bracket of 15 to 39 to be looked after and talked about. In past, when the diagnosis of cancer was considered as a ultimatum for death, like it's a time for death, and people who entered Tata Hospital, they were told that now you say Tata to this world, with a very short disease course, because we did not know how to treat them very efficiently and have a better outcome. But at present, the diagnosis of cancer is not equivalent of death. There is a long disease course. You have quite a complicated treatment, which many a times in children to the tune of 85%, and in others at least 50% of the time leads to long-term survival equivalent of cure. Or in the other half, those remaining people, it will have a recurrence and death. So there is a uncertainty, and one has to learn to cope with this uncertain survival, whichever way you go, because time is the only way. Though you can have many predictions, but still which way the particular patient survivor will go is very uncertain. So you have led from the certainty of death to uncertainty of survival. And this is a very elegant essay, which we must all read, by Dr. Fitzhugh-Mullan. And his entitlement of the essay was Seasons of Survival, a reflection of a physician with cancer, in New England Journal of Medicine in July of 1985, where he said that it is as if we have invented sophisticated techniques to save people from drowning. But once they have been pulled from the water, we leave them on the dock to cough and splutter on their own, in the belief that we have done all that we can. Now, this really led to the whole idea of how to look after cancer survivors in general, and led to a momentum. And the seasons of survival, which he spelled out in this essay, was that you have an acute stage where you have a diagnosis and treatment. Then you have an extended stage where you have a remission and maintenance therapy, like in ALL, or maintenance therapy for many other solid tumors also. And you have a permanent stage where you say it is a long-term survival. That is, and in pediatrics and many other embryonal tumor, this may amount to cure, but not necessarily in all. And the final stage is end of life. So everyone knows that end of life is always a final stage, and everybody is destined to die. But this experience of cancer or experience with cancer brings that out very much in front of you as to what is the time when you are supposed to go, and how uncertain or certain you are about that end of life milestone. This essay and further discussions led to this cancer control continuum, concept of cancer control continuum, which has been divided into prevention, primary prevention like tobacco control, diet, physical exercise, etc. Early detection through awareness and cancer screening, leading to early diagnosis, or otherwise, if somebody has not gone through this process of early detection, diagnosis at whatever stage, so tumor staging, patient counseling, and then treatment. Treatment has become multidisciplinary in almost all the patients, though pediatric oncology led the scene by involving chemotherapy upfront in most of the childhood cancer. Today it has become a norm, and now new kid on the block is the immunotherapy, means more of a precision medicine. And this, as you do it more successfully, will lead to survivorship. And then comes the question of long-term follow-up, late effect management, rehabilitation, coping, and health promotion. And those who are unfortunate not to be a survivor, they have an end of life care issue where you get involved with the palliative care team. So this is a cancer control continuum.
which emerged out of this thoughtful article by. So that led to the formation of National Coalition for Cancer Survivorship. It was like a movement, and it was founded in 1986 in Albuquerque, New Mexico, by a group of cancer survivors, which was including Dr. Patty Gans, who became the front runner for survivorship issues in USA. Hastings registered the name as NCCS. This is the oldest survivor-led advocacy organization in the US, governance of by and for cancer survivors. So it is run by cancer survivors, and it is highly respected, authentic voice at the federal level, advocating for quality cancer care for all Americans. And the first National Cancer Survivor Day was held on June 5th, 1988, which happened to be Sunday. And then since then, first Sunday in June is always celebrated as National Cancer Survivor Day. If you go to the cancer survivorship brief history, so the seeds were sown in 1985 by survivor and physician Fitzmullen, who identified the survivorship as a distinct phase of the cancer journey through his article. In 86, NCCS was found, and that converted survivorship from the art to science. In 1995, Imperatives for Quality Cancer Care was first time survivor's perspective was used in defining this quality of care. And so the NCCS contributed to their idea of quality care as a survivor's voice. In 1996, NCI Office of Cancer Survivorship was established. And this is the point where they converted art into a pure hard science. The NCI survivorship priorities are very clearly defined, that one has to do the long-term or late effects of cancer and its treatment, define them, monitor the outcomes, role of behavioral and socio-cultural factors in patient outcomes, understanding genetic risk and treatment, training researchers and disseminating research findings. So these were the 5 priorities which were laid out by the NCI's Cancer Survivors Office. And they defined what is the definition of survivorship. An individual, if you remember that seasons of survival, an individual is considered a cancer survivor from the time of cancer diagnosis through the balance of his or her life. Now, it is not to be considered as a stigma or something to fear about, but that cancer experience itself allows him to go through that cycle of 4 seasons of survival. This is a definition which has been adopted by NCCS and by NCI Office of Cancer Survivorship. But disease-free survival for at least 2 years after cessation of therapy or 5 years after the diagnosis, they are considered as a long-term survival. So 5-year disease-free survival has become the very standard way of looking at the efficacy of all treatment protocols in oncology. And the mission of survivorship program is to address the outcome of cancer and its therapy and improve cancer survivors' health and quality of life. So it is not only the outcome of cancer, but also improve the survivors' health and quality of life through integrated programs in patient care, research, prevention, and education. So all these are the part of the survivorship program. As of 1st January 2022, there are 18.1 million cancer survivors in United States. And SEER has brought out these projections that how the cancer survivors population is increasing day by day in all the age groups. And as you can see, at 18.1 million, they are under 50. And by 2040, they are supposed to double up, almost 75% increase to 26 million. So this population is going to be always growing population. And as depicted here, these cancer survivors by the current age, they fall into this 0 to 19. That means so-called pediatric 1,19,000, 1,19,000, and 20 to 39 are 6,36,000. So two put together will form the AYA population as by the US definition. So it's 6 times almost than the pediatric population, the 20 to 39 population. And this transition of children who are childhood cancer survivors and moving into the age group of this bracket, 20 to 39, and survivors of cancers in this age bracket, there has to be a transition from pediatrics to this age group. And transition has been clearly defined within the healthcare as a purposeful planned process that addresses the medical, psychosocial, and educational, vocational needs of adolescent and young adults with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare system. This is true with not only oncology, this is true with all chronic conditions like renal conditions. Same is true with endocrine and like diabetes, juvenile diabetes mellitus, chronic renal diseases. They all have to transition to the adult care. And this transition is a process to hand them over to the adult medicine counterparts. So by the year 2020, these are the projections for pediatrics, childhood cancer survivors. Number will exceed 500,000. One of 530 young adults between 20 to 39 years will be childhood cancer survivors. So it is very common phenomena in a gathering of 500 plus. You will always have somebody who is a childhood cancer survivor. No such definite estimates can be made, but some approximation of around 50,000 new pediatric cancers in the country with not everybody getting the treatment, appropriate treatment and in the network for being survival. At a conservative estimate of even 20% survival, 10 to 12,000 survivors can get added to our population each year. So that is a big number if you really go to see. And consequences of cancer survival are manifold. It is a physical, anatomical, or functional changes due to the surgical ablation like limb or amputation or enucleation, organ toxicity, morbidities that lead to premature onset of chronic illnesses, which is a very important point, like cardiovascular diseases, diabetes, metabolic syndromes, all of these chronic illnesses which really hamper, they cause more comorbidities and hamper quality of life. They become more psychological disturbances, socioeconomic burdens because of the above, and increased risk of second malignancy, which happens anywhere after 8 to 20 years in most of the situations. So they are in this age group, age bracket of adolescent and young adult. So there is a little very clear definition between a long-term and late effects. Now, long-term effects refer to any side effects or complication of treatment for which a cancer patient must compensate, also known as a persistent effects, and they begin during treatment and continue beyond the end of treatment. The classical example is neurotoxicity of many of the our chemotherapeutic agent like oxaliplatin or cisplatin. They continue though you never reach normal. You are near normal but never normal. While the late effects refer to unrecognized toxicity that are absent or subclinical at the end of therapy and become manifest later with the unmasking of unseen injury because of any of the following factors. Basically, it is due to the developmental process, failure of compensatory mechanism with the passage of time, and organ senescence. Now, the classical example is that Wilms tumor, you do nephrectomy, and most of the children will go through anephric, one kidney. Many of the normal children have one kidney and they survive. But due to whatever reasons, some of the Wilms tumor long-term survivor can land up with a decreasing renal function and land up with the problem. Organ senescence, the classical example being the cardiovascular diseases as a part of the Hodgkin's disease treatment, in which you use radiation and alkylating agents. So the cardiovascular diseases onset is a decade earlier than the normal population. Thus, the late effects are not direct cause-effect relationship, but it's an interplay of host factor, tumor factor, and treatment factors. And they decide as to how a particular survivor will have a late effect or will not have a late effect. At the same dose of drugs, one person will have a late effect, like a cardiotoxicity due to anthracycline, other will not. So what is that? And so much of research is going into that direction as to find out about genetics, premorbid conditions, existing premorbid condition at the time of exposure, and subsequent health behaviors which the survivors have, which contribute to these late effects. We are all very familiar as a practicing medical oncologist that we have acute toxicity, which are well documented, can be anticipated. You have a highly hematogenic drug, no MS's drug, and so on. So you can anticipate whether you will have those acute toxicity or not, and can be, generally it is offset by periods of good health between the two cycles. While late effects are generally identified, recently identified entities in late, I would say last part of the previous century, and now more and more understanding is coming up. Many could not have been even anticipated. And once it sets in, it can compromise health over entire lifespan. A long-term follow-up program should include at least a single physician. Can you have a water? At least a single physician interested in late effects. It is the dedication, interest, which is more important. A champion for the cause, a nurse or a nurse practitioner who is going to head the team. So if you don't have a champion for that cause, you are not going to be successful with any of the following. That is nurse or nurse practitioner coordinator, a dedicated time and place. And getting a dedicated time and place is the most important but most difficult thing in a very busy place. Like in TMH, I know I have moved my ACT clinic at some 6 to 7 places before they recognize that as an entity in a fixed place. So getting a place and a dedicated time is very, very important. At least 2 follow-up clinics a month. That should be the volume for of the survivors to have the meaningful data, means meaningful ACT clinic, follow-up long-term clinic. Comprehensive care and screening for late effects based on the survivor's treatment, means organs at risk, referral to appropriate specialist and wellness education. So these are the important component. And with this in mind, we had started this after completion of therapy, ACT clinic for childhood cancer survivors. Excuse me. Based on the model at St. Jude Children's Hospital. And it is very popularly now known all over the world as ACT Clinic. And that time I was really fascinated by the word ACT, which says that act beyond therapy to achieve cure in its true perspective. And this I had seen and witnessed, and somehow was fascinated, and we could start that in a very modest way in February 1991 at Tata Hospital, with the objective of monitoring growth, development, and sexual maturation of survivors, to monitor late effects of therapy, to address their psychosocial problems of the survivors, rehabilitation for useful productive adulthood, and to provide feedback for future protocol development. Like whatever you learn, they are not the mistakes, but it is a learning process that how to modify your future protocols to minimize this late effects. And it was a multidisciplinary team approach where a pediatric oncologist works in tandem with clinical psychologist, medical social worker, and there is an interaction with array of healthcare professionals which is required depending on the organ at risk. And from day one, we said that it should be service-oriented clinic and not just the end result analysis clinic. We need to find out a solution to the problems that we see. That was a commitment when we started this clinic. So these are the points which we do evaluation every time in ACT clinic. Summary of disease and treatment is defined. History of intercurrent illness, measurement of height, weight, and growth charts, assessment of pubertal development, cardiac monitoring, 2D echo, means organs at risk are screened appropriately. Not all investigations are done for all the survivors. Depending on what is required, only is done. And a good examination is done to see for the relapse or the second malignancy. Assessment of neuropsychological and psychosocial status is an integral part of this evaluation and very, very important. Counseling for the risk reducing lifestyle changes are done during this sessions, and everybody is told about premarital counseling in general and fertility in particular. The psychosocial evaluation involves scholastic performance, psychosocial problem, employment and marital status, and rehabilitation status. Consider, and the follow-up care has to have the physical, psychological, emotional care while you are addressing the late effects. Health risk behavior. Some survivors, they do have the health risk behavior, and their educational, vocational rehabilitation and empowerment needs to be looked at, and the family support has to be created. The medical late effects are graded as per the literature into 0 means absent, 1, 2, 3, and 4, depending on the severity, which are well defined. I will not go into the detail. As of now, current analysis at Tata Memorial Hospital, they have registered 3,600 survivors in that clinic, of which 2,411 are into the age bracket of more than 15 years, which forms around 67, 2/3 of them. And male to female ratio has always been skewed towards male, 2.5:1. Hodgkin's and solid tumors are almost equal. You are more now, 1.7:1. Mumbai, non-Mumbai, like we have a lot of patients from outside, so naturally they are from outside Mumbai, and that is why all rehabilitation and other efforts we will have to think as to how we can take care of the survivors when they are not in Mumbai. Median age at diagnosis was 8 years when they were diagnosed, and the current median age is 20 years. And time since cessation of therapy has been 12 years. So it's a very mature data. Most of the survivors being followed up for at least a decade, and median duration of follow-up is 12 years. As you can see, only 2.2% is an attrition death in this population. So the attrition due to various reasons are minimal, 2.2%, but mainly it is due to the second malignancy and a very late, very rarely, but late recurrence of the original malignancy. Either of the two, that is the thing. The deaths due to late effects we have not yet seen, because many of them may be dying at home, survivors, without our knowledge, as a sudden death, unknown cause. And then each of them are given the medical summary of treatment and recommended plan for follow-up. You commit to them, and every time they come, you give them the Xerox copy, means copy of the today's decision, because they are everywhere in the country. They are moving on with their education. So they must have some document for the attending physician to understand what is happening to them. So this is called passport for plan for health. They are told that you should carry this very, very safely wherever you are. And if you have any medical problems, you have to show this first for the doctors to understand. This provides all the details, problems which the survivor may face, preventive care recommendations, psychosocial concern, if any, and recommended referrals. Because all of them are not able to stay in Mumbai and do this. This is an ongoing process. So benefits of survivor care plan is psychosocial distress can be addressed. Cancer, like they feel more empowered. Survivor will feel more empowered having a document in the hand to say what they have and interact with their caregivers wherever they are. Cancer recurrences can be caught early. Preventable conditions may be avoided and potentially lethal late effects may be averted and thus improving the quality of life. So these are the advantages of survivor care plan, and each survivor should have that document with them. Now, challenges which survivors face. How do they identify risk and problems? Do they consider them seriously? Who will assess their cancer-related concerns? Will insurance covers for screening, follow-up, diagnostic test, care? Who will cover all this? Because the cancer treatment is over, so the help has stopped. How would they manage the ongoing medical care? And many of the survivors, they face this issue of even getting the mediclaim for non-related things. Even accidents are not covered because they don't get the mediclaim. So that is a big problem. How do they find a specialist who will take their concerns, symptoms very seriously? And the only way is to popularize this survivorship care plan and make our colleagues aware of this problems of a survivor and what resources are available for long-term survivors. I think there is a volume of literature in the Western world. And I think that is the area which we have to concentrate and come up with as to what is available and what can be developed. So this is the time when they require someone's assistance, they feel. A helping hand from someone amongst them. So, and this was a genesis of our survivor support group, UGAM, when they interacted during SIOPS 2007 at Mumbai, and conference with then it was called ICUPU, now it is called CCI. That time it was known as ICUPU, and as you can see, our survivors are interacting with the support group of SIOP, and that inspired them. This is a post-SIOP session which we had, and they all said that they need to come together, and they formed this support group called UGAM. And vision which was kept in mind was to ensure that every childhood cancer survivor finds his or her way to celebrate life after winning battle with cancer, and to facilitate the life's journey on correct path and in right direction. So this was the vision with which it was formed. Thus, the ACT clinic, which we started in 1991, after almost 2.5 decades, it was started in pediatric oncology unit, but the whole evolution takes place after you have this whole ancillary collaboration put in place, and it became a really holistic model for a survivorship clinic. So it went from the late effect clinic, it has now become a survivorship clinic. And we created this model for survivorship program where you need to address both medical and societal needs. UGAM brought out these survivors from the walls of hospital into the society and made them realize the need for looking at them differently. So this model is very, very important, where you look after the late effects and the medical problem within the ACT clinic. For example, ACT clinic at Tata Hospital, which we started. And then you have a societal support, that is UGAM, which was registered under Indian Cancer Society. So this societal support is equally important. So we realized after doing this that survivorship issues in India are not channelized through structured survivorship program. But this is the model which we should have. We cannot have only survivors model because we don't have a medical network so tight to take care of these medical needs of the survivors. So we should have things going hand in hand, parallel, so that both the things are taken care of. You just take care of the psychosocial needs without taking care of medical care. That is not good. And you just take care of medical issues and not look after their psychosocial need also is not good. So we need to have this both components of the survivorship care program. So we realize that survivorship issues in India are not channelized through structured survivorship program. There is no national or state level policy that addresses employment and health insurance problems faced by cancer survivors. No database to measure the outcome of cancer, and it requires more funding and support structure. And that is why association with non-governmental organization like Indian Cancer Society was very apt and appropriate. Through the survivorship vertical of Indian Cancer Society, we started this project Picasso, taking that model in mind, that is partnership in cancer survivorship optimization. And the objectives which we are kept in mind is to decrease the loss to follow-up, increase awareness of late effects and monitoring for early detection, encourage the disease-specific support groups, and to improve the quality of lives, and to integrate survivors into mainstream of society. And the methodology which we have adopted is to partner with hospitals to facilitate formation of ACT clinics and to develop the psychosocial and rehabilitation module. So Indian Cancer Society invests by way of giving the help through clinical psychologists and facilitating this psychosocial component of a person who is interested. A pediatric oncologist has to be interested in having a ACT clinic. Then only there is a point in having the partnership. So there has to be a commitment from a pediatric oncologist with a good volume of cancer survivors with whom we partner and provide the clinical psychology. So through this survivorship activities, we have partnership, we have created ACT clinics, we have empaneled 12 hospitals. We started in Mumbai only, where we first empaneled Vadia and Sion. And then later on, when SRCC crossed 5 years of existence, we have enrolled SRCC. And in other cities like Delhi, Bangalore, Chennai, we have already, and schemes in Jammu and J&K, they said that they need a help. So, and they are committed to that. So it is a champion for the cause who has to be there to drive the whole matter forward. To this, we said that if you find the problems, then we have to give a solution, because that was our commitment to begin with. So we created Dr. DJ Jasawala Educational and Vocational Skill Fund in Indian Cancer Society. We have supported 300 survivors. 72 have completed milestones. Like, we don't give one-time fellowship. We define their milestone and we take them through and through their journey and support them till they reach their milestone. Some of them have become doctors, engineers, nursing, pharmacy, and vocational. Many other vocational courses have been taken. The psychosocial counseling at ACT clinic not only provides the counseling, but also the career guidance. There is a career counseling also. And if somebody has not taken a right path, then we suggest them that instead of this, you go on this and we'll support you for. So change of paths have also happened, because many a times survivors may not have the correct guidance as to what is good for them. Late effects, if we have found out, then how to correct the late effects. Like we all know, growth hormone replacement, endocrine, hearing aid, orthopedic corrections, neuro rehabilitation, they are so difficult and expensive. So we have created a late effect fund, which is in the pilot stage. And so far we have supported 5 survivors with endocrine growth hormone replacement and so on and so forth. But this is a new field into which we have entered, and we are committed to do that. And the support group, Ugam, is the example. And we are encouraging our partners to form the support groups locally and take it forward. Byju's, after knowing us, our work and rehabilitation, they have provided free access to Byju's learning app. And those licenses have been given out to these survivors who are going to ACT clinic. So we have kept this as a strict discipline that you have to have ACT clinic, you have to attend, come for follow-up, get yourself tested, whatever your needs are, we are there. But you have to follow a disciplined pathway and reach your milestones. That is the way it is. So I will end by this statement of Sir William Osler. The good physician treats the disease. The great physician treats the patient who has the disease. So I think it's a good time to change our concept of not only treating the disease, but treating the patient with the disease as a whole. And as I said, we have expanded and we are partnering with others. So together, I think only that is the only way to go forward and we can create miracles. My personal acknowledgement to Dr. Maya Prasad, who is now looking after and taking the legacy of ACT clinic at Tata Hospital and adding the knowledge base in this direction, and Dr. Vanna Dhammankar, who is in charge of survivorship program at ICS. They are my two hands. I'm just in between thinker, but they are my hands. Thank you.
Thank you, ma'am. I think we have no words to express gratitude, appreciation, faith, and in your continued leadership of this movement. And I mean, it's a 4-decade-long journey, I guess, and you brought it out very, very beautifully. And in memoriam of and Dr. Bhattacharya. So it's a great moment for TYACON Foundation and for all the things that we wish to do for young people. In appreciation of your oration, we have a small token of gratitude.
You are a survivor and a fighter. Embrace your spirit. Keep faith in your pocket. Laugh. Laugh a lot. Indulge in confidence. Grow with each tear. Breathe in positivity. Remain gorgeous. Always remember, you are loved. Have hope. Never give up. With this, we come to the last session of the day, which is an open house for survivors. And I call upon Dr. Savita Goswami, Professor of Psycho-Oncology, Tata Memorial Hospital, Mumbai. And, okay. And co-chairperson, Dr. Captain Ritu Biani, dental surgeon, adventure and motivational speaker, breast cancer warrior.
चाहते Okay. Okay. Let me just start calling Mr. Ashok Thorve, who is from Mulshi. He had अशोक को जब वो 9th स्टैंडर्ड में था, अशोक का ये पहली बार है। जब वो 9th स्टैंडर्ड पास हुआ था तो मुर्शी करके एक पुणे के पास एक छोटा सा गांव है, और बस 9th 10th स्टैंडर्ड की समर वेकेशन में मस्ती मार रहे थे, गर्मी में खेल रहे थे, कूद रहे थे, और नदी में स्विमिंग कर रहे थे, और तब उसको बुखार हुआ था। उसकी बात की कहानी वो ही बताएगा, और ये उसका पहली बार है, एंड ही इज एक्चुअली अ वेरी स्मॉल टाइम फार्म वेजिटेबल वेंडर। तो बाकी वो बताएगा। अशोक। थैंक्स संदीप।
नमस्ते आदरणीय मंच, टाइकन टीम।
अशोक का मराठी इज मच बेटर, तो वो थोड़ा मिक्स करके बताएगा, और आप जैसे अपने मन में बोल दो।
थोड़ा हिंदी और मराठी मिक्स हो जाएगा, समझ के लेना थोड़ा। ये पहली बार है बड़े कॉन्फ्रेंस में बात करने का, तो यहाँ पर सबका अभिनंदन। ये टाइकन टीम और हाईवे इंजीनियरिंग और अपना चितलकर सर, डॉक्टर चितलकर सर, बिंदु मैडम, और मेरा जर्नी थोड़ा सा बताता हूँ आपको। थोड़ा ये क्या है, बात थोड़ा मराठी और हिंदी में जरा सब देख के ना, क्या थोड़ा ये होगा बीच बीच में। हाँ नहीं बोलतो मी, थोड़ा हिंदी मिक्स करून बोलतो तरी 2009 साल के 2009 में मेरा ट्रीटमेंट चालू हो गया। उस टाइम समझ में आया कि मेरे को ल्यूकीमिया है बीमारी। तो 2 साल ट्रीटमेंट चालू हो गया मेरा पूना में रूबीवाल। तो उधर डॉक्टर पद्मज कुलकर्णी वो मेरे डॉक्टर थे। तो हमारा फाइनेंशियल कंडीशन इतना नहीं था उस टाइम। पिताजी अपना फार्मर थे, खेत का काम करके हमारा गुजारा चल रहा था उस टाइम। वो ट्रीटमेंट डॉक्टर ने बोला कि इतना ट्रीटमेंट है, कीमो है। उस टाइम लोगों को मालूम नहीं था, उस टाइम 2009 साल में, कि गांव में पहली बार वो मालूम पड़ा कि कैंसर क्या है। उस टाइम पिताजी को भी मालूम नहीं था ये क्या चीज है। तो उन्होंने बोला ठीक है हम ट्रीटमेंट करेंगे, मतलब ले लो। हमने क्या रूबे हॉल में शिफ्ट कर लो। ट्रीटमेंट चालू हो गया। फाइनेंशियल छोटे छोटे ट्रस्ट थे उधर। इनकम सर्टिफिकेट अपना रहता है, तो इनकम सर्टिफिकेट देख के किधर ट्रस्ट वाले को पैसा उधर से आने का, ये पिताजी ने सब किया। एक दौर था कि पिताजी के पास थोड़ा पैसा कम कम, फिर पिताजी ने अपना जमीन आधे से ऊपर जमीन बेच डाला उस टाइम। ये करते करते समय थोड़ा चौथा साइकिल, पांचवा साइकिल। एक दिन ऐसा था कि चौथा साइकिल को मेरे पिताजी के पास पैसा नहीं था, और घर का सदस्य हम मानते थे वो बैल। तो उस दौर में पिताजी ने अपना बैल बेचा था। उस रात को पिताजी को इतना रोते देखा ना तो अभी भी याद आता है पिताजी का। थोड़ा इमोशनल हो रहा है, मैं सबको बता रहा हूँ आपने कहा। थोड़ा आगे जाके अपना ट्रीटमेंट भी अच्छी तरह कवर कर लिया, उसमें हो गया, सबने मदद की। वापस मैं अपने सर के बारे में थोड़ा बताना चाहता हूँ। पद्मज कुलकर्णी, डॉक्टर पद्मज कुलकर्णी ऐसे थे। उनकी वजह से मैं इधर खड़ा हुआ। उन्होंने 40% जो ट्रीटमेंट किया है, आणि 60% उन्होंने प्रोत्साहित करते थे हर बार। ऐसे प्रोत्साहित करते कि हो जाएगा, कर लो। आणि मैं उनका हर बार हर कीमो में जाता था ना, उनका इंतजार देखते, सर कब आएंगे, मेरे को कब ये करेंगे। कैसे मेरा तकलीफ दूर होता था उनसे बात करके। इन्होंने इतना भारी मतलब ट्रीटमेंट दिया ना उस टाइम। तो ऐसे करते 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 मेरा ट्रीटमेंट पूरा हो गया। 2 साल 2011 में पूरा होगा। 5 साल फॉलोअप में रहा सर के। फिर 2015 में मेरी माँ को भी बीमारी हो गई, 2 साल उनका ट्रीटमेंट सर के ही पास हो गया। तो घर वाले, मैं अकेला था, सबके सामने मैं सोचा कि माँ के सामने शादी कर ली। मेरा 3 बहनें थी, 2 बहन की शादी उस टाइम हो गया, 2012-13 में उनका शादी हो गया। तो रहे पिताजी, मेरी माँ। तो माँ के सामने ये फोटो है कि उस टाइम जनवरी में उनका ऑपरेशन हो गया, मई में मैंने शादी कर ली उनके सामने। तो यही महीने में 4 सितंबर में वो गुजर गई, मेरे 5 साल हो गए पूरा। तो ऐसे करते करते माँ का आशीर्वाद, एक बेटी हो गई पहली मेरे को 2018 में, 2020 में मेरे को लड़का हो गया। और मैं अकेला जिम्मेदारी लेते लेते बहन को पुलिस भी कर दिया। जो माँ का स्वप्न था कि कुछ बन के दिखाए। ये मेरी बहन है। ये सबसे छोटी बेटी है, ये और एक बेटी, तीसरा बेटी है। ऐसे हमारा फैमिली बढ़ गया और मेरा 14 साल का अभी तक चल रहा है। तो धन्यवाद कहता हूँ टीम टाइकन को और रितु मैडम को, जिन्होंने मेरे को इधर बोलने का ये दिया, प्रोत्साहित किया बोलने का, इधर आने का। तो धन्यवाद, थैंक यू।
अशोक से एक बात पूछनी थी। और अशोक, मुझे ऐसा लगता है कि आपने दिल से बोलना चाहिए, सच्ची सच्ची बोलना चाहिए कि 9th स्टैंडर्ड के बाद के 2-2.5 साल आपके ट्रीटमेंट में गए, फिर फॉलो अप्स हुए, फिर माँ बीमार पड़ी, फिर माँ का थोड़ा सा रिस्पॉन्सिबिलिटी आ गया क्योंकि फादर भी थोड़े अपसेट हो गए थे उनके। फिर शादी हुई क्योंकि वो शादी 21 साल में करनी थी, फिर एक लड़की, फिर लड़का, फिर एक लड़की हुई। और आपने मुझे बताया कि आप सब्जी, पाले भाजी जला मानते हो कि द ग्रीन वेजिटेबल्स, नॉट पूरा सब्जी का ये, वो ये बेच के आपको गुजारा होता है। तो आपकी जिंदगी वैसे देखा गया तो ट्रीटमेंट और रिस्पॉन्सिबिलिटी में बहुत बहुत बिजी रहा। तो कहीं कुछ लगता है क्या तुला असं वाटतं की तुझ्या मराठीत सांगितलं तरी चालेल?
जो 2009 में जो मैं खेलने कूदने का जो टाइम था, उसी टाइम बीमार गिर गया। वापस कॉलेज टाइम, ये टाइम जो घूमने का फिरने का वो जो रहता है कि वो फैमिली का बैकग्राउंड ये, फिर 2015 में वही बात। मतलब ऐसे 14 साल में पूरा जिम्मेदारी घर को चलाना है, चलाना है। पर मैं खुश हूँ, पीछे का छोड़ देता हूँ और आगे का सोचता हूँ। आज का सोचता हूँ, आगे क्या होने वाला मालूम नहीं है। आज का अपन हंस के खुल के जो बोलते हैं ना, अपना ये करने का। ज्यादा मैं अपसेट, मतलब पीछे का बात सोच के बैठेंगे तो अपन फिर अपसेट हो गए। आणि इधर आके ना वो अपने डॉक्टर चितल को, वो क्या है, वो टाइकन टीम, वो इधर आके मेरे को इतना अच्छा लगा ना। तो इनका हाईवे हाईवे इनका हाईवे, डीजे सर का डीजे सॉन्ग है और उमंग का दे उमंग लाते संग में, ये सब मिलके इधर मेरे को, मतलब सबका अलग ये सेवा है। मतलब अच्छा लगा है उनसे मिलके। संदीप सर है, प्रीति मैडम है, अपनी मैडम है, मुझे कुछ बताने के लिए वो अच्छा लगा इधर आके। और आपसे बात करके भी पहले है स्टेज पर सोमन अपन कैसे, ये 14 साल का युद्ध, कैंसर युद्ध मैंने लड़ा है और लड़ाई जीत ली है। पर क्या है, अपन स्टेज पे जाते हैं तो अपन भाषण करते तो किसी, ये 26 जनवरी 15 अगस्त उसका भाषण करते, पर खुद का भाषण करना है पहले बार। हाँ, तो अच्छा लगा। अपने बारे में अपन बात करेंगे, अपन सबका भाषण करते उस टाइम 26 जनवरी में, 15 अगस्त महात्मा गांधी का करते, इनका करते। चलो अपन भी योद्धा है ना, कैंसर योद्धा है ना, लड़ाई तो जीत ली ना, कौन सा भी लड़ाई रहने तो लड़ाई जीत ली ना। तो अच्छा लगा आने के बाद, और धन्यवाद देता हूँ। फिर वापस डॉक्टर पद्मज कुलकर्णी का नाम लेता हूँ, उनके वजह से ऋतु मैडम मिली आणि ऋतु मैडम से वजह से आप मिले। तो आणि सर ने सच में एक बात बताऊं मन की, तो तकलीफ तो होता है उस टाइम, जो दौर रहता है, जो पेशेंट उस टाइम तकलीफ, मतलब बाल जाते, ये हो जाते, वो हो जाते। पर मैं ऐसा था उस टाइम पेशेंट, अभी भी रूबी हॉल में स्टाफ है, सिस्टर है, वो है। तो कभी भी जाओ उस टाइम है ना, लड़के मतलब जो कोई भी पेशेंट एडमिट होने जाओ तो सिस्टर बिस्टर मेरे को पहले वो उधर बुलाती थी कि आंसू के पास इसको लेके जाओ जरा, वो बताएगा। क्योंकि सलाइन लगाया, केमिकल लगाया, इधर का नस भी गया मेरा पूरा, नस आईसीयू में भी था। पर
कब खत्म होता है, कब मैं बेड से निकल के मैं बालकनी में उधर जाके बैठता हूँ। सबको अच्छा लगता था ये कैसा पट 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 पट, मतलब डॉक्टर भी मेरे को इतना, स्टाफ भी बोलते थे कि दूसरे डॉक्टर के भी पेशेंट थे तो सिस्टर बोलते थे नहीं आशु के पास जरा उनको बात कराओ, ये वो ऐसा उसको पटाके वो तो खाना वो कुछ तो ये करेगा, इंजेक्शन लेगा तकलीफ नहीं हो जाएगा। मैं ये सब बात था, वो साल 2 साल कैसे गए ना, तो अभी तक सब याद है यानी जिया है और जिएंगे। चलिए क्या बहुत टाइम लिया आपका। स्टार्टिंग में जब मैडम से अब तक महीने भर, हाँ
मैं उसको एक हफ्ते पहले
हाँ
घर पे बुलाया, पहले उसकी स्टोरी सुन ली पूरा। डॉक्टर पद्मज की पेशेंट्स को मदद भी करते हैं, डॉक्टर पद्मज फ्रेंड भी है, मदद भी करते हैं। और कर्नल चितालकर ने बोला भी था कि क्योंकि इन लोगों को ज्यादा पता रहता है डॉक्टर्स के पास कितने पेशेंट है, हमारे पास तो पेशेंट की वही लिस्ट है जो हमसे पैसे की मदद मांगने आते हैं। तो इसलिए मैंने सोचा कि बिकॉज टाइकन अभी इतना अच्छा काम कर रहा है ना, और मुझे ऐसा लगता है कि भारत के हर कोने कोने में से कोई ना कोई हर एक इसमें आना चाहिए। क्योंकि मैंने संदीप को देखा, मैंने प्रीति को देखा, मैंने आई एम सॉरी मैं काफी लोगों के नाम भूलते गई हूँ, पर मैं ये भी चाहती हूँ कि आपके साथ साथ और भी नए नए लोग आए, और ताकि ये कि ये जीने का ये जो ये अंदाज है ये हर कोने कोने में पहुंचे और सिर्फ कुछ लोगों तक सीमित ना रहे। तो हाँ, तो इसको है ना मेरे बारे में इम्प्रेशन थोड़ा ज्यादा काय तुला काय वाटलं होतं सांग ना पटकन, कारण का मला तिला बोलायचं। बोल ना, बोल उसमें क्या, बिंदास बोल। हाँ? तू म्हणाला ना की मी अशी खूप सिरियस वाटायची।
स्टार्टिंगला भेटलो तेव्हा आहे ना हे असं कन्फ्युज मध्ये म्हणजे यायचे, ट्रेन मध्ये पण विचारलं काय कुठल्या टेन्शन मध्ये आहे का ते आहे का, म्हणजे असं एकदम त्यांची पण कहाणी विचारली किंवा काय झाले तर मॅडमला पण मी विचारलं, म्हणजे विचारू का नको पहिलं विचारलं होतं त्यांना, जास्त टेन्शन मध्ये काय राहता कन्फ्युज का होता, तरी बोललो होतो कंफ्यूज लग रहे थे। खुल के बोलने का अभी जी अपने संदीप सर है, कल से आके मेरे को नींद भी नहीं आया था, सुबह से ऐसा था, पर अभी उन्होंने ऐसा खोला दिया तो उन्होंने एक बार भी अच्छा एक बात बताया कि भाषण करने जाओगे ना तुम कि बंदूक है, बंदूक की गोली मारोगे तो गोली नहीं पड़ेगी तो खोल के मत नहीं देखने का, तो चाकू बिकू कुछ भी मारने का आगे जाने का। वो खोल के देखेंगे ना फिर क्या है। हाँ अच्छा मुझे सब मिले, वो शिवानी सब 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 दोस्त बन गए सब।
मेरा आपसे एक क्वेश्चन है। हेलो अशोक, मेरा आपसे एक क्वेश्चन है।
हाँ
अभी आप बिल्कुल ठीक हो गए हो,
हाँ,
ठीक है, आप देखते हो कितने सर्वाइवर्स हैं
हाँ,
जो जगह जगह जाके हेल्प करते हैं, ठीक है ना।
हाँ,
तो आप ऐसा करोगे अपने गांव में या आसपास के लोगों के साथ में, अगर आपको पता चलता है कोई बीमार है
हाँ,
या उसको ऐसा प्रॉब्लम है तो आप उनकी मदद करोगे?
हाँ करूंगा।
कैसे करोगे?
उनको मतलब अभी अपना टीम कैसे काम कर रहे हैं उनको जरा मदद, क्या मदद लगता है क्या नहीं, फाइनेंशियल क्या मदद है, कौन से ट्रस्ट है क्या है। हमारे पुणे में भी है ना मेरा पहला जो पिताजी और मामा उस टाइम में हमल का काम करते हैं, हमारा गांव था मुलसी से हम पुणे गए थे ट्रीटमेंट करने के लिए, तो मामा मेरे हमल का काम करते थे, पिताजी को मालूम नहीं था। उस दौर ऐसा था ना कि पैसे की बहुत कमी थी, और है ना ट्रस्ट हमारे जो सोशल वर्क रहते हॉस्पिटल में उन्होंने एक चिट्ठी देते हैं कि इधर इधर जाओ अपन सिद्धिविनायक मुंबई से भी आया था, टाटा ट्रस्ट हमारे जो मुलसी में रहता है वो टाटा ट्रस्ट का है उधर डैम, तो उनका भी मेरे को 90,000 का उस टाइम चेक आया था। पर फर्स्ट टाइम जो मेरे को 2,000 का पहला स्वामी समर्थ अक्कलकोट का 2,000 का चेक आया था। मिलते मिलते सब मतलब अपन अच्छे तो सब मेरे को सब है ना रुका नहीं ट्रीटमेंट कभी मेरा कि पैसा।
हाँ, तो इसीलिए मेरा कहना सिर्फ यही है कि आपको जितना हो सके आप लोगों की हेल्प करो। आपके पास नहीं है, हम जानते हैं, जैसे आप रितु मैडम को जानते हो, रितु मैडम डॉक्टर चितालकर सर को जानती हैं, तो इस तरह से लोगों की हेल्प हो सकती है। संदीप इतना अच्छा काम कर रहा है, तो आप किसी से भी कांटेक्ट करके, ये रुकना नहीं चाहिए क्योंकि आप इस दौर से गुजर चुके हो, तो ये रुकना नहीं चाहिए कि जो भी आपको अगर मिलता है कोई ऐसा कि जो बीमार है या जिसको हेल्प की जरूरत है तो आप जरूर हेल्प करें।
चलेगा
कनेक्ट करना
कनेक्ट, हाँ चलेगा, कनेक्ट लोगों से भी करूंगा, सर का भी नंबर ले, सबका नंबर भी लूंगा जब प्रोग्राम होगा। अभी ऋतु मैडम भी है, वो भी बताएंगी अगला कार्यक्रम क्या है, किधर है, तो मदद रहेगी मैम। आणि पुणे में भी ऐसे ट्रस्ट है जो गोलियां देते हैं, उधर से कुछ दाल देते हैं, चावल देते हैं, मतलब है। हाँ, सपोज टीम उधर भी है पुणे में, मतलब करते हैं। तो पहली बार इधर आया तो कर लूंगा, मतलब आप बोले कर लो। थोड़ा मराठी mix है। ओके चले, ओके, थैंक यू।
बहुत सही सर।
ओके, अभी हम पलक को बुलाए, मिस पलक। पलक के बाद यश साहू और यश यादव तैयार रहना।
Hello everyone. Hello everyone. My name is Palak Ragvanshi. मुझे इविंग सार्कोमा था 2019 में, जब मैं 10th स्टैंडर्ड में थी। और मेरे डॉक्टर राजेश सर हैं, और बाकी मुझे सभी का बहुत सपोर्ट मिला ट्रीटमेंट के टाइम। मतलब सर का भी बहुत सपोर्ट मिला, उनकी टीम्स का भी बहुत सपोर्ट मिला, फैमिली में भी सभी ने मुझे सपोर्ट किया। पहले जरूर मैं डरती थी कि मतलब अब क्या होगा, पर जैसे जैसे होता गया तो डर भी चला गया, और अब मैं एकदम ठीक हूँ। मैंने 10th में एग्जाम भी दिए थे और अच्छे परसेंट भी आए थे, और अभी फॉलो अप भी चल रहा है।
आप इस कॉन्फ्रेंस अभी आपका पहली बार?
नहीं, थर्ड टाइम है। Yes, ma'am.
तो आप अभी फर्स्ट टाइम हुआ, सेकंड टाइम हुआ, थर्ड टाइम हुआ, तो आप ऐसे क्या लेके जाते हो जब घर पे जाते हो इस कॉन्फ्रेंस से, और इसका आप क्या इस्तेमाल, कैसे इस्तेमाल करते हो?
मतलब मैं जितनी बार भी यहाँ आई हूँ, मुझे हमेशा कुछ ना कुछ सीखने को मिला है, और बहुत से लोगों से मोटिवेशन भी मिला है कि आगे लाइफ में कैसा क्या करना है।
तो आप अपनी तरफ से क्या करना चाहते हो आगे, अपना पर्सनल लाइफ के अपनी तरफ से अपना पर्सनल लाइफ का रंग भरते भरते समाज के लिए या दूसरे पेशेंट्स के लिए कुछ करने की चाहत है, या बाद में देखोगे टाइप?
नहीं नहीं, ऐसा नहीं।
नहीं नहीं, होता है ना कभी सेटल, पढ़ाई वगैरह सब इम्पोर्टेंट ईयर्स भी रहते हैं ना।
हाँ, अभी इस साल मेरा कॉलेज है, फर्स्ट ईयर ही है, और मतलब जो भी मेरी तरफ से जो भी मतलब पेशेंट्स के लिए जो अभी प्रेजेंट में है, उनके लिए जो भी हेल्प हो पाएगी मैं पूरी कोशिश करूंगी करने की।
Any questions from you all, from doctors to them? Thank you.
Thank
All the
you.
best. यश यादव, साहू, दो है यश ना, एक यश साहू, हाँ, यश साहू। यश साहू को शायद हम सभी जानते हैं, वो सुबह उन्होंने, वो बहुत अच्छे म्यूजिशियन है, बहुत अच्छा गाना गाते हैं, और पिछले टाइम भी ऑनलाइन उन्होंने बड़े सुंदर गाने गाए थे। यश अपनी गाने पास, ये ओपन हाउस है। यश समझ लो सामने आपका गिटार है या हारमोनियम है, और गाने की जगह आपसे बोल रहे हो। अपने टेल आप कब डायग्नोस हुए, कितने साल के थे?
मैं जब 12 साल का था तब मुझे ये मतलब बुखार आना चालू हुआ था। तो उसके बाद
संदीप कहाँ गया? तो ताली बजाओ यार। आप कहाँ के रहने वाले हो?
उज्जैन।
अच्छा, और घर की हालत, आई मीन ब्रीफ में क्या, जैसे फैमिली सपोर्ट कैसे है, घर में कौन कौन है?
पापा प्राइवेट स्कूल टीचर हैं और मम्मी हाउस वाइफ है।
और सिस्टर, भाई
सिस्टर
बहन?
ना वो 10th में। हाँ वो भी सिंगर है।
पिछले साल शायद दोनों ने गाए भी थे उसमें। तो
हॉजकिंस लिम्फोमा। हाँ बोन मेरो ट्रांसफर 2018 में। हाँ अभी तो ठीक। अभी बैचलर्स इन म्यूजिक 3rd ईयर, माधव म्यूजिक कॉलेज उज्जैन। मैं 14 मतलब डायग्नोज 14 साल का था जब हुआ था। नहीं मुझे बताया नहीं गया था, मैं ऐसे बताया नहीं, मम्मी पापा जब बात कर रहे थे तो मुझे ऐसे पता चला। वो था
ये भी केस तो बना था।
भूल गया।
पर क्या प्रॉब्लम क्या हुई थी, जैसे
वो ड्रग से उससे वो पैरालिसिस जैसा हो जाता था।
अच्छा।
वो तो बोला।
आप सोचना नहीं चाहते उसके बारे में अभी?
हाँ।
ओके, तो गाने के माध्यम से आप लोगों तक कुछ मैसेज भी, या अपनी खुद की भी कुछ कविताएं लिखते हो?
हाँ मैं गाने गाता हूँ।
गाने गाते हो?
सुना दो गाने, 2-3 बैठ।
ठीक है।
दो लाइन। वाह, वही ताली ताली इनके लिए।
ये इसका म्यूजिक चालू कर देना।
तो म्यूजिक
ये जो यहाँ पे
स्टार्ट द म्यूजिक।
ये समझ लो ना।
वॉल्यूम, आवाज बढ़ाओ, आवाज।
आवाज बढ़ा,
माइक में बोलिए। मैं
आवाज बढ़ा सकते हो?
जिंदगी की यही रीत है, हार के बाद ही जीत है। जिंदगी की यही रीत है, हार के बाद ही जीत है। थोड़े आंसू है, थोड़ी हंसी, आज गम है तो कल है खुशी। जिंदगी की यही रीत है, हार के बाद ही जीत है। थोड़े आंसू है, थोड़ी हंसी, आज गम है तो कल है खुशी। जिंदगी की यही रीत है, हार के बाद ही जीत है।
जिंदगी रात भी है सवेरा भी है, जिंदगी जिंदगी रात भी है सवेरा भी है, जिंदगी जिंदगी है सफर और बसेरा भी है, जिंदगी जिंदगी है सफर और बसेरा भी है, जिंदगी एक पल दर्द का दाव है, दूसरा सुख भरी छाव है, हर नए पल नया गीत है, जिंदगी की यही रीत है, जिंदगी की यही रीत है, जिंदगी की यही रीत है।
सविता गोस्वामी जी आ नहीं पाए हैं क्योंकि उनकी फ्लाइट डिलेड हो गई है। तो ऑन बिहाफ ऑफ उगम आई वेलकम एंड एनकरेज ऑल द सर्वाइवर्स, और हमारे उगम के थोड़े सदस्य भी इसमें आए हैं, तो उनको बोलूंगी कि आप आके कुछ शेयर करें, जिससे उनको भी ये प्लेटफॉर्म यूज करके उनकी बातों का और उनके विचारों का प्रदर्शन करने का एक मौका मिलेगा। तो डॉक्टर प्रीति इज अवर कोऑर्डिनेटर ऑफ उगम। प्रीति आप खड़े हो जाओ, प्रीति फार, और आप कौन तैयार है? तुषार और रूबी आइए ना, आप आइए। हाँ प्रीति,
हेलो एवरीवन। मैं प्रीति उगम से। जैसे कुरकुरे मैम का प्रेजेंटेशन हुआ था, उन्होंने उसमें बहुत सारी बातें बताई कि लेट इफेक्ट क्लिनिक जो है या एसीटी क्लिनिक जो है, और वहाँ क्यों आना चाहिए, फॉलोअप क्यों करना चाहिए, और ट्रीटमेंट के बाद भी जो सर्वाइवर्स है उन पे आफ्टर ट्रीटमेंट भी जो क्वालिटी ऑफ लाइफ है उस पर क्यों ध्यान देना है, या जो लेट इफेक्ट होते हैं उसको भी क्यों ट्रीट करना है, या फिर उनका एजुकेशन हो और साइको सोशल हो, जो भी हो, आगे जाके वो सारी बातें भी कितनी इंपॉर्टेंट है, ना कि सिर्फ ट्रीटमेंट खत्म होने तक। और उसका ही जो एग्जाम्पल है वो ये उगम है। ये मैं इतना कॉन्फिडेंटली और स्ट्रांगली क्यों बोल रही हूँ, क्योंकि मैं खुद भी उससे इतनी यहाँ तक आई हूँ, और ऐसे ही लोग हैं जो एक एक करके इससे जुड़ते गए, और आज हम 430+ सर्वाइवर्स है जो एक साथ है। तो जैसे मैं हूँ, मैं ज्यादा नहीं बोलूंगी। रेटिनोब्लास्टोमा था, जो भी ट्रीटमेंट हुई, एक एजुकेशन छोड़ दिया था, ऐसी एक लड़की, बट एक लाइफ का टर्निंग पॉइंट मतलब उगम, कि उगम से जुड़ने के बाद मैंने मेरा मास्टर्स कंप्लीट किया सोशल वर्क में। एज ए मेडिकल सोशल वर्कर लास्ट 8 ईयर से प्रैक्टिस कर रही हूँ, उगम में हूँ। और ऐसे ही जैसे कि एजुकेशन हो या करियर हो, लाइफ हो, या सोसाइटी में एक कंफर्टेबलनेस आए, लोग समझ कर ले। जैसे चितलकर सर ने मॉर्निंग में वो 10 लोगों का जो ग्रुप आया था, जो स्टूडेंट्स थे, जो समझना चाहते थे, जो बोलना चाहते कि हम भी इनको समझना चाहते, तो वो सोसाइटी हमें कैसे कंफर्ट करे। या फिर मेडिक्लेम है, बहुत सारी छोटी छोटी चीजें जो मैम ने बताई, तो वो कैसे हो सकती है, तो वो एक साथ आने से हो सकती है। और वो एक आने के लिए वो एक प्लेटफॉर्म चाहिए बात करने के लिए। जब स्कूल में जाते हैं तो स्कूल का कट्टा होता है, कॉलेज में जाते हैं कॉलेज का कट्टा मिल जाता है। तो ये जो किया है मैम ने, जो हमें दिया है, ये सर्वाइवर्स का कट्टा है। यहाँ आके बात करने में, बोलने में कुछ हिचकिचाहट नहीं रहती, मन में जो भी है वो बिंदास बोल सकते हैं। कोई डर नहीं रहता कि अरे ये मुझे जज करेगा, ये मेरे बारे में क्या बोलेगा, मेरा प्रोस्थेसिस है तो कोई मुझे देखते रहेगा तो मैं ऑकवर्ड हो जाऊंगी, या मैं चल रहा हूँ तो मेरी चाल पे कोई ये करेगा। कोई बॉडी इमेज इशू, कोई भी चीज हो, एक छोटी छोटी बातें हैं जो बहुत असर करती है इंसान पे, क्योंकि जो सोच रखते हैं उससे ही हम आगे बढ़ते हैं ना। तो वैसे ही हमारे साथ तुषार है, जिन्होंने होटल मैनेजमेंट किया है। मैं तुषार से कहूंगी कि वो थोड़ा सा अपने बारे में एक्सप्लेन करें। थैंक यू।
मेरा नाम तुषार संतोष मोरे है। मैं आपको मेरा पूरा बीमारी का कैसा हुआ और उसके बाद में आईसीएस के बाद में उगम, वो मेरा पूरा कैसा हो गया वो मैं पूरा अपना बता दूंगा थोड़ा शॉर्ट में। मेरा ट्रीटमेंट मेरा बॉम्बे हॉस्पिटल में ऑपरेशन हुआ। उसके बाद पता चला कि मेरे को कैंसर है, तो मेरे को टाटा हॉस्पिटल भेजा गया। टाटा हॉस्पिटल आने के बाद में इवन मैं ना बॉम्बे हॉस्पिटल में 17 दिन पूरा आईसीयू में था। तो मैं सोया था, मैं बैठा था पूरा, मेरे को सोने के लिए हो नहीं रहा था। पर मैं टाटा हॉस्पिटल में आने के बाद डॉक्टर अरुणा करके थे, उन्होंने पूरा देख लिया। तभी उनको पता चला कि मेरा आईसीडी का 2 होल बाहर आया था, उससे अंदर हवा जा रही थी और मेरे को सांस लेने के लिए तकलीफ हो रही थी। वो उन्होंने ठीक कर दिया। और उसके बाद मैं 27 दिन बाद में टाटा हॉस्पिटल आने के बाद में सोया। तभी मैं पूरा पूरा 27 दिन में सोया नहीं था। और उधर मेरा ट्रीटमेंट अच्छे से चला और मेरा बनावली सर के पास फाइल था, मेरा ट्रीटमेंट खत्म हो गया, सब हो गया। पर मैं इस बीमारी के बारे में इतना जानता नहीं था, तो मैं थोड़ा डिप्रेशन में था और मेरे को कुछ पता नहीं चलता था कि ये क्या होएगा वगैरह, कुछ नहीं पता चलता था। तो बाद में मेरा उगम के साथ मेरा संबंध हो गया। तब मेरे को पता चला कि मेरे जैसे ऐसे बहुत जन है और वो सामान्य आदमी के जैसा जिंदगी जी ले। और तभी मैं उसमें जुड़ा और मेरे को पता चला कि मैं आगे बढ़ सकता हूँ। और मेरा एक गोल था कि मैं आर्मी में जाने था मेरे को। मैं जब 7th स्टैंडर्ड में था तब मेरे को कैंसर हुआ था, पर तभी मैंने एडमिशन भी लिया था आर्मी स्कूल में। पर मेरा ऑपरेशन होने की वजह से मैं जा नहीं पाया। तब मैं पूरा करियर के इसमें भी मैं पूरा करियर में क्या करने का वो मेरे को पता नहीं चल रहा था। उसके बाद मैं आईसीएस में करियर काउंसलिंग हुआ मेरा। तब मैंने मेरा करियर दूसरा चूज किया, मैंने होटल मैनेजमेंट किया। और मैं होटल मैनेजमेंट पूरा करके मैं आज एक होटल में शेफ हूँ। और मैं ऐसा मेरे को सोशल वर्क करने के लिए मेरे को बहुत अच्छा लगता है। तो मेरे इधर एरिया में जितने मेरे पहचान में किसी को या कुछ रिलेटिव्स में कैंसर हुआ तो मैं उनको टाटा हॉस्पिटल लेके आता हूँ, उनको पूरा सब ट्रीटमेंट का करके देता हूँ। और मेरे पहचान की वजह से जितना जो है कुछ होता होगा तो उनको करके देता हूँ।
टीचर ने जो भी कहा उसमें कंक्लूड करने के लिए बोलूंगी कि जैसे उसकी ट्रीटमेंट खत्म हो गई, एक गैप हो गया, फॉलोअप के लिए आना शुरू हुआ, क्योंकि वो टाइम से तुषार से इंटरेक्ट किया, इसके लिए बता पा रही हूँ। तो वो एक शेल में रहता था, बात करना और यहाँ तक आना। जैसे अक्षय अपना ये अशोक ने थोड़ी देर पहले बोला कि पहली बार आके बात कर रहा हूँ या खुद के बारे में इतना बोल रहा हूँ, तो ये तुषार एक वैसा ही है। लेकिन आर्मी नहीं हो पा रहा है, इसके लिए एक डिसअपॉइंटमेंट होना, लेकिन एक जो करियर गाइडेंस होता है ना कि कौन सा रास्ता है, क्या पकड़े और क्या करे, तो वो जो गाइडेंस मिला वो सही टाइम पे मिला। और उसके लिए उसने जो भी सपोर्ट मिला उसकी वजह से उसका होटल मैनेजमेंट वो पूरा कर सका। तो जैसे मैंने अभी बोला ना कि एक ग्रुप होना, एक साथ होना कितना इम्पोर्टेंट है। और उगम में आके वो इतना अभी आगे ये हो गया कि जैसे हम लोग सेंट जूड में टाटा हॉस्पिटल में जो छोटे पीडियाट्रिक में बच्चे हैं उन्हें भी हम काउंसिल करते हैं, उनके पेरेंट्स को मोटिवेट करते हैं कि वो ट्रीटमेंट पूरी करे, आधे अधूरा छोड़कर नहीं जाना चाहिए। और उसके बाद भी लाइफ है, जैसे कि एग्जाम्पल हम विक्टर्स आपके सामने खड़े हैं, तो उसमें भी उसका पार्टिसिपेशन होता है। तो ये एक उसका जर्नी है, ये एक लाइफ चेंज ये है। थैंक यू तुषार। वैसे ही हमारे साथ है सैफ सिद्दीकी। आ जाओ। सैफ है जो अभी एमबीबीएस सेकेंड ईयर के स्टूडेंट है, और आगे का सैफ ही अपने बारे में बोल देंगे।
Hello and good evening, everybody. I am Saif Ali Siddiqui. I am currently a second year MBBS student at IMSR Jalna. I was diagnosed with embryonal rhabdomyosarcoma when I was at the age of 7. Right now, I am 24 years old, and it's been almost, you can say, 16 to 17 years after my diagnosis and everything. I've cured of everything, and it feels immense happiness from sitting on that side of the table as a patient and now sitting with the doctors and looking around the patients. And I'm very happy, and I thank Ugam and Kurkure ma'am for this, because after my reference to Kurkure ma'am through Dr. Tapan Saikia, who was my treating doctor, I came to know about ACT and everything. And that time I just had a vision of becoming a doctor. Like when I was in my treating phase, I just used to say कि सर आज आप इंजेक्शन लगा रहे हो, कल को मैं डॉक्टर बनूंगा और मैं आपको इंजेक्शन लगाऊंगा. So everyone used to smile कि अच्छा ठीक है बेटा तुम बड़े हो जाना, अभी फिलहाल तुम ट्रीटमेंट पूरा कर लो. So after that, when I was in my academics and I came to know like we have to do such a lot of studies and examinations and all. So then he again asked me, Saif, do you still want to be a doctor? So I said, yes, sir. So then he said, लेकिन पढ़ना बहुत पड़ेगा, हो पाएगा? So I said, sir, आप लोगों ने हिम्मत देके इतनी बड़ी जंग जिता दी, तो ये क्या बात, ये भी कर लेंगे. It took me 3 years to crack NEET entrance examination, but then I cracked it and I am here with you all. And thanks a lot, everybody.
All the very best.
And I hope one day the team this I saw today afternoon discussing and was a panel. I wish one day I would be in that panel too.
Great. All the best.
Thank you, everybody.
मुझे सबसे So we- ज्यादा टाइम नहीं लेना है, लेकिन थैंक यू सैफ. जैसे आपने सैफ को सुना, वैसे ही एक गोरखपुर में बड़ी हुई लड़की जिसने कभी मुंबई नहीं देखा, ट्रीटमेंट के लिए मुंबई तक आई, स्कूलिंग गांव में ही किया, बट उसके बाद जिद रखकर उगम को देखकर उसने क्या किया वो खुद ही बताएगी.
सबको मेरा प्रणाम, डॉक्टर्स एंड फ्रेंड्स, भाई बहन. मैं रितिका मौर्य गोरखपुर से हूँ. मेरी फैमिली गोरखपुर में रहती है. मेरा पूरा बचपन गोरखपुर में बीता और मैं जब 4 साल की थी तभी मुझे ब्रेन ट्यूमर का छोटा सा शिकायत आया. इसका सिटी स्कैन गोरखपुर में हुआ तो थोड़ा उसका अंश पता चला कि ब्रेन ट्यूमर है. तो वहाँ के डॉक्टर ने टाटा हॉस्पिटल में रेफर किया, सीधा वहीं गोरखपुर से टाटा हॉस्पिटल. तो यहाँ पे फिर दोबारा सारे फॉलोअप चेकअप हुए, सिटी स्कैन हुआ तो पता चला कि हाँ सच में इसको ट्यूमर का थोड़ा गांठ है. तो उसकी ट्रीटमेंट चालू हुई, 2005 से चालू हुई. वहाँ चालू होने के बाद मुझे कीमो हुआ. कीमो से मैं उस वक्त तो ठीक हो गई. फिर 2007 में फिर से वही बीमारी दोबारा आई उसी जगह पे, तो दोबारा फिर कीमो चालू हुआ. कीमो चालू होने के बाद वो बीमारी भी ठीक हो गई. तो 2008 में मेरी फाइल एसीटी में चली गई. फिर एसीटी के बाद से मैं उगम से मिली. उगम में मैं उस वक्त मेंबर तो नहीं थी, एज अ बस इतना जानती थी कि एक उगम ग्रुप है, चाइल्डहुड कैंसर सर्वाइवर का सपोर्ट ग्रुप. तो उसमें जो भी प्रोग्राम होते थे उस प्रोग्राम को अटेंड करना और उगम की एक्टिविटीज को देखना. मतलब मैं 2008 से देखती आ रही हूँ कि ये सब एसीटी का है और यहाँ पे एसीटी में फॉलोअप होते हैं, इसमें इतनी सपोर्टिंग होते हैं, डॉक्टर्स भी सपोर्ट करते हैं करियर को लेकर और हमें आगे क्या करना है, बहुत सारी चीज़ों को लेकर मोटिवेशनल सपोर्ट, फैमिली में कोई प्रॉब्लम तो उसके लिए सपोर्ट. तो जब मैं उगम में आई, उगम की एक एक एक्टिविटीज को देखी, उस वक्त उगम से एक अलग ही अटैचमेंट हो गया. मैं उस वक्त यही सोची कि एक मेरा कोई सपना नहीं था, सिर्फ यही था कि मैं उगम के लिए कुछ करूंगी, बड़ी हो जाऊंगी तो उगम के साथ रहना, सारी चीजें उगम के लिए सोच के रखी. तो उस वक्त मतलब मेरा कैरियर गोल ये था कि मैं कुछ बड़ा करूंगी, कुछ बनूंगी, लेकिन ये नहीं था कि मुझे एज अ प्रोफेशनली क्या बनना है. मैंने ये नहीं सोचा, बस एक उगम के सपोर्ट में रहना है. और अभी मैं क्या बीएससी कंप्लीट की हूँ मुंबई से, आगे बीएड की पढ़ाई कर रही, फर्स्ट ईयर में हूँ. बीएड में कर रही हूँ क्योंकि मेरी मम्मी को चाहती कि मैं टीचर बनूं. मैं मेरी मम्मी का सपना पूरा करने के लिए टीचर बन रही हूँ और फिर साइड बाय साइड में उगम के साथ हूँ. गोरखपुर से यहाँ इंदौर आई कॉन्फ्रेंस में उगम के थ्रू. 3 साल मैं मुंबई में रही, जब ग्रेजुएशन कंप्लीट की तब तक मैं उगम के साथ एक एक एक्टिविटीज किया. और इतने कम टाइम में यहाँ तक आना, मैं उगम को इतना थैंकफुल देती हूँ कि आज अगर उगम नहीं होता तो मैं इतना आगे आती हूँ. एक
थैंक यू रितिका. क्रेडिट खुद को भी देना चाहिए जो हिम्मत इसने रखी. जैसे कि इसने बोला कि इसने जो बीएससी किया वो मुंबई में रह के किया था, हॉस्टल में रह के. मम्मी तो गोरखपुर में ही है. जो एजुकेशन सपोर्ट दिया था, जैसे कि मैम ने बताया, जो एजुकेशन सपोर्ट इंडियन कैंसर सोसाइटी के थ्रू देते हैं. सो शी कंप्लीटेड हर ग्रेजुएशन with 80% in BSc और अभी आगे बीएड का ये करिए। थैंक यू चितलकर सर, आपका जो आपने ये जो अपॉर्चुनिटी दी है इसके लिए, ये जो भी यहाँ पे जितने भी सर्वाइवर्स विक्टर्स यहाँ तक आए, वो ये प्लेटफॉर्म पे खड़े रह के बात करने के लिए जो प्राउड फील करते हैं और एक जो हिम्मत आती है, एक जो मोटिवेशन आता है, वो सच में बहुत बहुत इम्पोर्टेंट है एज अ वॉरियर। थैंक यू सर, थैंक यू वेरी मच।
So we have probably the you are also survivor. एक मिनट मैं पहले कृष्णा को बुलाती हूँ। कृष्णा इज अ ALL केस और वो अपनी कहानी खुद बताएगा। मैंने कृष्णा को 2016 में देखा था।
गुड इवनिंग ऑल ऑफ यू। इतने सारे उसके बोल स्टेडियम में आप इतने सारे उसके लोगों के सामने बोलने के बावजूद आज मैं नर्वस हो रहा हूँ, क्योंकि बहुत साल हो गए स्टेज में आए हुए बोले हुए। मेरा नाम कृष्णा दास है और मैं ALL कैंसर सर्वाइवर हूँ। मुझे 98 में डायग्नोस हुआ था, तब मैं 2.5 साल का था एंड 2000 में क्योर हो गया। मेरा फर्स्ट केस जब आया था तो एक हॉस्पिटल से दूसरे हॉस्पिटल ट्रांसफर हुआ था। फाइनली मूलचंद से मुझे एम्स में ट्रांसफर किया गया। डॉक्टर LS आर्या थे उस टाइम, पीडियाट्रिक ऑन्कोलॉजिस्ट। देन उनके अंडर जो डॉक्टर्स थे, डॉक्टर संजय, उन्होंने मेरा ट्रीटमेंट कंप्लीट किया। उस दौरान एक फनी सीन भी हुआ था कि सर मेरा ट्रीटमेंट कर रहे थे, इंजेक्शन लगाए थे, तो मैंने उनके नोज पे किक मारा। जब भी मैं फॉलोअप के लिए जाता था, वो मेरे को हमेशा यही कहते थे, बेटा तू बड़ा हो जा, फिर मैं तुझे बताऊंगा अच्छे से। सो देन उसके बाद डॉक्टर बसंता आई। डॉक्टर बसंता, शी इज वेरी नाइस पर्सन एंड उनके सामने पेरेंट्स तो क्या, बच्चे भी चुप रहते थे। उनकी पर्सनालिटी ऐसी थी, अगर मैम ने एंटर किया सारे साइलेंट, जो भी बच्चे रो रहे सब चुप। अब करेंटली डॉक्टर रचना सेठ है जो फॉलोअप क्लिनिक्स वगैरह देखती है हमारे। एंड करेंटली आई एम अ मेडिकल लैब टेक्नोलॉजिस्ट इन द डिपार्टमेंट ऑफ पैथोलॉजी, ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज, न्यू दिल्ली। एंड 2 टाइम कोविड वॉरियर ऑल्सो। 2021 में भी मुझे कोविड हुआ था एंड 2022 में भी मुझे कोविड हुआ था एंड दोनों टाइप मैंने सर्वाइव किया। इवन 2021 में मेरी पूरी फैमिली जो थी कोविड से इन्फेक्टेड थी, स्पेशली माय मदर एंड माय ग्रैंडमा वाज टोटली इल, no chances for cure, but thanks for God and helping doctors, सबके साथ वो करके हमने क्योर किया। एंड करंटली अब मैं आपके सामने खड़ा हूँ एंड मेरा एम्बिशन ये है कि मैं अपने कॉज को कुछ करना चाहता हूँ, डोनेट। दैट्स वाई मैंने अपना मेडिकल फील्ड चूज किया, पैरामेडिकल फील्ड चूज किया मैंने। एंड आगे मेरा जो है एम्बिशंस है कि जितने भी सर्वाइवर्स है इन ऑल ओवर इंडिया, उनको एक प्लेटफॉर्म पे लाके कनेक्ट किया जाए, ताकि हम नेशनल, जैसे आउट ऑफ कंट्रीज में यूथ कैंसर सर्वाइवर ग्रुप है नेशनल बेसिस पे, वैसे हम इंडिया पे भी क्रिएट कर सके। दैट्स इट एंड थैंक यू ऑल, पूनम मैम, चितालकर सर एंड एवरी डॉक्टर्स, जिन्होंने हर एक पेशेंट, हर एक सर्वाइवर को सपोर्ट किया, मोटिवेट किया, ताकि वो अपनी लाइफ में ग्रो कर सके और अपने गोल्स को पा सके। थैंक यू।
कृष्णा, यू आर वर्किंग इन ऑल इंडिया इंस्टीट्यूट?
यस मैम।
तो अभी डॉक्टर रचना के साथ मिलके कुछ करो।
यस मैम।
हम का चैप्टर चालू करो, क्योंकि डॉक्टर रचना अभी वो जो मैं प्रोजेक्ट पिकासो के बारे में बोली, उनकी हिस्सेदार है। वो एसीटी क्लिनिक में हमारा सहयोग है, तो आप उसको आगे बढ़ाओ और आपका चैप्टर उधर चालू करो।
यस मैम, डेफिनेटली। एंड ACT क्लिनिक के अंडर अभी जो है हमारा लेट साइड इफेक्ट्स के काफी सारी चीजें जो है डिटेक्ट किए जा रहे हैं, जैसे आपका मेंटल हेल्थ एंड फिर फर्टिलिटी इश्यूज वगैरह, ये सारा कुछ कवर किया जाए। थैंक यू।
तो अभी आप वो बात तो हम कर रहे हैं मेडिकल साइड, अभी आप ये साइड करो।
यस मैम।
के जो साइकोलॉजिस्ट है ना, उनका नाम क्या है? उधर है उनसे मिलते हैं,
Yes, sure.
उनके सहयोग से आप आगे बढ़ सकते हैं।
Yeah. Thank ladies and gentlemen, please welcome Savita Goswami. She just arrived. And she's and she, I mean, her programs every year. You heard about first Sunday of June. I look forward to that day every single day of my life. It's such an energizing program. I can't tell you that. So even during the COVID, it was online, but it was amazing. And I think it's a fantastic energy that you created. It's bigger than the sun. I promise that. So thank you very much. And I mean, you are saying everything. So welcome. And this is a freewheeling session. So we'll work it out. Thank you.
तो ये नेक्स्ट इज नीरव जिसे who was a Hodgkin's patient.
हेलो, गुड मॉर्निंग, गुड इवनिंग डॉक्टर्स एंड फ्रेंड्स। मेरा नाम नीरव है। मुझे हॉजकिन लिम्फोमा हुआ था। मैं जब 12 साल का था 99 में। उसके बाद मैं रेगुलर फॉलोअप करता था। फिर मुझे ट्रीटमेंट कंप्लीट करने के बाद 2012 में एक रिकरेंस हुआ थायराइड कैंसर के थ्रू, और उसका मुझे बेनिफिट एसीटी क्लिनिक में मैंने फॉलोअप किया। उस फॉलोअप के दरमियान मुझे मेरा सेकंड कैंसर कैच हुआ। सो मेरा मैं एक स्पेशल केस हूँ। मुझे ऐसा फील होता है कि अगर कोई एक कैंसर होता है तो 5 साल के बाद उसका रिकरेंस होने का चांसेस ज्यादा होता है, लेकिन मुझे 12 साल के बाद मुझे रिकरेंस हुआ और मैं सेकंड मैलिग्नेंसी। यस। सो मैं टाटा हॉस्पिटल एसीटी क्लिनिक के अंडर में वहाँ पे मेरा ट्रीटमेंट हुआ। मेरा बॉर्न एंड बॉट अप मुंबई में है और मैं अभी सूरत में रहता हूँ और मैं ओला से जुड़ा हुआ हूँ। और एसीटी क्लिनिक में फॉलोअप में आते टाइम कुरकुरे मैडम से मिलना हुआ, बाकी लोगों से मिलता था और वहां से पता चला कि उगम करके एक ग्रुप बना हुआ है, तो मैं उगम से जुड़ा। स्कूल कॉलेज का थोड़ा बैड एक्सपीरियंस था, नया दोस्त नहीं बनाता था, लेकिन मैम के थ्रू पता चला कि एक ग्रुप बन रहा है, तो मैंने वहाँ पे डांस में पार्टिसिपेट किया था और मैंने देखा कि वहाँ पे सब मेरे जैसे सर्वाइवर ही है। तो मैं उसके बाद से मैंने नए दोस्त बनाने चालू किए और उगम में आने के बाद मुझे मेरे विंग्स लग गए, मैंने लाइफ जीना शुरू किया। सो ये मेरा एक्सपीरियंस है। थैंक यू।
यादव आ गया।
अरे गाना पण बोला
सगळे डान्स एक यश यादव का नाम एक
शुक्रिया, धन्यवाद बहुत बहुत। कहाँ से शुरू करें? अरे सच में यहाँ आने के बाद की सीन अलग हो जाती है। शुक्रिया, बहुत बहुत धन्यवाद आप सारे लोग को कि आपने एक बार फिर से अवसर दिया हमें कि हम आप लोग के बीच में आए और अपने बारे में शेयर करें। जर्नी जो है वो शुरुआत होती है 2007 से। उस टाइम पे हमको बोन कैंसर डायग्नोस हुआ। डायग्नोस होने से पहले लगभग 6 मंथ तक मैं एक हॉस्पिटल से दूसरे हॉस्पिटल, एक जिले से दूसरे जिले और एक हॉस्पिटल से दूसरे हॉस्पिटल में भटकता रहा। और जब भी गोरखपुर गया तो उधर बायोप्सी हुआ और फिर डॉक्टर ने बोला कि हाथ निकालना पड़ेगा और 1.5 लाख रुपए लगेंगे। बात है 2007 की। उस टाइम पर इतने सारे सपोर्ट ग्रुप नहीं थे, इतने सारे हॉस्पिटल्स नहीं थे, इतने सारे डॉक्टर्स भी नहीं थे। तो अच्छी बात है कि कुछ जान पहचान मुंबई में था और हम लोग अगले दिन बॉम्बे गए और वहाँ पर जो टाटा हॉस्पिटल में 1 साल का इलाज हुआ। तो इविंग सार्कोमा डायग्नोसिस था, तो 14 साइकिल लगे थे केमोथेरेपी और राइट ह्यूमरस जो बोन होती है वो रिप्लेस हुआ। उस टाइम पर बहुत जद्दोजहद हुआ था क्योंकि पापा जी का हमारा रिक्वेस्ट था डॉक्टर से कि हाथ बचाना है, और डॉक्टर बोल रहे थे कि आपका पैसा बच जाएगा, हाथ निकलवा दीजिए। तो पापा बोल रहे थे कि हम खेत बेच देंगे, जमीन बेच देंगे, चलेगा, लेकिन हाथ इसका बचाना ही है। तो उस टाइम पर जो है मेटल वगैरह वो सब आया, अराउंड 55,000 रुपीज लगे थे उसका, हाथ बच गया और हाथ बच करके बहुत ज्यादा बेनिफिट हुआ। सो जैसा मैम बता रही थी सुबह में कि ढेर सारे पॉइंट्स ऐसे आते हैं जिस टाइम पर आपको अटैचमेंट होता है डॉक्टर से, नर्सेस से, वार्ड में या फिर और अन्य जगह। तो वो सारे फेजेस जो है हमारे सामने भी चला। मेरी उम्र कुछ 12-13 साल था, कुछ ज्यादा ज्ञान नहीं था, गांव से आया हुआ था, पर यहाँ पर जो देख देख करके सीख गया। तो जब भी सर्जरी का टाइम था, तो सर्जरी के टाइम पर मैं जब भी वार्ड में, सॉरी, ऑपरेशन थिएटर में जब भी गया था अंदर, तो उस टाइम पर हंस रहा था, मुस्कुरा रहा था। तो डॉक्टर जो थे वो पूछे कि ऐसा पहली बार देखे पेशेंट जो सर मतलब ऑपरेशन थिएटर में मुस्कुराते हुए जा रहा हो। तो वो हमको पूछे अभी तू हंस क्यों रहा है? तो मैं बोला नहीं सर ऐसे ही हंसी आ रही है। बोले नहीं नहीं बता रीजन क्या है? बोले सर इतनी बड़ी बड़ी लाइटें मूवियों में देखता था, वो पहली बार इधर देखा हूँ तो हंसी आ रही है। तो बोले अच्छा तू बहुत बोलता है, चल सो जा अभी। उसके बाद में सुलाए 9:35 पर, और शाम को 4:30 बजे नींद खुली। तो उंगली हिलाया कि हाथ बचाएगी, नहीं, हाथ बचा हुआ था। बट तो फंक्शन जो है हाथ का चला गया था, वो इसलिए क्योंकि उतना बड़ा सर्जरी था। ये शोल्डर वाला जो होता है मोमेंट और इधर दोनों रिमूव हुआ। फिलहाल तो इतने समय अच्छा हो गया है, सब पूरा अच्छा है। बाइक वगैरह चलाता हूँ, लैपटॉप वगैरह बहुत फास्ट चलाता हूँ। सो उस टाइम पर फिजियोथेरेपिस्ट के साथ में संघर्ष हुआ, और फिर जो है मोमेंट हाथ में आना चालू हुआ धीरे धीरे। तो कुछ 6 मंथ का समय लगा था उंगलियां मतलब हिलने में, और एकदम अच्छा हो गया, बढ़िया हो गया। तो फिर उस टाइम पर जो है पूरा जो सपोर्ट सिस्टम है, पूरे डॉक्टर्स का, हॉस्पिटल का, सोशल सपोर्ट टीम का, एनजीओस का, सरकार का, वो सारे लोग की वजह से मैं ठीक हो पाया। एक भी कोई ऐसा डिपार्टमेंट नहीं है जिनका सपोर्ट नहीं हमको मिला हो, वो चाहे सोशल वर्क डिपार्टमेंट हो। सविता गोस्वामी मैम हमारे बीच में है। मैम के पास में हर 2 महीने 3 महीने में मैम को मैसेज करके अपॉइंटमेंट लेता था कि मैम मुझे आपसे मिलना है। मैम से मुलाकात हमारी हुई थी 2011 में आई थिंक, जिस टाइम पे हमारी फाइल एसीटी में गई थी। जैसा मैम बता रही थी, तो कुरकुरे मैम बता रही थी, हम लोग 11वें मंजिले पर मिले थे, तो प्ले रूम पे उस टाइम पर मैम थी, और साथ में डॉक्टर वंदना मैम थे। थोड़ा सा मैं मतलब डिटेल में जा रहा हूँ क्योंकि ऐसा लग रहा है कि थोड़ा डिटेल में बता देना हो सकता है फायदेमंद हो यहाँ। तो वहां पर मुलाकात हुआ, और फिर हमको उगम के बारे में जानकारी मिला। उगम के बारे में बहुत कुछ आप लोग सुन रहे थे, और उगम एक ऐसी चीज है जिसकी वजह से आज हम यहाँ पर हैं, सामने खड़े हैं। तो एक बार जोरदार तालियां। तालियों में कमी नहीं रहनी चाहिए, रात का डिनर नहीं मिलेगा नहीं तो। बहुत अच्छे, बहुत अच्छे। तो उगम ने हमको हर तरीके से सपोर्ट किया, हमारे एजुकेशन के लिए सपोर्ट करा, रहने के लिए सपोर्ट करा, जॉब के लिए रेडी करा। एक मोमेंट आया था जिस टाइम पर 2015 के आसपास में मैं सोचा था कि ओडाला ब्रिज से जाकर के कूद करके जान दे दूंगा। उस टाइम पर उगम ही था जो हाथ संभाला। शेखर झा करके सर हैं, मैं उनको यहाँ से धन्यवाद देना चाहता हूँ कि सर ने हमें बहुत समझाया, मैम के पास लेकर के गए, बहुत गाइडेंस मिली। लोगों को देखा जब भी उगम एनिवर्सरी सर आकर के स्टेज पे बता रहे थे कि वो एक दिन साल का होता है जिस दिन मैं जो है इंतजार करता हूँ कि वो दिन में हमें शरीक होना है, हमें जाना है, वहां पर उपस्थित होना है। वो दिन के बारे में मैं आपको बताना चाहता हूँ कि पूरा हॉल जो होता है 300, 400, 500, 600 कितनी सीटें रहे, वो तो खचाखच फुल रहती है। लोग नीचे बैठे रहते हैं, खड़े रहते हैं, हाहाकार जबरदस्त तरीके से मचता है। और वो सिर्फ आप सोच सकते हैं, जब तक वहां पे जाएंगे नहीं तब तक वो एहसास नहीं आ सकता है। और उस दिन जो है 2015 में फर्स्ट टाइम अपॉर्चुनिटी मिली थी मुझे जो है वो इवेंट को अटेंड करने के लिए। सब लोग आकर के स्टेज पर जो है नाच रहे थे, कूद रहे थे, अपने बारे में बता रहे थे, स्किट हो रहा था। मैं जो प्रीति मैम है यहाँ पर और बाकी सारे लोग ग्रुप को लीड कर रहे थे और मैं एक कोने में जाकर के पीछे बैठा हुआ था और मैं बहुत अपने आप को अकेला महसूस कर रहा था। इस तरह से कि शायद याद होगा मैम को उस टाइम पर जब हमको मीटिंग हुआ था फर्स्ट टाइम, तो हम आए थे और वहां पर सबको जो भी न्यू मेंबर होता है ना उसको बोला जाता है भैया अपने बारे में बताओ। तो अपने बारे में आज लोग आए थे स्टेज पे ना, तो भैया आप लोग बहुत सही बोले हैं। जब मैं गया था हमको चेयर पे बैठे थे, बोले खड़े होके बोलो। अब खड़े होके जब हम बोलने गए तो संदीप कुछ इस तरह से हमको बोलने के लिए 1-1.5 मिनट लग गया था संदीप बोलने में। वो दिन भी हमें याद है और मैम उसके साथ साथ यहाँ पर गवाह हैं कि वो मतलब हेजिटेशन लेवल उस स्तर का था कि आवाज नहीं मुंह से निकलती थी, गिक्की बंद हो जाती थी। वहां से जो है हाथ संभाले, सिखाए, पढ़ाए, संजीवनी का कोर्स करा। टीस बहुत बड़ा नाम है सोशल सेक्टर में, वो इंडिया में फर्स्ट आया, मतलब फर्स्ट उसकी स्थापना हुई थी, तो वहां से जो है कोर्स करा। टाटा में हमारा क्या बोलते हैं प्रैक्टिकल चला, हर ओपीडी हर डिपार्टमेंट में, वो चाहे गायनिक हो गया, ब्रेस्ट हो गया, ओरल हो गया, बच्चों का हो गया, वेटिंग एरिया, इधर उधर सब जगह जाना, लोगों का काउंसलिंग करना, अपने बारे में बताना, उनको केमोथेरेपी के बारे में बताना, साइड इफेक्ट के बारे में बताना, काउंसलिंग करना, सारी चीजें। तो सब सीखते गया। एक संस्था ने हमको बोल दिया था, बहुत ध्यान से सुनिएगा देवी सज्जनों, क्या बोला कि मैं नाम नहीं मेंशन करूंगा, उन्होंने सेंटेंस क्या बोला वो चीज बोलना चाहता हूं क्योंकि बहुत सारे लोग के सामने शायद ये वाली अवस्था आती होगी कि मेक श्योर ये व्यक्ति कल से टाटा हॉस्पिटल में घुसने ना पाए संदीप, क्योंकि यह ओपीडी में जाकर के पेशेंट को समझा नहीं पाता है, इसलिए क्योंकि इसको बोलने में दिक्कत होती है। उसके अगले ही दिन वो दिन जो था मेरे लिए बहुत मतलब आप सोच सकते हैं, मतलब बोल नहीं पाता इस वजह से ओपीडी में ना जाए, ये वाली बात तो है ही है, लेकिन टाटा हॉस्पिटल में घुसने ना पाए। तो हमने बोला भाई टाटा हॉस्पिटल तो हमारा दूसरा घर है और टाटा हॉस्पिटल में घुसने के लिए हमें किसी की परमिशन की जरूरत नहीं है, हम जब चाहे तब जाए। टाटा मतलब जो फील आता है अंदर वो शायद शब्दों में ना निकले। तो हम बोले ठीक है जी। तो अगले ही दिन हम फिर और भी संस्थाओं के पास गए, इंटरव्यू वगैरह हुआ, फिर एक बहुत बड़ी नामी जानी और ऑर्गेनाइजेशन में हमको काम करने का अवसर मिला और उसके बाद से हमने कभी पीछे मुड़ करके नहीं देखा। दूसरी बात, उस दिन पीछे बैठ करके वो सोच रहा था अकेला एकांत, तो रो रहा था एक किनारे कि यार इतने सारे लोग हैं, सबके दोस्त हैं, लेकिन मेरा एक भी दोस्त नहीं है, कोई पहचानने वाला नहीं है, कोई जानने वाला नहीं है। चुप था, बहुत शांत था, अकेला महसूस कर रहा था, लेकिन मन में एक ही विचार था कि एक टाइम आएगा हर कोई जानेंगे, और वो आया शायद समय। तो ओपीडी में जाना चालू किया, वार्ड में जाना चालू किया, मिलना चालू करा, और हमने मन में आज तक भी कभी ये नहीं सोचा है कि किसी ने अगर कुछ बोल दिया है तो हमें उसको दिखाना है करके, ये वाली फीलिंग नहीं है। हमें हमेशा यही मन में था कि अगर उसने कुछ बोला है इसका मतलब है कि ये वाला चीज हमें सीखना है या ये सुधार लाना है अपने अंदर। और करता गया तो टाटा हॉस्पिटल से और हॉस्पिटल में गया, उगम के जितने भी इवेंट्स होते थे, प्रोग्राम्स होते थे, सब चीजों में जाना चालू करा, लोगों को फिर जोड़ना चालू किया, लोगों को लीड करना चालू करा। फिर उसके बाद में कैंकिट्स करके एक संस्था है उसके साथ जुड़ा, फिर वहां पर सर्वाइवर सपोर्ट ग्रुप बनाया, उनके साथ में मुंबई मैराथन दौड़ना, रेलवे स्टेशन पर, गांव में, मार्केट में, स्कूल में, कॉलेज में, किधर भी जाकर के अपने बारे में शेयरिंग करना। तो अराउंड 10-20 हजार लोग के सामने तो जाकर के हमने लोगों को काउंसलिंग करा ही होगा, चाहे स्टेज के माध्यम से 1-to-1 ये सब चीजें। और जर्नी वहीं से हुई थी शुरू। फिर उसके बाद बढ़ते फिर 2018-19 में एक बार फ्रांस जाने का अवसर मिला। वो मेरे लाइफ का सबसे बड़ा अपॉर्चुनिटी था, वो इसलिए क्योंकि हाँ बताइए। बहुत अच्छी बात है, धन्यवाद। हम समझ सकते हैं, हम सोच रहे हैं शॉर्ट कर दें बात को, लेकिन आप लोग इंटरेस्ट दिखा रहे हैं इसलिए मैं बोलते चला जा रहा हूं। अगर इंटरेस्ट ना रहे तो मैं बात खत्म कर दूंगा अपनी। तो सीन ऐसा है कि अब फ्रांस जाना था और बात है कि इंग्लिश में बोलना था, और वो मुझे इंग्लिश आती नहीं थी। अब हमको बोला गया कि अगर तू 2 महीने में इंग्लिश नहीं सीखा तो फिर तेरे जगह पे दूसरे को भेज देंगे। ये तो होना ही नहीं था। हम तो मुंबई में दादर का जो सबसे बेस्ट इंग्लिश इंस्टीट्यूट है वहां पे जाकर के एडमिशन कराए और उनके सामने बोले ये बात कि देखिए बात ऐसा है कि हमको यहाँ पे 6 महीने नहीं पढ़ना है, हमको सिर्फ इतना बता दो कि किस तरह से हमको 20-30 मिनट प्रेजेंटेशन देना है, इतना मुझे सिखा दो बस, और कुछ नहीं सीखना है। फिर उसके बाद लग गया, उनका कुछ सिस्टम रहता था, सोमवार से शुक्रवार, सैटरडे संडे दूसरा सिस्टम, हम डेली आते थे। सैटरडे संडे 3-3 घंटे इंग्लिश सीखे और जाकर के फ्रांस में लियोन में वहां पर 25 मिनट का ओरल प्रेजेंटेशन दिया था और उसके बाद में 5 मिनट क्वेश्चन आंसर हुआ था। हमारे सामने ऑडियंस टोटल 450 लोग थी और 110 देश से लोग आए हुए थे। और उसके बाद में जब भी मैं स्टेज से नीचे उतरा, अच्छा शुरुआत तो इस तरह से हुई थी, तो वो सूख गया मुंह वगैरह सब, पानी की बोतल जितनी भी सामने थी खत्म, गटक गया, 1-1.5 लीटर समझ नहीं आया। फिर उसके बाद शुरू करा, धीरे 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 वो आ गया, रिसीव बन गया। तो बोलने के बाद में जब उतरा स्टेज से तो स्टैंडिंग ओवेशन मिला था। वो शब्द भी वहीं पे मैं सीखा, अच्छा इसको स्टैंडिंग ओवेशन मिलता है, क्योंकि हम 10 लोग को बोले, खड़ा होके लोग ताली बजा रहे थे। अच्छा तो स्टैंडिंग ओवेशन मिला, नहीं खड़े होके ताली बजा रहे थे, तो उसको ये बोलते हैं। हम ठीक है जी। तो अच्छा, ये इसके अलावा बहुत महत्वपूर्ण चीज जो आप लोग को शायद ध्यान देना चाहिए, उसके बाद मैं किसी को नहीं देखा कि कौन बंदा लंच में मिल रहा है, कौन बंदा ब्रेक में मिल रहा है, कौन लिफ्ट में मिल रहा है, किधर मिल रहा है। हर किसी को जाकर के अपने बारे में बताना और उनके बारे में सुनना। किसका व्हाट्सएप है, व्हाट्सएप नंबर लेना, जो व्हाट्सएप पे नहीं है फेसबुक का लिंक लेना, फेसबुक पे नहीं है तो इंस्टाग्राम, नहीं कुछ है तो ईमेल आईडी दे दो, लेकिन हम आपके संपर्क में रहेंगे। और उस तरह से आज के डेट में अराउंड जो है 8 से 9 जो है कंट्री से मैं जल्दी गिना देता हूँ। फ्रांस हो गया, चाइना हो गया, पाकिस्तान हो गया, इसके अलावा स्कॉटलैंड हो गया, घाना हो गया और जापान हो गया। तो इस तरह के देश के जो सर्वाइवर्स के साथ जुड़ा हुआ हूँ, डॉक्टर्स के साथ जुड़ा हुआ हूँ, और जो भी कुछ इस तरह के नेशनल इंटरनेशनल इवेंट्स वगैरह होते हैं तो आज भी उसमें शरीक होता हूँ। तो ये रही कुछ जर्नी और बात है 2020 की, जब मैं गांव गया था। अच्छा, मैं मेरे एजुकेशन के बारे में नहीं बताया। तो एजुकेशन के हिसाब से मेरा डबल मास्टर्स है, मैं एमए इन सोशियोलॉजी करा और उसके बाद में MSW करा, तो मास्टर ऑफ सोशल वर्कर की डिग्री भी मेरे पास है। और उसके बाद में मैं इंडियन स्कूल ऑफ डेवलपमेंट मैनेजमेंट से 1 साल का कोर्स करा, डेवलपमेंट लीडरशिप मैनेजमेंट। उसमें ये चीज सिखाया जाता है कि किस तरह एक ऑर्गेनाइजेशन को, एक एनजीओ को लीड करना होता है। क्योंकि बहुत बार ऐसा होता है कि एनजीओ लोग जो खोल देते हैं क्योंकि उन्होंने कुछ दर्द देखा है, कुछ पेन देखा है, या कुछ उनके परिवार में या आसपास में घटना घटी है, तो वो चेंज लाने के लिए खोल दिए। बट एक टाइम आने के बाद में किस तरह से उसको सचमुच लीड करने के लिए किन किन चीजों की रिक्वायरमेंट है वो शायद नहीं हो पाती है, जिसकी वजह से और ऑर्गेनाइजेशन में तोड़ फोड़ होते हैं और लोग छोड़ करके जाते हैं। तो सारी चीजें मैं 1 साल में सीखा। और फिर सीखने के बाद में हमने डिजिट स्वास्थ्य फाउंडेशन की शुरुआत करी। उसके बारे में आज नहीं बताऊंगा, कल बताऊंगा मेरे प्यारे भाइयों बहनों और सारे साथियों। तो यहीं पे शायद हमें रुकना चाहिए क्योंकि हम लोग को आज जाना है 56 दुकान जाना है। सो थैंक यू सो वेरी मच, बहुत बहुत धन्यवाद आप सब लोग।
थैंक यू एवरीवन। लेकिन मैंने बहुत कुछ मिस कर दिया है, आई नो दैट। मैंने बहुत कुछ मिस कर दिया है, आप सबके अनुभव सुनना मैंने मिस कर दिया है और उसके लिए वेरी सॉरी। बहुत प्लान किया था कि सेशन आज का ऐसा करेंगे वैसा करेंगे, सर से 2-3 बार फोन करके बात की, लेकिन जो प्लान करते वो होता कहाँ है ना कई बार। बट कोई बात नहीं, एक बार प्लान ठीक से नहीं हुआ तो भी हम दोबारा प्लान करते हैं, प्लान करना तो नहीं छोड़ते हैं ना। सो कल का सेशन अच्छा करेंगे। यहाँ पर जितने भी लोग हैं हर कोई फिर से पार्टिसिपेट करेगा, मैं फिर से सबको सुनूंगी।
आपके साथ रह के ये लोग सब बहुत होशियार हो गए और अपने आप करते हैं, तो अभी हमें छोड़ देना चाहिए बस।
यस हमें छोड़ देना चाहिए, लिटरली हमें छोड़ देना चाहिए। और मैम ने जो बात कही वो मैं एज अ कॉम्प्लीमेंट लेती हूँ कि यस सब लोग इतने ज्यादा अच्छे से अपने आप को एक्सप्रेस कर पाते हैं और सोच रहे हैं इतना कुछ अपने लाइफ के बारे में, तो ये बहुत बड़ी चीज है। हमारा काम तो सिर्फ आयोजन है, बाकी सब तो आप ही करने वाले हैं। तो कल का सेशन भी वैसे ही होगा, हम तो आयोजन करने के लिए है, सेशन को तो लीड आप ही को करना है, क्योंकि आखिर ये आपके अनुभव है, पूरा सेशन आपका शो होने वाला है। और जैसे आज आप सब लोगों ने अपने एक्सपीरियंसेस के बारे में कहा, तो वैसे कल के सेशन में आप बात करेंगे ज्यादातर आपके फ्रीडम के बारे में। आपके फ्रीडम के बारे में आप क्या सोचते हैं, ये मैं थोड़ा आइडिया दे के रखती हूँ ताकि एवरीवन शुड थिंक अबाउट इट। आप सब लोग सोच के आएंगे और बात करेंगे कि अपना फ्रीडम, अपनी आजादी सबको प्यारी होती है। लाइफ में बदलाव आने के बाद कई सारी एडजस्टमेंट करनी पड़ती है, तो इस आजादी पे असर हो सकता है। अगर होता है तो हम क्या करते हैं, कुछ चीजें नहीं कर पाते तो हम क्या करते हैं, हम कैसे लाइफ को फिर आगे बढ़ाते हैं, या कौन सी दिक्कतें आती है तो उसके लिए क्या करना चाहिए। डॉक्टर्स भी होंगे, क्योंकि कई बार हमें पता नहीं चलता है ना कि हमें क्या करना चाहिए, तो वो हो सकता है वो भी कुछ गाइडेंस हमें करे। तो ये सेशन कल होने वाला है। और फिर से एक बार मैं कहूंगी कि बहुत अच्छा सेशन मैंने मिस कर दिया। और यस सर आपने तो चुरा लिया मेरा डायलॉग, आपने मेरा डायलॉग चुरा लिया। सो यस, पिक्चर अभी बाकी है, इनफैक्ट पिक्चर मूवी यहाँ से शुरू हो रहा है। आपकी लाइफ जो है, जो जर्नी है आपकी, तो ये किसी एक मौके के यहाँ आने के बाद हमें लगता है ना कि बस अभी क्या है, अभी सब खत्म हो गया। बट इनफैक्ट सबके अनुभव सुनने के बाद में आप लोगों को भी एक दूसरे को लगा होगा कि कितना कुछ किया है, उसने कितना किया, इसने कितना किया है, उसने क्या भुगता है, उसने क्या जिया है। इसका मतलब ये है कि मूवी जो है, लाइफ की मूवी जो है, उसका एंड कैसे करना है वो हमारे हाथ में है। उसका डायरेक्टर हम है, उसके राइटर हम है, हम सब कुछ उस मूवी के लिए कर सकते हैं। तो पिक्चर अभी बाकी है और हमें ही करना है उसको कंप्लीट। सो थैंक यू सो मच फॉर दिस वंडरफुल सेशन जो मैंने मिस कर दिया है।
थैंक यू सो मच। और चलते चलते एक मैंने कुछ लिखा था जो मुझे ऐसा लगा कि आप लोगों के लिए, हमारे सबके लिए ही है कि जीवन में जब हादसे, आघात, संकट, दुर्घटनाएं या कैंसर जैसी बीमारियां होती है, तो हम केवल दो तरीके से जी सकते हैं। या तो रोते हुए पीड़ित मानसिकता में जीते रहो, या उसी संकट को अपनी ताकत बना के अपना जुनून बना लो और एक योद्धा की तरह, जैसे कि आप सबके अभी कहानियां जो सुन रहे हैं, सिर्फ पेशेंट्स के ही नहीं, सिर्फ सर्वाइवर्स के नहीं, पर जो डॉक्टर भी एक योद्धा की तरह लड़ रहे हैं, उसको लेके जीवन में आगे बढ़ना है। थैंक यू सो मच।
I think we have to celebrate our birthday. Yes. So first thing is happy birthday.
Happy birthday.
Great birthday. I got to know yesterday. So.
Thank you.
It's okay. Action replay.
Charming, yeah.
Thank you.
Thank you. Thank you so much.
एक्चुअली मैं भी इसकी पैनलिस्ट थी, लेकिन जब मैंने आप लोगों की कहानी सुनी, एक तो सबसे पहले कि मैं ना एडोलसेंट में आती हूँ ना मैं यंग में आती हूँ, बिकॉज ये मेरा 50वां सालगिरह है।
तो इसलिए मैंने सोचा कि मैं अपनी स्टोरी ना सुनाते हुए आप लोगों की सुनूं, और मुझे एक्चुअली ऐसा लगा कि दुनिया में कितना गम है, मेरा गम कितना कम है। और ये बात सच है कि जब आपको पता चलता है कि आपको कैंसर है, एक फियर तो नहीं था मुझे, क्योंकि मेरा सपोर्ट सिस्टम बहुत अच्छा था, नो डाउट। लेकिन फिर भी हाँ, मुझे बहुत सारी चीजें खोने का गम, मुझे ऐसा लगा कि मैं शायद ये चीजें खो जाऊंगी। तो उसमें सबसे ज्यादा मुझे लगा था, एक तो करियर मैंने आप लोगों को बताया, दूसरा मुझे डॉक्टर ने कहा था आपका फर्स्ट स्टेज है। मैंने बहुत जल्दी डायग्नोस कर लिया था एक्चुअली। मेरे 7 मिसकैरेजेस हुए हैं, तो उसका कुछ मुझे इफेक्ट होता था बॉडी में। मेरे को लिम्नॉट मतलब कुछ नॉड्स हो गए थे अपने आर्मपिट में, और वो 15 इयर्स तक थे। उनकी सर्जरी होती थी और उनकी बायोप्सी होती थी, कभी कुछ नहीं निकलता था। तो फिर एक ऐसे 15 साल के बाद वो बंद हुआ। तो उसके बाद मेरे को एक बेटा हुआ, और फिर उसके बाद फिर वो बीमारी मुझे रिपीट हुई। एंड फिर उसका भी सर्जरी भी मैं मतलब ये मेरी पहली सर्जरी नहीं थी जो कैंसर की थी, वो मेरी 10वीं या 11वीं सर्जरी रही होगी। हालांकि वो बहुत बड़ी सर्जरी थी। और जैसे संदीप आपने बताया कि होश आते ही आपने हाथ फील किया कि है कि नहीं है। यकीन मानिए जब मुझे होश आया तो मेरा लेफ्ट हैंड सीधा मेरे राइट ब्रेस्ट पे गया, जबकि मैं आधी होश में थी और आधी बेहोश थी। और मैंने डॉक्टर से पूछा मैम गया क्या? तो बिकॉज सर्जरी से पहले मुझसे बार बार पूछ रहे थे कि वुड यू लाइक टू कीप इट और वुड यू लाइक टू रिमूव इट। एंड मैं क्योंकि ये एक बीमारी ऐसी है, कोई खांसी जुकाम बुखार नहीं है कि जिसके बारे में हमें घर के नुस्खे पता हो या हमें इसके बारे में कहीं से सुनने से मिला हो। तो मेरी फैमिली में भी किसी को नहीं था। तो मेरे को बस ये पता था कि इसका ट्रीटमेंट बहुत दर्दनाक होता है। और जब वो रिमूव हुआ और जब मैं सर्जरी में जा रही थी तो उन्होंने मुझसे कहा कि वुड यू लाइक टू कीप इट। तो क्योंकि बहुत पहला स्टेज है आपका और हम सिर्फ ऐसा कर सकते हैं कि हम सिर्फ उतना पोर्शन निकाल के। और तो मैंने आई गिव my faith and trust to them and I said do whatever is best for me. So एक चीज तो ये होना चाहिए कि please trust doctors and do as they say, because हमें कुछ नहीं पता होता इसके बारे में जब तक हम इसमें आते नहीं हैं। और फिर हम अपने ट्रीटमेंट के दौरान, अपनी जर्नी के दौरान बहुत कुछ सीखते हैं। फिर ब्रेस्ट गया तो उन्होंने बोला था कि अरे आपका फर्स्ट स्टेज है तो ऐसा आपको कुछ कीमो वीमो नहीं होगा। तो मैं भी थोड़ा ठीक है चलो, अब मेरा ट्रीटमेंट खत्म हो गया। मैं स्कूल से सिर्फ 15 दिन की छुट्टी लेके बॉम्बे गई थी और मुझे लग रहा था कि शायद हो जाएगा, मैं वापस आऊंगी ना, आई विल जॉइन माय जॉब। फिर उन्होंने बोला नहीं आपका तो कीमो भी होगा। अब कीमो हुआ तो सबसे पहले टेंशन है कि बाल चले जाएंगे, एंड बाल मुझे बहुत पसंद है अपने। एंड बिलीव मी आफ्टर कीमो मेरे बाल बहुत अच्छे आए, जो मैं अब मैंने जब मैं गंजी हुई, इनफैक्ट आई लॉस्ट एवरी हेयर, वी ऑल हैव लॉस्ट एवरी पॉसिबल हेयर ऑन अ बॉडी ड्यूरिंग कीमो। तो उसको जब मैं बाहर निकलती थी तो मैं हिजाब करने लगी। पहले मैं हिजाब नहीं करती थी, तो मैं हिजाब करने लगी। बट जब मैं क्योर कर गई और जब मैंने देखा मेरे बाल आ रहे हैं और पहले से बहुत अच्छे बाल आ रहे हैं, तो देन आई सेड नहीं, जब मैंने अपनी वो कमी छुपाने के लिए हिजाब लिया तो लेट मी नाउ, एंड गॉड हैज हेल्प मी टू कम ऑल द वे। और उन्होंने मेरे लिए सब बेस्ट इंतजाम किए। यू विल नॉट बिलीव, डॉक्टर प्रफुल्ल देसाई ने मेरी सर्जरी करी और मेरा हॉस्पिटल जो था वो भी बहुत अच्छा था। डॉक्टर अडवाणी ने मेरी कीमो प्लान करी, लेकिन मैं बहुत ज्यादा होमसिक फील करने लगी थी। तो एक कीमो वहां कराने के बाद मैं इंदौर आई तो मुझे समझ नहीं आया कि मैं यहाँ किसको दिखाऊं। Then I contacted my my childhood friend Sapna, who's been working in this, and then she guided me to Dr. Chitalkar, and believe me, I really enjoyed that journey of my chemo because sir ने उसको इतना easy बना दिया था। एक चीज मेरी डॉक्टर से थोड़ी शिकायत थी पहले, वो बहुत डिटेल में बात नहीं करते और डॉक्टर सर बिल्कुल चुप नहीं होते। वो आपको इतना बताते हैं कि आधी बीमारी तो शायद सर से मिलके ही चली जाती है। और कीमो के टाइम में जब मेरी कीमो चल रही थी तो मेरी सर्जरी कोरोना का फर्स्ट लॉकडाउन था और मैं बहुत दूर रहती हूँ यहाँ से, ऑलमोस्ट मैं तो द अदर कॉर्नर ऑफ दिस टाउन, तो वहां से आना मेरे लिए थोड़ा मुश्किल हो रहा था और हर जगह पुलिस बैठी थी, सब थी। तो हम लोगों ने एक पेपर पे लिखा था इलाज के लिए और बिंदु जा रहे हैं, और ये कार पे चिपका दिया था, तो पुलिस हमें रोकती नहीं थी और हम शीशा नीचे करके तो उनको लगता था शायद कोरोना का इलाज कराने तो नहीं जा रहे, तो नो वन स्टॉप्ड अस और बहुत आराम से यहाँ भी आते थे। तो रूम्स में मेरे ख्याल से 2-4 ही पेशेंट हम लोगों को मिलते थे। सो मेरी जर्नी एज कम्पेयर टू यू ऑल बहुत 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 थोड़ी है, बट हाँ तकलीफ होती है इसमें, लेकिन इफ यू हैव अ फैमिली सपोर्ट, इफ यू हैव योर फ्रेंड्स सपोर्ट। मुझे याद है जब मैं पहली बार गंजी हुई तो मेरी फ्रेंड्स कोरोना में किसी तरह मैनेज करके चुपके चुपके 2-3 फ्रेंड्स मेरे घर आए थे एंड वी हैड डांस ऑन बाला सॉन्ग, ओ बाला ओ बाला। अनफॉर्चुनेटली आई लॉस्ट दैट वीडियो। और मुझे मुझे देख के मेरे हस्बैंड को थोड़ी तकलीफ होती थी, बिकॉज मुझे ऐसा लगता है कि जब हम मरीज होते हैं ना तो हमें तो सारे आराम और सारे वो हमें देते हैं, हम वो जर्नी होता है ठीक है, वो ट्रीटमेंट है वो सब हमको, लेकिन उस सबको हमारे लिए अरेंज करना, और आई थिंक उनके लिए ज्यादा तकलीफ देह होता है, हमारे घर वालों के लिए और हमारे भाई बहनों के लिए। सो उनको देख के मुझे बहुत तकलीफ होती थी, अदरवाइज मुझे अपने लिए कभी कुछ नहीं लगा। गॉड हैज मेड मी लाइक दैट। थोड़ी सी स्ट्रांग हूँ मैं, शायद मेरे सर्कमस्टांसेस लाइफ में ऐसे रही हूँ, और फौजी की बेटी हूँ, तो तो दैट्स ऑल माय जर्नी। अब मैं वापस आई एम अल्हम्दुलिल्लाह परफेक्टली ऑल राइट। और एक चीज और अच्छी हुई थी मेरे साथ, जब कोरोना में मुझे सॉरी कि जब कैंसर में मुझे ये लगा कि मैं मिडिल सेशन अपने बच्चों को छोड़ के जा रही हूँ और क्या होगा मेरे बच्चों का, और मेरी जॉब तो नहीं चली जाएगी। तो उस वक्त लॉकडाउन लग गया, सारे घर पे बैठ गए, तो मैं घर पे थी तो सारे घर पे थे। और ऑनलाइन क्लासेस जब शुरू हुई तो बहुत कुछ सीखा ड्यूरिंग ऑनलाइन क्लासेस लेना सीखा, कंप्यूटर हैंडल करना सीखा। सो आई रियली एंजॉयड माय कैंसर जर्नी, बिकॉज सब कुछ बंद था और मैं घर में थी, मैं आराम कर रही थी, तो सारी दुनिया आराम कर रही थी। So that's all. Thank you so much.
Now I understood what you can do. Yeah? Now you can make a plan. Back to this. Yeah, I think you know you take her to last time.